Hello. Hello.
Yes, sir. Okay.
Tech team, can you make Dr. Uday Pawar co-host also, please?
Uday, can you hear me?
Yes, sir.
Good morning, sir.
Good morning.
Good morning, sir.
Just finished the Delhi
Yeah, I know.
seminar and came down.
I know. This whole week we have been jumping.
I
from
know,
here
I
to
know.
there.
And next weekend is going to be busy.
Yeah, yes, sir.
Luckily, after that, there's a Christmas and New Year.
Yeah.
So many meetings which could have been scheduled there, gone. And because of that now, first week and second week are tightly packed again.
Yeah, yes, sir. Yes, sir.
सुधीर गाना सॉन्ग कैसे लगा अपना BSS का?
बहुत अच्छा सर, बहुत ही अच्छा. Very good.
If you hear it on a good audio system or good speakers, you'll really enjoy it.
Yeah, I heard it, sir. In fact, you had messaged me that you hear on very good voice.
No, no, this is the final mastered and mixed version.
Yeah.
After the vocal recording, I had to do a lot of work on that.
Yeah.
Then at the end of that, I am very satisfied with what we have achieved.
Yes, excellent, sir. Excellent composition and everything is very good. The tune,
it basically shows the spirit of BSS.
Yes, sir. Yes.
Brings out BSS. Yeah.
So can we start the virtual video? We can play it twice, if it's okay.
Yeah. Yeah, I think it is okay.
Okay, okay. Tech team, start the virtual video, please.
Hi friends, I'm Ram Chadda. I welcome you for the Bombay Spine Society Annual Conference, BSSCON, 19th and 20th of December 2020. We are having 4 fantastic pre-conference workshops a week earlier on the 13th of December. I want each one of you to take your time out and join us for this one-of-a-kind mega virtual event. We are sure you'll have so much to contribute. The interaction, the international faculty, excellent Indian faculty, workshops which are going to help you evolve with your day-to-day practice, and finally, the culmination in a state-of-the-art Congress. A meeting where every unanswered query, question of yours will have a solution. Please join us. Bombay Spine Society welcomes you. We look forward to having you in large numbers being a part of BSSCON, Bombay Spine Society Annual Conference this year, 13th, 19th and 20th of December.
Please do join us on 13th December for a very informative and well-planned spine workshop, followed by a very well-structured main conference on 19th and 20th December, where you will be able to interact with galaxy of distinguished spine surgeons. Do join us. BSS will be eagerly waiting for all of you.
Welcome to BSSCON 2020, the first annual meeting of the Bombay Spine Society. The program on 19th and 20th will be highly interactive. We have an excellent academic program with eminent faculty from both India and across the globe sharing their knowledge and experiences with us. We look forward to interacting and welcoming you on December 19th and 20th. Do register for BSSCON 2020.
BSSCON brings to your homes the who's who in spine surgery from across the world at a mere $1,000. Not only that, you get to attend the pre-conference workshop on the 13th with the meeting on the 19th and 20th of December, which is going to be a star-studded, absolutely top of the heap weekend for you. So be there or be square. See you soon.
We are proud to announce that we are organizing our first annual conference. This is history in making. So this will be held on 19th and 20th of December 2020 under the leadership of one and only Dr. Vishal Kundani, under the stewardship of Dr. Srivastav. I welcome you all to please attend the conference. So please register as soon as possible and enjoy the recipes of the conference. Thank you.
Please join this conference and enjoy the academic feast put to you, not just from Bombay, but also from our national as well as international faculty. See you there.
Welcome to BSSCON 2020. Let the festivity begin.
We are starting at 9:30 over there.
9:15. We're starting at 9:30. Just a 15 minutes overview about the platform that we're going to have. So I request the technical team from VAMA to take us through the platform that we're going to have for the conference.
Okay, one sec, sir. I'll start. Shall I?
Yes, please.
Your voice is slightly low.
Okay. Is it audible now?
Yeah, better now.
Okay, all right. So good morning, everybody. And we are very glad to have you for BSSCON 2020 virtual conference. The first ever virtual conference we are doing for the Bombay Spine Society. I'll take you through very quickly to the platform, how to navigate, how to reach out to the session halls, how to go to the exhibition area, how to interact with the booth staff, and how to go about information desk if you have any issue while logging in or while navigating to the platform. So this is the login page. As soon as you click the link which we have shared with you, you will land on this page. You just have to put your email ID. That's it. No password required. And submit. So this is the lobby you will enter as soon as you put in your password. So here we are seeing these small buttons. These are the quick navigation buttons. If you wish to go to scientific hall, you can click here. If you wish to go to exhibition hall, you can click here. If you want to see the agenda for the day, you can actually click here and find the agenda. And e-poster, it will not this e-poster will be accessible for 19th and 20th. Today it's not there. So apart from this, all the buttons are actually working. For any assistance, when you are on the platform, you can go to the information desk and our backend team is there. They can help you out. You can actually check the agenda from agenda tab over here as well. I'll take you to the exhibition hall first, and then we will go to the scientific hall. So this is the exhibition hall. Probably the exhibition will start today. Some of the exhibitors are already there. Some of the exhibitors will be joining us soon. So these are the exhibition booth. The first scroll is our premium sponsors, followed by gold, silver, and bronze. Very quickly, I'll take you to one of the booth to check how you can interact with the booth staff. So let's go to any of the booth and we will see how to interact with them. So these are the buttons which you have to click and you have to get in touch with them. So in this product video, you can actually see the products and videos, product and services videos which they have uploaded. You can actually have a look and see them. In documents info, you can find their company profile, product profile, brochure, catalog, anything which you can actually see and interact with them later regarding that. If you wish to speak to any booth staff, you can actually chat with them over here, and you can do a audio call, video call, and WhatsApp call with them. If you want to book an appointment, if you are busy in a session and if you want to catch up with them later, you can book an appointment with them. You just have to click this schedule. Right now, as the conference is going to start from 10 onwards, so we have this 10 a.m. schedule. Later on, all the schedules will be here. You can actually click the schedule of your choice and you can request the exhibitors if they can book your appointment at your scheduled time. You can chat with them later. And if you want to just go directly to the sales information, so they will be having their sales information, sales staff information over here. You can download their business card and you can interact with them at your piece. So this is the exhibition. Now I'll take you to the scientific hall. Let's go to the lobby again. And these are the e-posters. So this hall will be live from 19th. And scientific hall, we are just going to go to the scientific hall and check what is going on. As soon as you are in scientific hall, you will see the agenda of the day. So as we haven't started it yet, so all the topics and workshop schedules are upcoming. We are live. So if you click this button, you will actually see what is going on right now on the platform. So I'm just clicking in and I'll take it off because then my voice will echo. So this is what's happening on the platform right now. As I'm giving you the navigation, this is also happening over there. Just make sure, there will be a lag of 15-20 seconds, not more than that, while I'm giving my lecture live and what you are going to see. And you can actually, while going through the workshop, if you have any question, you can ask a question. You can see this tab. You can click here, put your question, submit, and faculty can see your question and they can answer. And if later on, if we have any poll, so faculty will put up a question on the screen and the question will come over here and you can actually select the choice options of your choice and the final result will be shown like here. This is a dummy poll. So this is how the final result will be shown. So you can watch the session on the small screen as well, and you can actually enlarge the screen, full screen, and you can watch the screen like this also. So let's go back to the lobby. So this is the platform and it's very simple. If in case you have any technical glitch while logging in, we have given our technical team's number on the email which has been shared to you, or when you are on the platform and if you have any problem, any issue visiting any exhibition hall or you're not understanding anything, you can simply come to the information desk over here and chat with our booth staff. It's a live chat. Your query would be sorted immediately. So this is it. Let's have a great conference today and hope to serve you. If anything, please reach out to us. Thank you so much.
Thank you, Mama team.
Thank you, sir.
So the faculty, they have to register through the link that we have sent, and that's the only link that you need to click. For the delegates, there is a separate platform, and the delegates can ask the questions as just need to describe by asking the chat. So this is to minimize the crosstalk, but for the faculty, there is only one link which has been sent to all of you, and everything will be done through that link. Was it clear for everybody?
May I ask a question to the technical team, please?
Yes, sir.
When we go from the scientific hall to the exhibition hall, or from the exhibition hall to the scientific hall, does the back button take us back to the open screen where we have all the options?
Yes,
or
sir.
is there a direct way to go as well?
Yeah, so there is a direct way also. So when you are in a session hall, you can actually see the navigation button down. You can go to the exhibition hall either by clicking that navigation button, or you can go back to the lobby and click the exhibition area. It's just 2 clicks.
Thank you, ma'am.
You're welcome.
So we are live now. Good morning, guys. Bombay Spine Society welcomes you all, and I, on behalf of the organizing team, along with the president of Bombay Spine Society, Dr. Srivastav sir, our past presidents, Dr. Ram Chadda, Dr. Goregaonkar sir, and the patron of all the spine surgeons across the country, Dr. V.T. Ingalalikar sir, along with my colleague and the support of Dr. Uday Pawar and the technical team here from VAMA team. And of course, Neeraj Bijlani and Ashok Sham, who are going to also relay this for people who have not been able to register via OrthoTV, through YouTube, Facebook. We are all logged in. We are all live there. And the faces are here. Abhay is there already, though he's out, but he's cheering you up. And I look forward to welcoming you all. Bombay Spine Society has curated an amazing scientific program for you. And we look forward that today is going to be the day that we'll be creating a history by making virtual standards of conducting a conference and having an interactive platform to teach and to share our bit of knowledge with you all. Over to you, Uday, for the start of BSSCON. Welcome all.
So thank you, Vishal. Greetings to one and all watching this live conference of the Bombay Spine Society. It gives me immense pleasure, warmth to welcome you all on behalf of the entire Bombay Spine Society and its organizing committee. We are a small but closely knit family who takes immense pride in our conduct of the academic discussions, the teaching programs, and I'm sure as some of you might have experienced in the past. We have in the last year formalized our association, and this year we have a virtual meeting for all of you as our first annual conference due to the circumstances that we are in. But behind this first meeting are all the stalwarts and the young Turks of the Bombay Spine Society, whom you might have heard at all the national and international conferences. And we are immensely proud of each one of them. Each topic for discussion and debate for the conference was chosen, keeping in mind the interest of all the participants, right from the rank novice to the established spine professor or a spine consultant. There is something for each one of them. Today, we kickstart the pre-conference workshop the whole day. And there are going to be 4 pre-conference workshops on basic spine, cervical spine module, a minimally invasive spine surgery module, and an osteoporotic fracture management module. So heartfelt gratitude to all present here and taking a keen part in this vital program. I welcome you all and an osteoporotic fracture management Bombay Spine Society module. We are very happy that all of you are here with us, and let's make this program a success. I transfer this thing to my co-host, Dr. Vishal Kunanani, to give a program overview for today. Yes, Vishal.
Thank you, Uday. Thank you so much for passing on the welcome address on behalf of Bombay Spine Society. I take this opportunity to run you through the program. We have already created a video to run you through the interactive auditorium, which is the virtual auditorium where you can not only enter into the auditorium, have a one-on-one chat. There are Q&A panels also, so you can put through the questions that you have come across in your mind while going through the conference. There is also exhibition hall. I would request all the delegates to please at least once visit all the exhibitors and sponsors. They are all eagerly waiting to serve you and meet you and one-on-one live chat with you. But the highlight of the program is the scientific content. And the scientific content has been curated over 3 days. The buffet is spread in such a manner that it has something for everyone. We are going to start this program today with live workshops. Now, the first question comes, how is the workshop going to happen when it is virtual? How is it going to give a virtual and yet physical? The workshop is going to be conducted, though virtually, but on sawbones. Our speakers have curated it in such a way. The faculty of Bombay Spine Society has programmed the workshop in a manner where you're going to be actually seeing not only the surgical anatomy on sawbones, there are videos of the surgical techniques, there are talks dealing with the problems and salvage options, and the basics and the principles of basic spine surgery workshop, including basic spine. There is a step up in cervical spine instrumentation techniques. All these things are in the pre-noon session from 10 to 12 is the basic spine surgery workshop, which is going to happen today in a couple of minutes from now. From 12 to 12:30, there's going to be a short break to give you a breather in, and we'll be sharing in PDF articles to all our registered delegates. So wait for us. We'll be sending you through your emails the PDF articles on the techniques that are being discussed today. After 12:30, again, the cervical spine instrumentation will be the next workshop from 12:30 to 2:30. Again, at 2:30, we have a small breather. Mind you, these workshops have been curated in a manner to feed in the most basic and the most advanced part of instrumentation techniques, both in basic spine and cervical spine. To savor your taste buds, minimal invasive spine surgery workshop happens after a 30-minute breather from 3 o'clock onwards, where our moderators are going to run you through the basics, the armamentarium, the principles of MIS workshop, and of course the surgical videos and discussions. Enough time has been kept in each workshop to make it more interactive, and there is a panel panel button on the auditorium chat where you can just click the button, ask a question, and your question will be taken forward by the moderators. So minded, it is genuinely an interactive platform. It is not didactic where one-sided knowledge flow is happening, and you can ask the question at any point in time, and your questions will be recorded with us and they will be taken by the moderators, and these questions will then be answered one-on-one, even if it takes a little longer time to answer every bit of question. In case your question doesn't reach us to us, your questions can be mailed to us, and all the Bombay Spine Society members are in your inbox. Numbers are there with you. You can send it to us directly also. However, try to interact on the platform with push the button of ask a question, and your question will directly be registered and asked and answered by the panelist on the platform. The day will not be over at 5:30 yet, because the most awaited session and the most intriguing session on osteoporotic soft bones, there is a hard talk on the osteoporotic treatment protocols and A to Z of osteoporotic fractures, osteoporotic spine, medical management, diagnosis of pathological fractures, surgical management challenges and salvages. The session will start only at 5 p.m. post, that is 5:30 to 7:30 p.m. And that last part of the day will savor you through the most difficult and intriguing times of osteoporotic spine and other issues in medical management of osteoporosis. While we end the day at 7:30 p.m., we will not be leaving you behind. We will be leaving you behind with a week to read all the articles that will be shared with you, only to join you back again on the 19th of December and 20th of December, which is the day of main conference. 19th December, we start sharp at 3 p.m. again with an inaugural address on that day, followed by free paper sessions. Just to keep you informed, Bombay Spine Society Conference, the first annual meeting, received an overwhelming response of free papers, and we received 168 abstracts in the free paper session. Unfortunately, we were able to only provide space to 60 of them, which were the best of the best, and these 60 papers have been categorized into free papers. There is so much more time. There are 4 sessions on free papers which will be at relay, and the research of country is going to be portrayed in a big manner on 19th and 20th in 3 free paper sessions distributed evenly across the main platform. To keep it uniform, there is no hall B happening. There is nothing simultaneously. There is nothing spontaneous happening on the other hall, and everything is happening on the main platform so that everyone can catch everything that is happening on this conference, and nothing has been missed out just because you are in one or the other platform there. followed by free papers. A star galaxy of stars from across the globe are joining us on 19th December to deal with topics like spinal trauma, spinal deformity, cervical spine problems, and of course the minimal invasive spine surgery. And these are presidential invited guest lectures on the 19th evening from 4:30 p.m. onwards till late in the night at 8:30 p.m. Those 4 hours with Star Galaxy faculty from US, from Japan, from Australia, from Malaysia, and various other parts of the globe are going to be there, while Bombay Spine Society faculty is going to be there to share their knowledge and the national experiences on spinal trauma, minimal invasive spine surgery, and spine deformity. And that is the star attraction in presidential guest lectures on the 19th of December. We look forward to see you on the 19th as well. 20th morning, we start sharp at 9 a.m. and the topics which generally are not spoken much have been covered in detail, including high-grade spondylolisthesis, cervical myelopathy, multi-level compressive myelopathies. The problems of dealing with them are going to be tackled in great detail. We have best publications from across the country. We received 20 papers, out of which 5. It was really a tough call for the judges to choose the best 5 publications out of the 20 best publications in spine surgery. And those 5 will be presented on the podium. Those 5 best publications from across the country are going to be awarded. We have 10 best papers out of the 168 abstracts selected as Bombay Spine Society Best Paper Award, again on the 20th. We have 2 free paper sessions on the 20th also. And then following that, we have the best video sessions. We received 20 video techniques, innovative video techniques in spine surgery from across the country, and we were able to shortlist only 3 of them. We have also got 60 e-posters which will be relayed in a separate hall. They will be on constant run on the 19th and 20th. The e-poster hall will be running. And the noon session will be for minimal invasive spine surgery and also various other techniques. High-grade spondylolisthesis, multi-level cervical myelopathy, spinal deformity, rigid curves, and also minimal invasive spine surgery are not the only things that we are going to discuss. We are also going to discuss about how to make the spine surgery safe, which is the most coveted topic today, and to enhance the knowledge on safety in spine surgery. The last session on the 20th December will start at 7 o'clock following, and there is a break. So don't think that we are going to exhaust you. This learning is very interactive on one hand, and yet it gives you breather after every session. It is all spread across the day with enough amount of break to keep you virtually glued and yet breathe upon the knowledge that is being shared by Bombay Spine Society. We are also looking forward to see you on the platform, and hold us and ask us any question that you wish to. We will be more than happy to walk with you and run with you in this gala knowledge sharing platform of Bombay Spine Society Conference. Again, I take this opportunity to welcome you all to Bombay Spine Society Conference and look forward to share what we know lesser than other. Thank you so much. Over to you, Dr. Uday.
So thank you, Dr. Vishal. I now request our President, Dr. Professor Sudhir Srivastava, sir, to give a welcome address to the delegates. Over to you, sir.
Thank you, Dr. Uday. Hi, friends. A very good morning to all of you. On behalf of Bombay Spine Society, I welcome all the delegates, BSS members, and our patrons who have shaped this society to its present zenith. It is my proud privilege to address this august virtual gathering. Today, it is the first academic event of Bombay Spine Society annual scientific proceeding in the form of workshop. It is a pre-conference workshop. Countdown has already started for the main conference, which is going to be held on 19th and 20th of December. We have different modules of this workshop back to back, from basic spine workshop to the most advanced one. All the dynamic conveners along with the organizing secretary have crafted it very well. I am more than sure that all the delegates will be immensely benefited out of this. Our respected and beloved Dr. VTI sir has written and composed Bombay Spine Society anthem. I'm proud to declare that this is going to be played today, first time in the BSS history. I feel honored to request VTI sir to please inaugurate this Bombay Spine Society anthem. Thank you very much.
Well, thank you, Sudhir. Thank you, Uday. Thank you, Vishal. I first thank you for holding this meeting. You all people have taken the Bombay Spine Society to such great heights that today the whole world is looking at us with respect. And I'm sure after this conference, it will be even multiplied many times. So the plethora of speakers, the huge number of topics, the number of papers coming on right in the first major event of BSS itself speaks what people think about BSS. Most of the first conferences generally are half-day, quarter-day meetings, but here we are huge whole-day, 4 workshops, and next week we have again large number of academic events. Well, I hereby declare. I didn't understand that. I hereby declare this conference to be inaugurated, and I'm very happy to be here about that. Thank you very much.
So thank you, Dr. Ingalalikar. We are going to play the BSS anthem, which Dr. Ingalalikar has written, sung with his colleagues. The lyrics of the anthem are going to be playing across your screen. Please join us, all the BSS members. Please join us.
We are the final scientists and spinal surgeon specialists. Folks with heart full of empathy, who practice patient care with integrity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society.
We are academic ambassadors of India. We are academic ambassadors of India. We are
technology modern, embracing we are. Technology modern, embracing we are. Modern by academic community. Will be futuristic till eternity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. Motivated members and vibrant leaders, visionary pioneers and world-class teachers. Motivated members and vibrant leaders, pathfinders, we find no hurdles. Pathfinders, we find no hurdles. We love the mark, we have no enmity. We are a strong bond fraternity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the final a surgeon specialist. Force with heart full of empathy, who practice patient care with integrity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine.
So thank you so much, Dr. Ingalalekar. Thank you so much. That was great. I'm sure the delegates will experience each and every word written in that anthem as they go through these 3 days of the conference.
We'll be sending this PPT to each one of them. Please try to listen to it on a large speakers. You will really enjoy it. Thank you.
Thank you, sir. Now, taking this forward, may I respectfully request our past presidents, Dr. Ram Chadda, followed by Dr. Arvind Goregaonkar, to please guide us few words and the delegates as well. Dr. Ram Chadda, please.
Thank you very much, Uday. At the outset, with due respects to our patron, chief patron, father figure, Professor V.T. Ingalalekar, my esteemed senior colleagues, President of the BSS, Dr. S.K. Srivastav, somebody we have immense respect for, immediate past President, Dr. Arvind Goregaonkar, the man who held my hand and helped me achieve what I am today. My two very dear friends, Vishal Kunnani, Uday Pawar. These guys have proven that we should follow the 10x rule of Grant Cardone. Think big, achieve bigger. Promise and deliver more than you can promise. Guys, you have proven beyond doubt that you are a level beyond what any of the past has achieved till date. And I speak not just on my behalf, I speak on behalf of so many of us who have sowed the seeds and cultivated this particular harvest, which you guys are now
you have
reaping.
proven.
I am really, really proud that a dream we shared became your desire. Then you designed an event of this magnitude. You stuck to the discipline that needs to be followed when you follow the 10x rule. And finally, you have dared to do what none have and are delivering much more than we expected. It is indeed huge privilege that we have a 4-figure attendance today. No event online of a single society, of a spine association, anywhere in the country or probably worldwide would have a virtual event going past the 999 mark. It gives us so much of pride. Whether it is Gautam, who did hard work in the past, Samir, who did hard work, Abhay, who did very hard work, Arvind, who was always there with us, the younger Arvind, who's now into the minimally invasive group, and so many of you, led by Dr. Ingalalekar, Dr. Bhojraj, Dr. Lahiri, people whom we've respected and who are our role models. You've done something which we are so proud of. Go ahead, keep pushing and deliver much more than we have ever dreamt. God bless you. So proud of you. Over to you, Arvind.
Thank you so much, Dr. Ram Chadda, for being the guiding light as always. I now request Dr. Goregaonkar to share a few words of his experience. Dr. Goregaonkar.
Good morning to everybody.
Good morning, sir.
Welcome to Bombay Spine Society first conference. This was in our mind last 2 years. We are trying to do it. Unfortunately, we cannot reach to the point where we can have a big conference. But Corona-19 has taught us what else we can do. lot of advantages of this virtual conference. At the same time, there's a lot of disadvantages also. Whatever said, this conference has been organized very well. I must congratulate Dr. Srivastav and Dr. Kundanani for excellent arrangement. They have taken lots of efforts. They have put in lot of effort, and all the Bombay Spine Society members, they are contributing a lot. So I'm sure you will learn a lot of things. Stick to the screen always. Don't go away, because every line, every word will be important for you. And whatever your questions, personal questions, or whatever you want to know further, you can get it from your speaker. So thank you very much. Once again, welcome to all of you, and have a good time for the conference. Thank you.
Thank you, sirs. May I kindly request our scientific advisor for the conference, Dr. Gautam Zaveri, our beloved Dr. Gautam Zaveri, to speak few words before we kickstart the proceedings. Sir.
Thank you very much, Uday, for giving me a chance to address the delegates. Well, to Dr. Srivastav, our president, Dr. Ingalalikar, our patron and our teacher, to Dr. Ram Chadda, Dr. Arvind Goregaonkar, both of whom were lecturers and my teachers when I was a student resident in Sion Hospital, and to all the young colleagues who have gathered from the Bombay Spine Society. I think for us as members of the Bombay Spine Society, this is a momentous occasion. It's a dream fulfilled, where we have been able to organize this first annual conference. It's been there in the waiting, as Dr. Goregaonkar said, for some time. But finally, thanks to the efforts of Dr. Uday Pawar and Dr. Vishal Kundnani, this conference has come to fruition. Over the years, the Bombay Orthopaedic Society, or Bombay Spine Society for that matter, has been looked up to within India, and now even in the surrounding countries such as Pakistan, Nepal, Bangladesh, Afghanistan, Sri Lanka, as a leader in academics and a leader in the treatment of spinal problems. Over the next, today and over the next 2 days, which is over the next weekend, I'm sure you will see why. The program that we have designed is incredibly comprehensive. It covers the newest treatments as well as all the basic aspects of spinal problems. I'm sure that every delegate, whether he be a resident in orthopedics, whether he is a fellow, postgraduate fellow, or whether he is a consultant spine surgeon, will gain a lot from this conference. So I'm sure all of you will enjoy this meeting. Please make the maximum of whatever we have designed and the portfolio we have put forth for you. With that, I would like to hand the mic back to Uday Pawar and wish the organizers the best of luck for this great meeting.
Thank you, sirs. Thank you, actually, all the seniors of the Bombay Spine Society for being there with us every time and bailing us out of any eventuality. Now, sticking to the traditions of Bombay Spine Society, along with great academics, we are a great team of people who stick to our time. So rather, we are ahead of time right now, and I welcome you all again for this fabulous virtual online platform meeting of the Bombay Spine Society. And now we shift gears to the actual match of the day, which is the 4 workshops that we are going to have, and we are kickstarting it from the basic spine surgical techniques. And I invite my friend Dr. Satyen Mehta to take over as the moderator of the next 2 hours, and we kickstart the proceedings from here on. Over to you, Satyen.
Good morning, everyone. Welcome to the basic spine techniques workshop. I also would like to invite our panelists, Dr. Gautam Zaveri, Dr. Ingal Halikar, Dr. S.K. Srivastav, Dr. Manish Puthari, and Dr. Dheeraj as well as Abhilash, Dr. Abhilash, to the session. I'll just share my screen. So, and Dr. Zaveri, so can you unmute yourself? I'd like to ask you about this patient. This patient is a 45-year-old male and has come with back pain and bilateral S1 radiculopathy since the last 6 months. Obviously, it's been 6 months and the patient continues to have pain, and now surgical treatment is being thought of. So, what on your initial thoughts, sir? What are you thinking about here as you see this MRI?
So, as I see this MRI, I'm thinking that this is a patient with who has had bilateral radicular leg pain. It's a large posterocentral to slightly right-sided disc, and he has not had any relief with conservative treatment. So if this patient is willing, at this point in time, I would like to offer the option of a surgical decompression in the form of a discectomy.
Discectomy, there are various ways of doing a discectomy here. So what are you thinking of?
So when you think of discectomies, discectomy can be classified depending upon the type, amount of bone you remove, which can be a laminectomy discectomy, a hemilaminectomy discectomy, it could be a fenestration discectomy, or it could be a posterolateral endoscopic discectomy where you do not enter the canal directly. And then based upon the visual aid you use, it could be a traditional open discectomy. If you use a microscope, it could be a microdiscectomy. Or you could use a microendoscope, which then is a microendoscopic, or a completely total endoscopic discectomy. In this case, I would be thinking of a fenestration discectomy. This prolapse is at L5S1, where the interlaminar space is usually wide open. Though the disc here is collapsed to a certain extent, so there will be a certain amount of overlap of the lamina on the disc space, but I think we should still be able to manage with very little bone removal to a fenestration discectomy. And in order to perform the fenestration discectomy, I would use a microscope as a visual aid. The only question is, will I be able to get the entire disc out through a single right-sided microdiscectomy? And since the patient has bilateral symptoms, is there any reason for me to go bilaterally and decompress the nerve roots? So the answer to that is no, I don't think so. I think a right-sided microdiscectomy would be all that I would require. If I can get adequate amount of disc removal, patient will get relief of his bilateral leg pain.
Great. Thank you, sir. I'll ask Dr. Ingalalikar the same thing. Sir, Dr. Zaveri said that because it is L5S1, we have much more space available here. So he should be able to get away with a fenestration. My first question to you, sir, is that would you think of doing something differently if this was a 4-5 or a 3-4 disc?
No, I don't think I would have thought about it. I would do exactly same approach like Gautam has said, but I would like to point out to one anatomical fact. If you look at the disc in a straight line, draw the line posteriorly straight, it is lying underneath the lower half of the lamina, not so much in front of the interlaminar space. This is something people must keep in mind, that when you are doing a work in the disc or when you want to do discectomy, when you do the fenestration, you will have to remove lower half of the upper lamina, and you don't need to touch the lower lamina at all. But if you remove that and try to go obliquely, probably you are not going to have a satisfactory clearance. For a satisfactory clearance, the bulge should be seen nearly from the top of the bulge, the center of the bulge, and the inferior part. They must be clearly seen. So the hemilaminectomy should be, and like Gautam said, because it's a spacious canal and it's a 6 months duration, we should be able to dissect out everything clearly well. If this patient had repeated radiculopathy on the opposite side with intense pain, inflammation, not only paresthesia, that would indicate that the opposite side root also was inflamed. And in that case, chances of adhesions in the other side may be there. With that history, I would prefer to do bilateral fenestration and release the root. That's the only additional thing I would do. And even for upper levels, my general thinking would be about same.
Great. So Dr. S.K. Srivastav.
Spine, what happens is the lamina tends to overlap the disc space far more. And therefore, the amount of bone resection required from the upper lamina as you go higher up in the lumbar spine is more. At L5-S1, it is far lesser. But again, it depends also on the disc space reduction. Here, the disc space is reduced. So as Dr. Ingalalikar pointed out, there is a little bit of laminar overlap, which you may have to remove.
Right. I would have thought that at an L3-4, you would have to probably do a proper laminectomy or at least much more bone removal than at L5-S1. Is Dr. Srivastav here? Sir, if you can unmute yourself. When I saw this MRI, I actually was a little bit worried because it looked like a hard disc and maybe that there would be more adhesions and maybe a microdiscectomy would not be the right way to go. But Dr. Zaveri and Dr. Ingalalikar are very confident that they can just take it out from the right side with a microfenestration approach. Do you have anything that you're worried about, sir, or are you fully confident?
No, actually, this can be taken out from one side approach, because usually when we approach to this area, we don't make a very big rent there and take out everything. With your probe, you can pull it out. Though I fully agree with you, this is a chronic disc, it appears. You see the signal changes in the vertebral body, the decrease in the height, the black disc. So all this tells you that this is a chronic disc which has now become, he has presented, with the 6-month duration history. Now, but all these things, if you even see the axial cut, it is more on one side, right side, but it is majorly a central part, which is slightly more on the right side. So if you make an opening here, you can pull out this disc very nicely. So once you made the space to work, you have to just pull out this disc and you'll find that everything is loose. So they have pointed out that one side this can be done and it can be nicely actually taken out. There is.
I would like to modify Dr. Srivastav's word slightly. This is a chronic disc, it's a degenerative disc, and it also has aortic changes. So it may not be one single fragment. It could be it still could be fragmented disc, even the bulge, and therefore deliver it completely. The general tendency is to, the moment you make an incision in the annulus, you grab it and pull it. So when you do that, you would probably leave behind many small pieces which are unconnected but forming a bulge. So go around it inside the capsule of that and deliver it in totality and then pull on it. But most people generally, as soon as they see it, they start pulling on it and leave behind the fragments. So just be careful about that.
Yes, Dr. Zaveri.
Satyan, I would like to make one point, which is for the junior delegates who are watching this meeting, and that is that there is no harm in removing a little bit more bone. So if you are not surgically equipped to do a fenestration discectomy, don't be embarrassed to do a hemilaminectomy and achieve the same. The most important thing is that you should not be retracting the neural structures too much. So if you are not able to achieve this through a fenestration discectomy, do a hemilaminectomy. There is no harm. But make sure that during the surgery, retraction to the dural structures and the neural structures is kept to the minimum. That is far more dangerous than removing a little bit more bone.
Great, that's an excellent point, sir.
Take the same point further. If the purpose of your surgery is neural decompression, then the neural decompression has to be unquestionably complete and satisfactory. You can't do shortcut. वो बाकी वो shrink हो जाएगा, वो हो जाएगा. It doesn't happen. It has to be absolutely complete.
Great.
And towards that, if you need hemianoplasty, go ahead. Don't hesitate to do that.
So I'll just summarize that number one is that alpha S1, normally we just need a small fenestration and we are able to do a discectomy. However, the patient safety is most important. We need to avoid too much of neural retraction. And if you need to remove extra bone, it's fine. But the patient needs to be safe. You need to avoid any complications. If you may be able to get this out as one piece, but I mean, don't be heroic and just go slowly. Make sure that the neural decompression is perfect and adequately done, which is your main aim. So before we just go ahead from this case to the actual crux, which is a micro lumbar discectomy techniques. So if we were to do a micro lumbar discectomy, what is the? I'll just disconnect.
So Satyen, while you are disconnecting and showing us the video, there are two more points in that I would like to add. That as you go higher up in the spine, the facet joint L5S1, L4-5, L3-4, and then L2-3, the facet joint has to be resected a little bit, the medial part of the facet joint, so that you can go lateral to the nerve root and approach the disc space. So the more higher up you are, the more of the medial facet you have to excise, and in order to prevent retraction of the neural structures. And the second thing, as Dr. Ingalalikar pointed out, the goal of the surgery is unquestionably a complete decompression and not purely a discectomy. As you grow, when the disc prolapse is there in the slightly elderly individuals, people who are above 40, they also have a facet joint hypertrophy and little bit of lateral canal stenosis. So just doing a discectomy may not be enough, and in these patients, a little bit of lateral recess decompression to decompress the nerve root adequately is extremely vital.
Great, thank you, sir.
Can I add one small point?
Yes, sir. Small point.
There are bile duct dilators which are used by general surgeons, abdominal surgeons. They are malleable stems and a bullet-like tip, and they come from 3 millimeter, 4 millimeter, 5 millimeter. So if you, from this approach, if you want to see the root underneath, you may not be able to go and see it clearly. You can use this starting with 3 millimeters dilators. You're not dilating anything. You're only gauging the looseness of the root within the canal by this. And if you feel that it is tight, then you may have to remove a little more facet, like Gautam said. Be careful not to damage the superficial capsule of that facet joint. Don't strip that capsule. Keep it as much intact as you can, except the medial part which you're resecting.
So the first step in doing your microlumbar discectomy is to get a proper positioning in these patients. And for that, I'd like to invite Dr. Manish Kothari. If the delegates have any questions for us regarding positioning, please type it in now. Go ahead, Manish, please.
All right. Thank you all senior panelists, Dr. Satyen Mehta, for this opportunity. I'm Dr. Manish Kothari from Jaslok Hospital. Now coming to micro discectomy, positioning is the first step, of course, but it is also one of the most important steps. It's like instead of chasing your girlfriend and you propose to her, you want your girlfriend to propose to you. So let the disc come to you rather than you change the disc, and your positioning can help you do that. So another analogy here, a perfect cover drive needs a perfect body position. So let's see how we do that. Now let's go to the physiology part of it. Prone position, we know, changes the physiology of the patient under anesthesia. So there is increase in airway pressure because of the pressure on the chest. There is increase in the abdominal pressure. And there are unnatural pressure points which you need to take care of. So another important part in the anatomy is we all know that the spine is surrounded by a very rich plexus of venous system. There is an internal venous system which surrounds the neural structures. There is an external venous system around the vertebral body and the posterior elements. And you have the connecting system between the two, which eventually will lead to the inferior vena cava and also partly to the superior vena cava. So any increase in the IVC pressure will lead to increased pressure in the epidural veins, and we all know what is the consequence of that. So poor positioning, I'm going to start the reverse way. Poor positioning leads to increased bleeding, increased surgical time, your access to the disc is less, you may have to remove more bone. There are unnatural pressure points as we discussed, and it may lead to, you may treat the radicular pain, the patient may but end up having a pain at the pressure points or something like a meralgia paresthetica, which is common up to 20%. So what are the goals of a safe positioning? You want very adequate padding of the pressure points. The abdomen should be free. You have to reduce the abdominal pressure, which will indirectly reduce the IVC pressure, and open up the interlaminar space so that when you do your laminotomy, your disc is presented to you. Another important part is when you open up the interlaminar space, your flavum is stretched. So removing the flavum, a stretched flavum, is far easier than removing a crumpled flavum in a discectomy case. Now, coming to the pressure points, starting from head to toe, first and foremost, you have to take care of the eyes. This is a prone view that I commonly use. You can see the eyes from the underside. There's a mirror on the underside, and you can very well visualize the eyes so that you make sure that the eyes are free. Next, you come to the shoulders. You want the shoulders and elbows to be in a 90-90 position, and they should be in slight about 20-30 degrees of forward flexion. Next, you want to take care of all the nerves. So one is the ulnar nerve. Second is the axillary, the brachial plexus in the axilla. Third, you want to take the lateral cutaneous nerve of thigh. Make sure the bony points on the knee and the ankles are taken care of. You want to flex the hip and knees slightly so that your root retraction becomes easy. Third, you want to look at the abdomen. Now, any external pressure on the abdomen will increase the abdominal pressure and will indirectly lead to IVC pressure. Now, there are certain scenarios which will cause this as a problem. First is if the bolsters are too close. If you are someone who likes to keep your bolsters vertical and a patient is slightly hefty and the bolsters come too close, there is effectively pressure on the abdomen and the IVC pressure will increase. If the bolsters are too far out, the patient may sink between the bolsters and the abdomen will touch the table. That itself will increase the abdominal pressure. And commonly nowadays, if the patient has a large belly, then it is difficult to manage with the bolster. We'll look at it how. Now, while we are looking at the IVC pressure, we also need to know what are the intrinsic factors, what are things other than the bolsters that can cause increase in IVC pressure. So let's look at them. One is any pressure on the chest. So if you have an assistant who's resting on the patient with the elbow on the patient, that may increase the pressure. The anesthetist, sometimes if you're a junior or a resident, may have a very high tidal volume for that according to the weight of the patient, which will indirectly lead to increased pressure. If the patient is asthmatic and not properly bronchodilated, again that will lead to pressure. If the patient is poorly paralyzed, as in the neuromuscular block is not given properly and the dose is not given, or if the atracurium bottles are kept outside before given, they need a cold chain bind, you remember that, then again that will lead to poor neuromuscular blockade. The anesthetist will tell you that I've just given a block now, but you will say no, the muscles are tight and still bleeding. So this is one thing that you can think of, and the depth of anesthesia has to be correct. Third, again, the anesthetist will tell you that I have given adequate hypotension, your field is good. No, but hypotension alone does not lead to reduced bleeding. You have to take care of all these things. So one thing that I look at is the airway pressure is something called as a P peak. In this, it is measured as showing as 17. So anything less than 22, 23 is actually quite okay. Anything more than 30, you will definitely have a lot of bleeding. And you try to compare the supine airway pressure versus the prone airway pressure. If there is a very large change, then you need to make sure that there is no pressure on the abdomen or the tube is not kinking anywhere. So all of these steps taken before you start draping will reduce your bleeding. Other is, again, you look if the tidal volume is too high, or if you're having a lot of bleeding, you can ask your anesthetist, can you please reduce the tidal volume for a short while so that I can control the bleeding, let the blood clot, and then you can resume the surgery. Third is you want to open up the disc space. Now this is where you don't chase the disc comes to you. So a common way of doing is using the Wilson's frame. They are slightly expensive but very handy for thin patients. So this works like a car jack. You can jack up the spine, reduce the lordosis, get it into flexion, so the posterior part of the disc opens, the interlaminar space opens, and your access becomes much easier. It has this handle on one side where you can jack it up like as a car stepney, and you can also adjust the distance in between the bolsters according to the size of the patient. Very handy, very useful, but slightly expensive. Other older method of using is a knee chest position. So in this case, you can see there is a bolster kept under the chest. The head has been turned to one side. This patient has not had a prone view. But if you see the knee at the popliteal fossa, the pressures are quite high. So for a half an hour, 1 hour case, probably it is quite okay. But if this goes on for more than 2 hours, you might be in trouble. So to reduce the popliteal pressure, they have this buttock support which is attached to the table, which makes sure that the knee does not flex completely. Also, in older patients with arthritic knees, this might lead to knee pain after the surgery. Other is you can break the table. So for a relatively thin patient or a moderate patient, you can keep the bolsters vertical and you can break the table so that it gives you some flexion in the lumbar spine. So this is not a discectomy case, but just to demonstrate how much you can break the table to achieve a very good flexion in the lumbar spine. Other is dealing with obese patients. Now you look at the tummy of this lady. This is not going to fit in between two bolsters. This is not going to fit with horizontal bolsters. You need very large horizontal bolsters. And again, that will also lead to increased abdominal pressure. Horizontal bolsters will also increase your lumbar lordosis and decrease your working area. So there are some certain other specialized bolsters available which are made according to the shape of the patient, which can be used. Another different technique that you can use for patients with large bellies is you can stack up some pillows on the chest side, and you can stack up the bolster on another small pillow to raise the height so that you get adequate distance between the belly and the table. So these are some small tips and tricks to take care of the positioning during the patient. So to summarize, you need adequate padding, free the abdomen and chest, open up the spine so that the disc work becomes easy, and plan well in advance for obese patients. Thank you.
Yeah, Dheeraj, do you have any questions for Manish?
Yeah. No, it was an excellent talk. I have no questions. He has taken care of every aspect which can be explained for positioning. Gautam sir, any questions from your side?
No, I think that was a wonderful talk. Manish, what about, you talked a lot about flexion. I did that a lot during the initial days of my starting practice. Today, I don't bother that much. I think when you give a lot of flexion, it tightens up the structures at the back. And therefore, if you're doing a micro discectomy, the retraction becomes a little bit more difficult. Also, when you give, it doesn't seem to really matter, unless the patient has a very small disc space. Other than that, majority of the times I'm able to get away with a fenestration at L4-5, L5-S1, even in a normally positioned spine. I don't make any efforts nowadays to actually flex the spine anymore.
Yeah, so excellent question, sir. I just add about 10 degrees or so of flexion just to make it slightly open up. As in, it doesn't. That picture was just to demonstrate how much you can do as needed, but that's not the usual practice. And slight opening of the disc is actually quite helpful. The disc actually presents to you many times. It makes your job quite easy. And the flavum, the important part is the flavum stretches up, so you can take up the flavum very easily. You don't have to remove much of the bone if the flavum is stretched. If the flavum is crumpled, you have to keep taking the bone to get to the end of the flavum.
Can I add a tip to the thing? When you position the obese patient with large pads and pillows and bolsters under the abdomen, the total height from the back of the patient surface to the underneath the table, that distance increases. And sometimes if you have C-arm, which may, after you put in the C-arm to even the local eyes, sometimes you don't have enough space for functioning. This
So
is
you
a
can
gentle.
get the C-arm from above rather than taking
No, no.
the C-arm
Whether
from
you
under the
take from
table.
above, the the arm has a fixed distance of 90 centimeters or so.
Yes, sir. But so far I've not had any
And
problem with that.
then if you increase the height, the back of the surface of the back to the underneath of the table, that jaw for the C-arm sometimes will not leave you space for functioning. So just be careful about that. Just be aware of this.
Dr. Srivastava,
Yeah, only one comment that in case of lumbar canal stenosis, okay, if you too much flex the spine, the physiological position which the patient takes, and then he starts getting symptoms, that may be slightly decrease in that position. So we will not be able to decompress it so nicely. So in that case, in cases of lumbar canal stenosis, it is better to keep in neutral or maybe slightly more in extension as much as it is possible, so that we are able to decompress it nicely. When you hyperflex the spine, so your decompression is not that adequate, which usually the patient takes the safe when he stands.
Right,
So
sir. Very
that is the
important
only
point
one.
here, sir. But this position is purely for a discectomy case. This position is not for a stenosis case.
Yeah,
in stenosis, you want over stenosed condition, as in a probably a lordotic patient or a neutral patient. You don't want a flex spine in a stenosis case. This is purely for discectomy.
Yeah. So another advantage in a microdiscectomy case for stretching of spine, that we are releasing the upper laminar lower half or the lower laminotomy till the time we have a loosened ligamentum flavum. So if the stretched ligamentum flavum, it's better to be loosened up till the with a laminotomy against a loose latched ligamentum flavum.
So to remove the flavum, there are two techniques. One is you go to the upper end, at the lower end of the upper lamina, and you reach the upper end of the flavum, or you make a midline incision in the flavum itself, and then you start taking the flavum. Right? I'm sure Dr. Satyan Mehta will explain that during the video technique. So if the flavum is stressed, you can very easily take an incision in the flavum rather than in a crumpled flavum.
Great. So we'll go ahead to the
Satyen, can I
technique part. Yeah, please.
So the mechanics always are between the positioning, the size of the disc. So if it's a huge disc, the dura is going to be compressed significantly against the flavum as well, and the bony pieces as well. So you got to take into consideration that as well, and not hyperflexes, so that the dural retraction or dural injury becomes very common, especially in a huge disc.
Great. Thank you, Uday. I think we'll summarize here that yes, if you do flex the spine, it makes it a little easier to get the disc out. However, you've got to wait against the degree of neural compression and, of course, what your ease is. So we'll go ahead to the technique part. But the most important part in positioning is adequate padding of all your structures, so that you avoid any injuries and have adequate venous decompression, so that you don't have bleeding during the surgery, care of eyes, etc.
One more tip here again. I'm sorry, I'm dragging. We always catheterize the patient and connect it to the bag. We want the bladder to be empty, because even congested, filled up bladder would increase Baxter's venous plexus pressure. And we have seen it troubling us during surgery if they're not. Every time you catheterize the bladder and drain it continuously, you will be more comfortable on the table.
Yeah. I want to request all the delegates who are watching, you can go on to the questions answers part, and you can just put in a question on whatever technique part or whatever questions you have, and we will put it to our esteemed panelists to answer, to help you out. So I'll start sharing our screen for the presentation now, for the technique part. So we've already discussed the positioning, and we'll go on to the technique of the microlumbar discectomy. As Dr. Ingalalikar already said, that when you have a disc herniation, the herniated part of this is at the lower end of your lamina. And if you are at the lower you are at L5 and L4-5, you don't need to remove much of bone. You just need to remove the ligamentum flavum from here, and maybe a little bit of laminotomy, and you can go into the disc. So you do not need to get any of the spinous process out or any of the laminar part out. If you see, this is where it is. The spinous process is higher, and the disc is at the lower end of your process and lower end of your lamina. So the microlumbar discectomy is now the gold standard in treating lumbar disc herniations. All the other forms of discectomies with other forms of penetrations, etc., are variations. Now, considering this patient who is a little bit heavy with a left-sided disc, this is the way we position this patient. If you want, you can give it a little bit of flexion as we have done it here, but make sure there is adequate padding at the pressure points which was discussed. Now, this is probably the most important part on of the surgery is your level marking. Now, this is where you can make mistakes very easily, especially in a heavier patient. First of all, you need to use a wide gauge needle and you need to put it on the opposite side. So if you are doing it from the left side, you put it on the right side into the area where you feel that they are going to get into that space. The angle also should help you to reach that area. All right. And so you need to make sure that you are at the right level when you start the surgery. And even after you open it up later on also, you should reconfirm, because that is the point where it can easily go wrong. When you open this patient up and you start dissecting, it is very easy to slide along the lamina. You can slide proximally and go to the higher level. So when you're doing an L5S1, it is very easy to slide and reach L45. And then if you start opening that L45 up, you may realize that there's no disc there, and then you check your level and unnecessarily you have done opened up a wrong level. So it's very important to make sure that you don't go to that wrong level and make sure you stick to this correct level where you are. This is our workhorse for doing your microlumbar discectomy, which is a McCulloch's retractor. Make sure you use one which has got a double joint so that it is easy to place, a hook which is in the interspinous area on one side, and a blade which is helps to thread to retract your muscle on the other side. You can place, you can even use a tube retractor if you want, and a microscope is always handy. Using a McCulloch's retractor, you can easily reach that level and you can do your discectomy from there. You can use a tube and you can angulate the tube to go to the other level as well, but that is your next stage. However, realistically, it doesn't make much difference. You can do quite well with both. And this is the video which I'm starting off on the exposure part. If you want me to stop in between, just let me know. This is the lamina here on the left, on the 9 o'clock side. This is the ligamentum flavum in the center. This is your spinous process.
While you are going on, I think it is vital that people should understand that by marking the skin, you are not definitive. Some people say, I mark the skin, so I am at the right level. The skin is stretchable and mobile, and therefore you may not be at the right level even after marking the skin. And therefore, I usually always, after having exposed the interlaminar space, put a Penfield over there and take another shoot in order to confirm that I am at the right level. And please do not, when you're doing small incision surgeries, it's very easy to get lost because you're not getting any support from the landmarks which are normally there. So don't look at the mobility of the spinous process or the sounding of the sacrum and the lumbar spine, which we normally take as methods to identify level. Make it physically that you take a Penfield 4 and take an X-ray shoot intraoperatively to make it. The second most important point in measuring levels is that please make sure that you have a pre-operative X-ray and you look for transitional segments, etc. Now, if you have a pre-operative X-ray, make sure that you compare it with the pre-operative MRI and make sure the levels marked in the MRI and what you are seeing on X-ray are the same. Because when you go intraoperatively under the C-arm, you are seeing an X-ray. So you will be counting from L5S1 upwards, and that is absolutely vital in deciding your level.
Intraoperatively, I would even say let the focus be from the first good-looking disc or first disc looking? Is it the first? Is it the second? Is it the third? Because 4, 5, 5S1, even sometimes if the radiologist mark it wrong on MRI,
Yeah.
then you may go wrong altogether. So you have to decide, looking at MRI, is this the first disc space? Is it the second disc space, third disc space, and accordingly go up.
One more point which we can add here is that when you open it up, you can actually make out that the amount of interlaminar space that you're seeing. I said L looks like an L5S1, looks like an L4-5, looks like an L3-4. If it gets narrower, and if you feel that it is really wrong, then you got to really make sure whether you're before going inside. And of course, Siam is very important. Should I go ahead?
Go ahead.
So again, this is the video. This is at your 9 o'clock, from 6 to 9 o'clock. This is your lamina of L5. This is your ligamentum flavum here. At 3 o'clock is your S1 upper end. And this is your spinous process at this level. So here I am, we are not going to remove any of the lamina. So I'm just making a small cut at the medial aspect of the ligamentum flavum. We go on the medial aspect because there is much more space in the canal at that level, and so it is much safer to cut along that rather than going laterally where you are much closer to the neural elements. So we are going closer to the spinous process, and when I make this cut, we are going to make it only on the superficial aspect of the ligamentum flavum, so that the rest of the dissection can be done by blunt dissection using your Penfield number 4, where you can just penetrate the inner part very gradually and get into the space. And this is how we are doing it here. We've already entered, but looking through the microscope. So once we've entered through the neural space, we put a Penfield along that between the Penfield and the ligamentum flavum, and then make a cut again on the lateral aspect, so that you make this cut as a T shape, one longitudinally and one transversely, so that you can then easily remove the rest of the ligamentum flavum and expose the epidural fat underneath. You can even use a patty underneath that to protect the neural elements, especially if you feel that it is very tight, and also to make sure that there are no adhesions there. So this is what we are doing here. So I'll just pause here. Anything you want to add, Dr. Srivastav, sir, at this point?
You nicely mentioned that moving the Penfield below the flavum is very, very important. More so if one has a chronic disc. In that case, there are adhesions, and sometimes that is the cause of biting the dura when you are putting your Carrison. So this is extremely important.
Yes, sir. So I'll go ahead. I put the patty inside, and we are still dissecting the last part of the ligamentum flavum on the lateral side. Once the dura is exposed, again there is a small band of ligamentum flavum very laterally, and that you need to usually remove, excise, to get an adequate neural decompression over there as well.
Satyan, I call this lateral band as a roof of the lateral recess. The whole lateral recess is there, and that continues as a interior capsule of the facet joint. So this ligamentum flavum and everything is all exactly same plane. On the roots, the lateral margin of the dura, everything else is underneath this whole space. So it's a roof of the lateral recess.
What you said, Satyan, is very important, because unless you remove this piece of ligamentum flavum, you cannot see the root.
You cannot see the root, and you can't even decompress it.
Important thing in a discectomy is, do not start your discectomy till you have seen the shoulder of the root. You should be able to see the root completely before you start doing. Sometimes the disc may pop up out inside in the axilla, and you tend to try and go and take it. If you do that, the risk of axillary injury, the dural injury, as well as you cutting the nerve root in thinking it's a disc, is very, very high. So first isolate and clearly see the nerve root before you start your discectomy.
Excellent, sir. I was just going to say that, and you just read my mind, that as soon as you see the neural element, don't think of it as a root and start dissecting it. Make sure that you go laterally and look for the nerve root, and then only expose it all along, get to the shoulder. Sometimes you may even see conjoined roots. You don't, and it's be very tight, and you may damage the neural structure in trying to retract it, thinking that this is the only root. So this is what we've done here at this stage. The root has been exposed, and we've used the patty as a passive retractor distally, and going to use a patty proximally as well to isolate this and isolate the disc, get a good exposure of the disc here. We're making sure there are no adhesions, using a hook, which is a very helpful instrument to make sure that it's free while we dissect the root out. So I'll go to the next part of the video. This is we've used a neural retractor here. This is a bigger one. Normally we use just a Penfield or maybe a Penfield number 1. This is the root, this is the dura, and the disc has been exposed at this stage. This is the disc space. We make an opening for pituitary rhonchus to get the disc out. You can usually get the extruded part of the disc out very easily by using a hook and excising that. Dr. Srivastav, you wanted to add something here, sir?
This is very fine. You have explained everything nicely.
Yeah, Satyen,
yes, sir.
One of the advantages of fenestration over interlaminar approach or total laminectomy is your assistant who is retracting the nerve root or the dura can never over-retract it.
Never over-retract it, yes, sir.
The bony margins of the fenestration will always obstruct him.
Yes, sir. So you're lucky you always have assistants. Normally, when I do this, I'm doing it on my own because...
So, but then your left hand is your assistant, so it will not over-retract it.
Yes. My left hand is more than my assistant.
Another point I would like to make, after taking out the disc, and you should not close the thing unless you see the neural structure is very free.
Yes.
The nerve root which is exiting just below it is absolutely free, and palpate that area whether there is no remnant piece there.
Yes, sir. Dheeraj?
Yes. So have you stopped doing laminotomies in microdiscectomy? Are you always going from midline, doing ligament excision and then removing the disc?
It depends on the level. At L5 S1, you don't need to do any of that. At L4-5, you may need to do it. Depends on how much space is available. L3-4 for sure. I mean, you have to remove the a lot of the lamina more.
See, if the disc has flowed downwards or flowed upwards, say for example, 4-5 disc has migrated upwards behind the body of 4, sometimes you'll end up doing hemilaminectomy. You start as a fenestration, but you'll end up doing hemilaminectomy.
Right. I started doing this method initially in my practice, and I was not very happy with the getting the planes right. However, you have demonstrated excellently well. So
I'll just go ahead.
On your training. So Satyen trained with me. This is how I did it. That is why he is doing it.
Superb, sir. Great, sir.
So we're using a blunt hook to get the extruded part out. And we're just making sure that there is no remnants left out, and the root is nice and free, all till you can feel it down into its foramen. And
Satyen, can I add a couple of points to you? In the beginning, you showed how you put a blunt hook to dissect. So it's important that once you make the annular incision, you don't just plunge for the disc. You put in a blunt hook and you actually separate the disc as much as possible and then gently start pulling out. And the second thing is, when you put your disc punch into the disc space, in the first bite, please do not take the disc. Just let it come out, because what happens is when you initially go in, it plunges in. There is a certain pressure, negative pressure there, which you are overcoming, and it goes in. So it plunges into the disc space. So if you go there, you might have gone very deep and you might get a anterior structure, a vessel in your disc punch. So usually I do not take the first bit. I come out just like that. Then the second time when I introduce, that is the time when I start taking a disc fragment. Always remember that do not go too deep into the disc space with your disc punch and take a bite. You might land up with an anterior problem.
Great.
I want to tell all the delegates one thing here. there are two most important things you must have on the operation table.
Yes, sir.
One is patience and second is meticulousness.
So you mean patient or patience?
Patience. Patience and meticulousness. Those people who are sort of very fast and rash drivers, I would say they should go for trauma management or a joint replacement or something. They should not touch the spine. These neural structures or even other structures also, they need to be handled carefully. And the race against the time is extremely bad. Oh, I finished my discectomy in 15 minutes is not a thing, something to be proud of. I do a discectomy where the patient never comes back with a problem is a matter of pride.
Satyan, at the end, do you do any disc space irrigation?
Yeah, I was going to ask that. You read my mind always. So, yes, I don't do any irrigation usually if I've got an adequate discectomy done. But I think some people do. Dheeraj, I think you do irrigation regularly.
No, I don't do irrigation now. I want to ask Gautam sir and you as well one question that how do you look for the difficult all the areas which we check after discectomy, though you are satisfied with the discectomy? So you look for the axilla or search for any other fragment which might be left after discectomy?
Yes, normally we do because, sometimes you may push a fragment here and there without realizing. So it's just better to check it. Takes a couple of minutes only.
Right.
The second question is, do you put local steroid or local anesthetic infiltration periradicular at the end of your surgery? I do.
Yes, I do as well. And only the place where I do not do it is when the dura is very thin and if there is a chance that it can lead to a delayed rupture because putting a steroid there thins out the dura even more. Also in diabetics, we try to avoid as they don't want the sugars to go very crazy.
Right. Third question, which I'm sure a lot of delegates must be thinking, since you took a vertical incision in the ligamentum flavum, do you suture the ligamentum flavum at the end or anything like that?
There is no flavum left, sir.
Right now, but there are people who have procedures where there is a flavum is sutured or the annulus is sutured, so nothing like that.
Nothing like that.
And so once you have closed the wound, when do you mobilize this patient, Satyan?
I mobilize them in a few hours by evening.
By evening. Yes. And what do you start them on any back exercises early or they are started later?
We start them on basic isometric type of exercises initially. And after a month or so, we start them on more aggressive exercise.
Lovely. Okay. I think that was a very nice presentation, Satyan.
Yes, I'll just quickly, so there's a few seconds on doing the same discectomy through the tube where you can see this lateral recess roof being removed. As Dr. Ingalalikar explained that you need to get this out and then you just retract the root and get the extruded disc out.
So this upper angle is extremely important, which you have shown at over there. That is the angle between the lamina and the facet. That is called as the pheasant's angle. And you need to remove a little bit of bone there in order to be able to get to the disc space. That is exactly where the disc space is at L4-5, L3-4.
Great.
Yeah. Satyan, there is a question from a delegate, Vishnu Das. So his question is, if you go inside, there is no disc there. So should we take an incision over the disc and try to remove or get away with adequate decompression without disturbing the disc?
What does Dr. Srivastava want to answer that?
I think the most important thing there, Dheeraj, is take another Siam shoot.
You're at the wrong level.
If you do not find anything which does not match your pre-operative MRI picture, if you have seen a very large disc and you are getting a very small disc, immediately before doing anything further, take a Siam shoot. Make sure at the right level. Okay. Usually in the good old days, now a little lesser, but the good old days when I started practice, I would take 3 shoots. 1 at skin marking, 2nd at interlaminar space, 3rd, I would put a Penfield probe in my disc space at the end of the discectomy and take a picture. So that is the way to document that you have done an adequate job.
Right, sir. So if the level is fine, sometimes we do have the annulus are intact, and many times it's just due to a bulge, it's the nerve is compressed. So what do you do in that
No,
case?
so Dheeraj, this happens if it's not a herniated, sort of not ruptured disc, but good posterior annular cover. And when you give little flexion in that space, that posterior annulus is straightened out, and the bulge becomes less flattened. And that could be another reason why what looked like a good bulge when a patient lying supine lordotic on MRI table is now straightened out. So it's a bulgeable annulus, which is not bulging now because you've given flexion in the segment. But like Gautam said, you must check.
L5S1 disc space, which was, disc prolapse, which was chronic, and there was a significant reduction in the disc space. Often you find osteophytes which are very large. How do you tackle them? Do you take them out, or you just believe in a secondary decompression of the nerve root you have achieved and leave it alone?
So if it is easy to take out, then we can use an small osteotome to take it out. But if I've got an adequate decompression by just doing the discectomy, then that is enough. I don't overly go crazy in trying to take it.
So I think that is important. You should
if that osteophyte
will regrow over time.
Yeah. If that osteophyte is like a bad speed breaker for your car on the road, you request people to remove it. But if it is not too bad, you accept it. Similarly, if the root is not tented up badly, you may not do anything there.
So we'll go ahead, sir, and Doctor. I'd like to invite Dr. Zaveri to take on to the next session, next part of the session, where we are going to discuss the surgical technique of doing a laminectomy and a TLIF procedure.
Thank you very much, Satyan. And so here, this is a 57-year-old male who has come with severe back pain, bilateral radicular pain. You can see on the X-rays, this is a mobile lytic listhesis. The MRI did not show any evidence of any disc herniation at the level, and nor was there any severe central canal stenosis. The patient had just a mobile lytic listhesis which was causing pain. My question, let's ask Dheeraj. Dheeraj, how would you deal with this patient considering the MRI is not showing anything bad? As you would see, there would be an L4-5 pseudo bulge was there, but other than that, there was nothing much on an MRI.
Gautam, we would like to see the MRI.
Actually, the MRI is lower down in the presentation.
Okay. No, because if the listhesis is significantly corrected, and therefore MRI doesn't show things bad, then you got to interpret MRI in view of the central film. Look at the X-ray film in the middle, which is inflection. This patient's MRI cannot be done in this position, but things are bad.
Yeah. So Dheeraj, how will you deal with this? Will you treat this patient as had about 4 months of non-operative treatment, but with symptoms?
Yeah.
How would you treat this now?
So there is definitely instability there and a significant instability. So I will go ahead with TLIF surgery in such case.
Right. So you would go with a decompression and instrumented fusion is what you are saying through a transforaminal approach. Now my question is, will you be doing a laminectomy decompression or will you just go through the foramen in this patient?
Okay. So I always like to do a laminectomy first in such cases. Then go for fasciectomy and do the anterior fusion and disc debridement first. Then go for a pedicle screw fixation. So initially I used to go reverse with the pedicle screws trajectory first, especially in such a grade 2 listhesis. Getting the pedicle tract, especially the upper vertebra, it used to be very difficult, especially in depth.
Right. Thank you very much, Dheeraj. Without much ado, since our talk is on lumbar decompression, there are 4 types of lumbar decompression one can do. One can do a laminectomy. Usually it is recommended in the upper lumbar spine or in patients with a severe central canal stenosis or with a large disc, central disc prolapse. We would think of doing a laminectomy. If the patient has a more of a lateral canal stenosis, more in the upper lumbar spine, there is a sequestrated disc which has gone up or down, you would think of doing a hemilaminectomy. And nowadays, we do a lot more of intralaminar decompression, especially in the lower lumbar spine, or over the top decompression. What I'm going to show you is a video of a simple lumbar decompression laminectomy. This video was shared to me with me by Dr. Sandeep Sonode, who has done this procedure. So if he has made any mistakes, please don't castigate me. So the positioning is a simple prone position over bolsters, and it is in extension, it is not in flexion, unlike the position that Manish showed for this thing. The level is marked, and having marked the level, we then take a posterior midline incision. You must remember when you make the incision that in the midline there is nothing. So from skin to spinous process, you can directly go in a single incision. Below the spinous process, at the level of the spinous process, the lumbodorsal fascia is attached. So in patients who are a little more obese, I like to retract the fat a little bit and then dissect it out, and then so that it doesn't interfere with our exposure, and more importantly, doesn't interfere with our closure. Then you dissect the lumbodorsal fascia. You must remember the lumbodorsal fascia is attached to the spinous process. You have to go in layers slowly because otherwise you plunge into the muscle. The spinous process tip is bulbous. If you go directly vertically down with your cautery, you will go into muscle and it will bleed. So the cautery tip should be directed medially so that you can dissect the lumbodorsal fascia and the muscle insertion of the bone. As you dissect the muscle, your cautery should go from caudal to cephalad. Why is that? Because the muscles are inserted and they take off from cephalad to caudal. So if you go from cephalad, that is from above downwards, then what will happen? You will go into muscle and there will be bleeding. However, if you go from below upwards, you will go into the angle of the muscular origin, and therefore you will be right on bone, and there will be bleeding will be less. Remember, the muscle is attached to the lamina, whereas it is the tendons of the muscle which are attached to the lower border of the spinous process and to the lower border of the lamina, which need to be cut. Now you can do a blunt dissection using a periosteum elevator or a Cobb elevator, or you can use a cautery, and then I like to cut it with a scissor. The reason why I cut the tendons with the scissor is because that way you don't end up damaging the facet capsule. Your initial dissection should go towards, as you can see on one side, the pars interarticularis. So your initial dissection should go up to the pars interarticularis laterally. You must see the pars interarticularis because you don't want to remove too much of pars interarticularis during your decompression, or you may land up with instability. Having exposed that, you then start removing in a laminectomy. You remove
can you pause here?
Yeah, absolutely. So in a laminectomy, what you tend to do is you put in a layer spinous process cutter and you nibble out the spinous processes. Now you can see the laminae. Now you have 2-3 different ways of cutting the lamina. Some people use only Kerrison punches, some people use nibblers along with the Kerrison punches, and some people use high-speed drills to thin out the lamina, and then they go ahead and start excising the lamina. The lamina, the bottom end of the lamina, as you saw over there, is V-shaped, as you can see over here, and you have to basically go there. The lamina slopes downwards. The cephalad end of the lamina is digging into the dural sac, whereas the caudal end of the lamina is superficial, and therefore you always go from caudal to cephalad when you are doing a laminectomy. Keep in mind that you have to keep the pars at least 7 to 10 millimeters of the pars interarticularis intact in order to be able to do prevent instability. Before you start your laminectomy, the ligamentum flavum is going below that. So what you do is you put a scoop or a Penfield 4 and dissect the flavum off the underedge of the lamina and then start doing your laminectomy. When you reach the upper end of the flavum, as you saw Dr. Sonode, dissected that by using a blunt hook, and then started doing his flavor removal.
So would you put in patties before doing this dissection?
So no, I normally do not put in patties, but yes, I know that a number of people would always operate over a patty. They would dissect with a patty and operate over a patty. I simply put in a Penfield 4 and dissect out the flavum, make sure there are no additions, and then I go ahead and use it. I use a two-handed technique. With my left hand, I retract the neural structures, and with my right hand, I'm using the Kerrison punch and taking out the pieces. So as you can see, he has removed the inferior overhang and reached the superior edge of the ligamentum flavum.
Yes, go ahead, sir.
So that is the dural sac which is now coming into view. So as he said, there are three ways of doing a flavotomy: separating it from the undersurface of the superior lamina. So what you have to do is you have to cut the superior lamina till you reach, you can see the upper free edge of the ligamentum flavum. Then put a blunt hook, separate the adhesions, and then start taking the ligamentum flavum. The second is separating it from the superior border of inferior lamina. That is most easy at L5S1 because the superior border of S1 is very thin and sharp. So what we do is we put a small scoop in between the flavum and the inferior lamina, and then we move it around so that it gets separated, and then use a Kerrison to take it out. Or you can explore the midline between the two fibers of the flavum. So here you can see, now he's going laterally, and he's reflecting the entire flavum inferiorly.
So would you think that this would be the most critical step, and this is the point where you can easily get dural tear, and so you need to be very careful here?
Yes, absolutely. This is a very critical step. When you are, therefore, adhesions you should look for. Number two is the second most common place where you get a dural tear is at the upper edge of the ligament of the lamina. That is where the lamina is digging in. And third is, if you are not careful, you get it at the axilla. The upper edge comes here at the lower end of your laminectomy that you are doing. The upper edge of the lower vertebra is digging in there. When you put your Kerrison, if you have not angulated it upwards, you can take a side bite of the flavum.
Like there are peritoneal bands, there are naturally existing bands which go from the peripheral wall, anteriorly, posteriorly, laterally, to the dural sac and to the nerve roots. And if you don't dissect them off, and if you try to remove a piece of lamina, and if there is underlying band, dural band, it will eventually pull out a strip of dura, producing a tear which is linear. Well, producing tear can be sutured, but if that band removes a width of the dural strip, say 2 mm, 3 mm, when you suture it, you're going to effectively produce a dural stenosis. Therefore, try to see that these things. And if there is a history of recurrent radiculitis, not radiculopathy, that the root was inflamed and patient had intense pain down repeatedly, you must expect adhesions. If they're not there, God has given you bonus during surgery. But you take it for granted that the adhesions will be there. And when you try to take care of these adhesions, generally you land up. Very often, these adhesions are nothing else but newly produced arterioles and venules. So when
you can see over here that Dr. Sonawane is basically putting in a patty and dissecting the flavum of the dura before putting in your Kerrison. This is now he has reached the lower level end of his laminectomy, which is basically the lower vertebra. And this is where you have to be most careful in terms of tearing the dura. Sorry, sir, for interrupting. Please go ahead.
Yeah, no, so very often these adhesions are nothing else but the venules and arterioles going from periphery and supplying the nerve root. And when you dissect all of them and cut them or cauterize them or do something there, in front of your eyes, the root, which looked reasonably okay, now starts swelling up, becomes edematous. Not only because of your handling, but because of dividing their arterioles and venules. Therefore, you be careful.
As you can see, he is with that the ligamentum flavum is gradually being excised. What I like to do is keep the ligamentum flavum intact, and I finish my bony work on, especially on the sides where I'm decompressing at the level. You must remember that the laminectomy decompresses the central canal pressure. At this point onwards, now you start undercutting. You don't excise like you were doing at a 90-day. You can see now how he is angulating his Kerrison punch at an angle of 45. This was upwards. But in the same manner, he's trying to show you that this is the facet joint which is compressing the dural sac. So
this particular step is very important.
He's going to undercut. He will start using his Kerrison in a more oblique fashion so that he doesn't remove the superficial bone, only the bone in the depth, which is actually causing compression or narrowing of the lateral recess, is going to be removed.
This
the lateral border of lateral recess is the pedicle. As you can see over here, he's showing you the pars interarticularis, and he was showing that he has left at least 7 to 10 millimeters of the pars in order to maintain stability. You have to leave that much amount of facet joint also vertically. And now the undercutting has started. The undercutting is preferably done from the opposite side because that is the way you get vision into the lateral recess. That's a flavum band which Dr. Ingalalekar was talking during the discectomy. Same flavum band is overhanging the lateral canal in this patient. That band needs to be dissected out before you remove because the nerve root is right below that, and therefore if you're not careful there is a high risk of nerve root injury or dural injury. So he has dissected it out and now he's putting in a Kerrison punch.
I so often see patients where only midline dissection has been done. Only midline decompression has been done, calling it laminectomy. But the lateral recess decompression is the most important. The pathology so often is only in the lateral side, not in the midline. So decompressing midline doesn't help. It is even possible for you to do bilateral lateral recess decompression without decompressing midline.
So
you will find so many patients.
What he is doing is that he is removing the superior part of the inferior lamina laterally so as to deroof the entire canal. Unless you do that, you will not be able to go out up to the neural foramina where it is going out the nerve root. So here he is gradually removing the undersurface, what is called as the overhanging facet joint, in order to be able to decompress the canal. Similar situation. You can see how the dural sac, the dura has become very thin. You can actually see the nerve root structures because of the tight stenosis.
So do you think that he's done quite a wide decompression? And I mean, normally would you also do such a wide decompression?
If required, yes.
Yes, I would do a wide decompression as long as I am sure that I am not destabilizing. If I have left 7 to 10 millimeters of the pars like he has, and I have not removed too much of the facet joint, then I will remove as much as is necessary in order to make sure that my nerve root is adequately free.
Again, Satyan, I would like to repeat what I said. If the purpose of surgery is neural decompression, it must be done.
Epidural vein. And that is where just below that facet joint, the epidural veins and plexuses are there. And if you are not carefully dissected out gently with a Penfield 4, it bleeds copiously and then it blocks your surgery. So be a little gentle in that area in terms of dissecting out the epidural vessels and then start excising the facet joint. How do you determine what is the extent of lateral recess? When you feel the medial border of pedicle, that is the lateral border of the lateral canal. It means that you have decompressed the lateral canal adequately. Then you as Dr. Ingalalekar mentioned about those mild duct probes, the similar dilators. Well, similarly, we have blunt probes in our armamentarium. those blunt probes can be put into the neural foramina, or the penfield for the other end, what is called as the Watson chain, can be put into the foramen to check for whether it is free or not. And the retractability of the nerve root also tells you whether it is free or not. So at this point in time, you have finished the lumbar canal decompression, and we now move on to the next part of the procedure, and that is the transforaminal lumbar interbody fusion. I think the most important thing you must remember is that instrumentation is not equal to spinal fusion. A number of times we spend a lot of time putting in pedicle screws, and then when it comes to doing the fusion, we throw in a little bit of bone graft and we think we have done a fantastic job of the surgery. You must remember that the primary job of surgery is fusion, and instrumentation is being done only to improve the fusion rate and stabilize the spine until fusion occurs. So what are the types of spinal fusion? A posterior spinal fusion was described in 1910 by Albee and Hibbs, where they decorticated the spinous processes, the lamina and the facets at the back, and put bone graft over that area to do a posterior fusion. However, the posterior fusion is not possible when you have to do a decompression at the back, and therefore you needed to put bone graft somewhere else. Plus, posterior fusion is on the distraction surface of the spine, and therefore the risk of non-union was very high. So people started putting bone graft a little more anteriorly by going laterally in between the transverse processes and laying it on the intertransverse membrane. However, intertransverse process also is still on the distraction surface, no better, and people condemned it, saying that the non-union rates were high. So one of the more preferred approaches these days is the interbody fusion. An interbody fusion is a fusion where you remove the disc and put the graft in between two vertebrae. It can be done anteriorly through an anterior retroperitoneal approach or a transperitoneal approach. Cloward described what is called a spliff, a posterior approach where you do a laminectomy, then you do a medial facetectomy and retract the dural sac in order to be able to put your cage or graft. Then subsequently came out what is called as the transforaminal approach, which Dr. Dheeraj Sonawade was alluding to. And today there are other approaches called as the lateral lumbar interbody fusion and the axial lumbar interbody fusion. The advantages of an interbody fusion are it allows a larger surface area for fusion. It is on the compression surface of the spine, and therefore it is under compression loads, therefore fusion rates are better. It allows correction of lumbar lordosis. It allows restoration of disc height and increases the neural foraminal height. It also allows spinal canal dimensions increase, therefore relieving the stenosis indirectly. What is spliff, which is what Cloward described? As I have shown you, your laminectomy has been performed, a medial facetectomy has been performed, and then retracting the dural sac. You have to retract the dural sac considerably, especially higher up in the leg. L5S1, it is still easily possible, but as you go higher up, the dural retraction is much higher in order to be able to do a pliff. Thus, the disadvantages of pliff are that you are working through the epidural veins, so bleeding is a problem. Because of the amount of handling of the dural sac, dural lacerations, nerve root injuries, and post-operative cauda equina syndromes have been reported. What is T-lift? T-lift is a transforaminal approach. In the pliff, you are going directly posteriorly and straight down at a 90-degree angle from your incision into the disc space. Here you start going posterolaterally by excising a part of the facet in order to be able to access the disc space from the posterolateral approach. The advantage of this is that you get more space lateral to the dural sac, and therefore you do not have to retract the dural or neural structures that much in order to reach the disc space. The advantages, as I said, reduce the damage to dura and nerve root. You can see the epidural veins very well and cauterize them, and therefore it reduces bleeding. It can be performed safely even in the upper lumbar spine. Since you are performing only a unilateral annulotomy, unlike in a pliff where you have to do bilateral annulotomy, this procedure is faster. Because you are going through a virgin area often, because previously a laminectomy may be done, a discectomy may be done, your pliff becomes very difficult because there is epidural scarring from previous surgery and adhesions. This procedure is much better even in patients with these type of patients. So when do you do TLIF? In patients with degenerate discs or disc prolapse or degenerative or lytic spondylolisthesis. When you have to fuse the spine in a revision situation. In patients with degenerative scoliosis to not only achieve a fusion tool, but to achieve correction of the deformity, and in patients with spondylolisthesis. The steps of TLIF, as with any procedure, are exposure. Dr. Dheeraj was very correctly alluding to when I asked him earlier that having exposed the spine adequately to the tip of the transverse processes, the next step is to put in pedicle screws bilaterally. You assemble the rods on the side opposite to which you are doing the TLIF from, and you distract between the screws so that the disc space opens up. Once you've done that, you finish your decompression, whichever way you would like to do, laminectomy, hemilaminectomy, interlaminar, whatever, and do your facet resection. Having done the facet resection and established in a portal for entry into the disc space, now you do a thorough disc space with end plate preparation. You template and tile the bone cage. Having done that, you put in bone graft into the disc space and then put your cage inside. Finally, assemble both the rods and compress so that the cage is wedged in and it is under compression so that by Wolff's law, fusion occurs much better. So this is the positioning we do for a patient who is undergoing a laminectomy or an interbody fusion. The extension allows this patient to be in the position of maximum compression, and therefore your stenosis decompression is better. And also the recreation of the normal lumbar lordosis means that when you fuse that segment, it will be fused in an ideal lordotic position in most circumstances. Unlike what Manish showed, I like to use horizontal bolsters and not vertical bolsters. The upper bolster is placed below the lower thorax and the lower bolster is placed along the curve of the iliac bone so that it rests on that. The knees are flexed at about 40 degrees so that it helps in recreation of the lumbar lordosis. After marking the levels, we infiltrate the skin with 1:500,000 saline adrenaline, and having done that, we expose the spine through a posterior midline approach. I already showed you the exposure but that exposure was only up to the pars interarticularis and the facetal capsule. Till then, the capsule is not disrupted. Having exposed the spine, we take a picture and make sure that we are at the right levels. Once we have taken a picture and we have exposed that area, we start exposing further laterally beyond the facet capsule. We keep the facet capsules intact at both segments initially, but towards the end, the level which you are going to fuse, the facetal capsule has to be removed. But you must strive to keep the facet capsule at the cephalad level, because otherwise you are unnecessarily promoting degeneration of the level as well as instability. The exposure is used if you are planning to do a posterolateral grafting along with the interbody fusion, then you must expose till the tip of the transverse process. If you are not planning to do an interbody intertransverse fusion, then just beyond the facet joint is enough, so just so that you can put the screws. Meticulous hemostasis must be maintained at all stages. Having done that, we then insert pedicle screws bilaterally, and having put in the pedicle screws, we assemble the contralateral rod and then distract between the screws. The advantage of distracting is that the disc space opens up, making your surgery on decompression as well as discectomy on the opposite side far more easily. Having done that, you do your traditional decompression. You can decompress in many different ways: laminectomy, hemilaminectomy, over-the-top decompression as is shown below over here. Or if your decompression is not necessary in that particular patient and you are doing a TLIF with an in situ fusion, then in these patients, you can just remove the facet. it is absolutely vital to remove the facet joint, the medial facet, which is the inferior facet of the superior vertebra, has to be excised completely. And the superior facet of the inferior vertebra has to be amputated at the level of the end plate so that you get adequate room in order to approach the disc space. Which side should the facet be resected? Always go on the side of the worst neurologic deficit. If there is no deficit, on the side of the worst radiculopathy, the worst compression, or if there is a patient who has a disc prolapse or a facet cyst, I prefer to go on that side. In a patient with a degenerative scoliosis, we like to go onto the concavity of the scoliosis so that some amount of correction can be achieved. Having done that, you now start with your discectomy and end plate preparation. You do a thorough discectomy. Be very careful when you are removing the cartilaginous end plate. Keep the bony end plate intact, because if you are too aggressive in removing the end plate, then the base is weak and the cage tends to subside. Having done this decompression, you have to do a bone grafting. We take cancellous bone and insert it into the anterior 1/2 or anterior 2/3 of the disc space, and then insert a cage into. Previously, I used to use these banana cages, but I found them a little difficult to manipulate inside, and now I use the bullet-shaped cages in order to fuse the spine. Having put in your bone graft, the last step is to assemble the rods. And having assembled the rods, if you're going to do intertransverse fusion, then you can put it in over there. And then you apply compression. When you compress, the bone graft comes under compression and by Wolff law tends to align itself, the trabecular pattern aligns itself and it starts fusing much better. So let us show you this technique. This is the position. This is what Dr. Manish Kothari was showing initially, that the patient is positioned without pressure on the eyes. There is a mirror below there, which is showing you that the eyes have no pressure. The arms and elbows and shoulders are at 90-90. The abdomen is free and the spine is in lordosis. A midline incision, you are exposing the spine in layers. Initially, you are doing only the medial dissection. Then at some point, you reach till the tip of the transverse processes and start inserting your screws. This is having insert. This is the transverse process and the pars interarticularis junction, which is being exposed so that your pedicle screws can be inserted. There is a constant bleeder which is there at that level where exactly where this bite is being taken. You must make sure that you cauterize that bleeder before you start taking the bite. You can use a drill. I do not normally use a drill. Having used a drill to expose your pedicle, you start inserting the pedicle. The entry point is the middle half of your transverse process at its very base or junction with the pars interarticularis. Having made the hole, you probe it and make sure that all the walls are intact. The purpose of the probe is to palpate the walls of the pedicle. Having done that, you insert your screws. Some people do not like to put the inferior screw on the side of the interbody fusion because they feel it comes in the way of their fixation if it has a big collar. I don't have such a problem. I put in all 4 screws before I start my decompression. So here, now you can see the pars interarticularis is being excised. Once you excise the pars interarticularis, the medial facet becomes free, that is the inferior facet, and you can excise it. Now you can see the superior facet. This is the ligamentum flavum. You excise the inferior border of the lamina till you can see the ligamentum flavum top edge, and then you start resecting the flavum gradually with a blunt hook till you see the dural sac. Once you see the dural sac, you'll see the nerve root lateral to it. Dissect the nerve root laterally all the way down At this point, there are constant epidural veins which you can easily see and coagulate. They are especially there along the pedicle wall. You will have to remove this inferior facet, the superior facet of the lower vertebra, which was still excised. You will have to remove the upper third of that facet as it is being removed right now. You remove it till you reach the superior border of the pedicle. Because once you have removed that much, that means the disc space is clearly exposed. This is the superior nerve root. That is the nerve root, exiting nerve root from the vertebra above. This has to be dissected. I put in a patty along that nerve root to push it further up. I use 3 patties. One patty goes into the spinal canal at the axilla of the nerve root above. One patty goes laterally so that the lateral part of that nerve root gets dissected and is pushed upwards, and one patty goes inferiorly along the nerve root, which is traversing over there. Then you make a generous annulotomy and start removing the disc. There are a number of instruments available which are such as disc shavers like this, which help you to break the disc and cut it out. So you use that. Be very gentle. Go from the posterolateral approach. You can see that there is so much space that you don't even need to retract the dural sac. I usually get my assistant to put a dura dissector over there, not to retract, but more as a protection for the dural sac in case my instrument slips.
So at this stage, while you're doing this, there is no rod placed on the other side. Do you think that makes any difference in
my PPT? I said that I would prefer to put the rod first on the opposite side, distract and fix it so that this type of abnormal mobility doesn't occur. So you keep on.
If you're going on increasing, sir, when do you know which is the end point and you should stop at this stage?
Point in time when you start moving and you hear a little bit of scraping sound, that is the time when I stop. I used to in the past do a lot of this very aggressive curating, and that resulted in cage subsidence. I'm not happy to do much of curating now. I do far lesser curating than I used to do in the past. Having done an adequate discectomy, you give a thorough disc space wash so that any loose fragments will come out. Now is the time to put in to template it. So you template it, put in a template, and the trial cage is the one which is appropriate, is the one which doesn't get pulled out easily once it's locked into the disc space. Having done the templating, I now put bone graft. There are funnels available, or you can use a 1 cc, 2 cc syringe to inject the bone graft which is meshed into the disc space. I use a bone graft punch to make sure that the graft lies along the anterior annulus all across the disc space. And then finally you put in your cage. The cage is put in so that the serrated margins are towards the end plate. You protect your dural sac. I'm not happy with this. I would always protect the dural sac with a dura dissector so that I don't slip and injure it. It is not that you don't have space, but your hands may slip and you may fall. The cage should be inserted such that it is recessed 2 to 5 millimeters below the posterior margin of the vertebral body. Once you do that, then
you put the cage in without removing the patties while you're inserting the cage?
No, the patties were removed. See, there are no threads seen. So, having done that, now you finish the rest of your decompression. Make sure there is adequate room below the lamina above, lamina below. And over the top decompression was done over here. The rod is bent into a lordotic angle, and then it is placed in there loosely. Fix the lower caps, and both the screws on the lower screws are tightened, and then the upper screws are compression is applied across the rods on both sides so as to load the disc. So just to show you a little bit of the specific part, this is a short 2-minute video.
Starts after all the screws are.
So this is the distraction applied.
Distraction from the side.
Now you start with your T-lift procedure. See the amount of space which is there laterally.
The preparation of the superior part of the inferior head blade starts with proper excision of the osteophyte.
Yeah, but Satyan, I think your point was very valid. You should make sure that before you actually put in the cage, final cage, you must remove the patties, because sometimes the patties get entangled in the cage and they go into the disc space, and then they are very difficult to remove. So make sure you remove the patties before you put in the cage.
Great, great. Dr. Engalalika,
well dissected out and don't get entrapped into your cage.
Dr. Engalalika, do you have any questions, sir, for the or any comments on the T-lift technique?
There are one or two things.
As that is the main area of fusion.
One of the important
Zaveri sir, can you switch off the...
No, I don't know how to do it.
Into the disc space.
I have been doing T-lift all the time. It's not that I have not done T-lift, but I'm very comfortable. And if I can retain the particular amount of parts, I'm generally very happy. People believe that retracting the cord will produce damage.
As you can see, now it is being compressed.
I don't have so many patients who can be really counted as failures and create local adhesions, etc. We are very comfortable doing.
Any tricks about anything you would do differently, sir? Whatever we
I think
now you have to tell
everything that you have done is more or less on the same line. I would do. My colleagues sometimes they prefer to put the implants first, but I prefer to do decompression first.
I prefer
unless the area is grossly unstable, I would not put in the screws first. I would do the decompression first, because nothing comes in my way. It also tells me after I have done stabilization, if a particular area is going to create difficulty to the root, I would not know it. But if it's mobile, I would know how comfortable the root is after my decompression. Now, as I said earlier, I prefer to do stenotic decompressions to be done in a slightly lordotic position or symptom producing position, which I have found out prior to the surgery by examination.
Right.
What happens is in flexion, all the areas inside, the central canal, the lateral recess, everything gets opened out. So a stenotic patient, if you put him in a flexion and open up, you will feel, stenosis itna kharab nahi hai. This stenosis doesn't look too bad. And therefore, your decompression may tend to be lesser than adequate. You tend to lesser. Therefore, all those patients, I prefer to put them in neutral position. I have bolsters, what we call 4 poster bolsters. I put them, the lower thorax is free, the pectoral area is supported and iliac crest is supported. But the remaining area is free. It's a mild lordosis. If I need on the table, I use laminar distractor to produce local flexion for the ease of my working. So when I remove the laminar distractor, I know truly what has happened inside. And unless I am happy in that position, see, one has to learn to envisage this patient's alignment when he's functioning. Say, for example, he's going to stand on the bus stop or a railway platform, he's going to stand in certain amount of lordosis. So in lordosis, he's going to have complaints. And if he already says that I don't have trouble in sitting, when I stand up, I have problem. And if you operate him in flexion, probably you're not going to envisage his comfort or adequacy of decompression in that position.
I think we have run out of time. I should say.
Yeah. So we just you can stop sharing.
If there are any questions, we can take them rather than me continuing the presentation.
So you can take last question. One of the delegates is asking how to assess a complete decompression of the neural structure.
So that is very good question. I think the central canal decompression is very evident to you, because once you have done the laminectomy, you'll be able to see the dural sac bulging out. But be sure that at the upper end and the lower end of your decompression, you put in a Penfield 4 and gently between the lamina and the dural sac, and make sure that the lamina is not digging into the dural sac. If it is, you should do a little bit of undercutting of the lamina to make sure the central canal is adequately decompressed. In the lumbar spine at L4-5, L5-1, sometimes there is a large central disc or an osteophyte where you're not sure whether you've done an adequate decompression. I actually can use sometimes a finger onto the dural sac to make sure there is no central disc palpable. As far as the lateral recess decompression is concerned, once you understand the borders of the lateral recess, the anterior surface, so once you've removed all this, you will be able to feel the root very clearly, and you should be able to retract the nerve root very easily. So about 2 to 3 millimeters of retraction of the nerve root should be easily possible at the base of the nerve root. Then you put in, as I said earlier, you can take a Watson chain nerve root resector, you can use a Penfield 4, you can use a hook, and put it into the neural foramina. And usually, if you are able to easily pass it, that means the foraminal decompression is also adequate. So that is how we judge the adequacy of a decompression.
So there are two questions from our delegates. Dr. Hassan is asking, do you ever face any post-operative contralateral radiculopathy, and how do you prevent that? That is the first one. Can you take that first?
That's a very good question. Sometimes what happens, patients don't have a preoperative radiculopathy, but on MRI, you with radiculitis, as sir would say, and on MRI, you see a tight central canal with a tight L4-5 stenosis. So in such a patient, you end up doing an L4-5, L4 laminectomy, and you don't decompress only the painful side, you decompress the opposite side also. And when you decompress the opposite side, there is inflammation of the roots post-operatively, which can cause a little bit of radiculitis for a few days, but it does tend to settle down over a week or 10 days, nothing much to worry about here. But what you do face, especially in a T-lift procedure, is radiculitis on the same side. Often the disc space is reduced significantly. And when the disc space is reduced significantly, the exiting nerve root above is very close to where you are putting your cage from. And therefore, if you don't have enough space, there is a lot of irritation of the dorsal root ganglion of that nerve root. And that it is not the exiting, traversing root which is a problem in a teeth. It is the exiting root which is a problem. And causes paresthesias of that existing root and pain along that route. So at the end of a T-lift procedure, I normally use a gel foam which I soak in Kenacort and put it around that nerve root in order to relieve the pain.
One of the reasons
the same day and probably are gone home within 48 hours. Yes, sir, please.
One of the reasons could be sometimes after we put in the cage or a bone graft, we compress the screws together. We approximate them more, and we have found that especially if you have unilateral cage going on the opposite side, when you tighten, you have produced a nerve root stenosis or even stark compression at times.
Yes.
So one has to be careful about that. So when you try to compress it, the purpose of the compression is only to see that the cage doesn't back off. It's only for the stability of the cage, not for very tight holding. So just be careful when you're tightening that particular side.
Other thing you have to be careful about is that when you're compressing in an osteoporotic bone, the screw can actually break through the inferior pedicle, and that can irritate the nerve, and that can also cause problems. So be careful of that. Yes.
Last question, sir. I'll ask Dr. Engel Alikar and Zaveesan, if you want, you can add. Again from Dr. Hassan, is that he feels that the T-lift cage has a larger foot imprint and could lead to subsidence, and an O-lift has a smaller foot imprint and may not cause subsidence. Does that theory match your thinking at all?
No, on the contrary, the larger the foot
incidence, the lesser is the subsidence.
Larger the footprint, the larger the area, lesser is the subsidence. The subsidence occurs, like Gautam said, he doesn't scrape as badly as he used to scrape earlier, the end plate. If you happen to remove the hard part of the end plate and expose areas, especially in the middle of it, central area, especially if you remove the hard end plate, the soft end plate are going to sink.
And Satyan, actually, that is my problem with the expandable T-leaf cage. T-leaf cage, when it expands, has a polar fit. It does not have a. So what happens is the loading occurs only on that expanded part, and therefore the risk of subsidence is higher, according to me. And I don't like to use the expandable.
I have always seen all expandable cages sinking.
Yes. So one last question, sir, before we go on to the next topic. Again from Dr. Hassan, is it necessary to explore the exiting route always? Dr. Ingalalikar, sir.
Yes, always. I don't only do that. In a stenotic cases, I look at the upper route, I look at the lower route. I talked about the malleable bile duct probes. That malleability allows us to hook the thing almost like this and pass it through the upper foramen, pass it through the lower foramen, pass it through the concern foramen. And by straightening them out or gently curving, you can almost palpate 3 foramens through one fenestration.
Great.
And you can see what has happened adjacent, or if you've done multiple level. One of the reasons why I like to do decompression first and put the pedicle screws later on, I rarely find my screws cutting on the medial side because I can always palpate the medial margin and pass my screws accordingly.
Okay. Thank you, sir. Thank you. Over to Dheeraj. We'll go on to the next part where you're going to demonstrate the technique for lumbar pedicle screw and sacral screw insertion.
Satyan, Satyan, can I retire? I have some other commitment now.
Thank you, sir.
Will you please allow me? Thank you, everybody.
Thank you, sir.
Satyan, Gautam, Dheeraj, it's a wonderful session going on.
Thank you, sir.
I'm sure the delegates are going to be benefited by this.
Thank you. Thank you for your
all the best to all the delegates.
Thank you, sir. Yeah, so we can go ahead with the next talk on a video presentation on a sawbone for lumbar pedicle screw insertion technique. Yeah. So just to make orient my all the delegates, right side is the sacrum and left side of the screen is the upper lumbar vertebra. Okay. Can see before going to the technique, we just start with a brief anatomy. So this is the spinous process. You all must be aware. This is the inferior facet. This is superior facet and transverse process. So all these 4 structures one should be knowing before inserting the pedicle screw. So we use an intersection technique for lumbar pedicle screw insertion. So intersection is an intersection of 2 lines. So first one line is a vertical line which is going lateral aspect of the superior facet tangential to that, and another line is a horizontal line which is a mid transverse line. Okay. So we can follow the mid transverse line with the ball tip. You see here, this is a horizontal line, and another vertical line is a tangential line to the superior facet. So lateral to the superior facet, we draw another tangential line. And the meeting point of these 2 lines is the entry point for the lumbar pedicle screws. So I have shown here down below by drawing with a marker. So this is a mid transverse line, and another one is this is another tangential line to the superior facet. You can see the intersection point is the entry point for the lumbar pedicle screws. So there is another way of inserting the lumbar pedicle screws with a slightly medial entry. So which is the entry is slightly medial to the intersection technique. So in intersection technique, the standard entry is lateral to the superior facet, while the another accepted entry point is slightly medial. So just before, just below a millimeter below the superior facet can be the entry for the lumbar pedicle screw. the trajectory or the medial angulation in such cases, the medial angulation is slightly lesser than the intersection technique. Yeah. So you have to aware of the sagittal alignment as well as the coronal alignment of the lumbar spine. So for sagittal alignment, for putting the screw cranially or caudally, one has to be looking at the X-rays continuously, as well as the fluoroscopy continuously for checking the alignment. Also, while after before taking an incision, one have to put a vertical artery, a straight artery, just to check the trajectory of the pedicle screw for that particular vertebra to get the sagittal craniocondyle angulation. So for L3, usually it's straight because it is the apex of the sagittal of the convexity of the lumbar vertebra, while for L1, L2, it is slightly cranially angulated. The medial angulation for every vertebra, we add 5 degree for every level. For L1, we add 5 degree. We start from 5 degree. L2, we add another 5 degrees, 10. So L3, 15, L4, 20, and L5, 25 degrees. So this much medial angulation has to be given. And the craniocaudal angulation can be decided preoperatively, as well as one can see the orientation of the spinous process as well as the lamina. So this is what I was telling about. The entry is slightly medial in another standard entry, and the intersection technique, the entry is slightly lateral, and which is the most accepted technique. Okay, now we'll orient you with the instrument set. Yeah, so this is the instrument set we should be aware of before putting a lumbar pedicle screw. The right side first instrument is the entry out, just to make an opening for the entry. The second instrument is a straight Lenke probe. So the another next to that is a curved Lenke probe. The straight Lenke probe is a preferred probe for lumbar pedicle trajectory in a lumbar spine, while a curved and Lenke probe is preferred especially in dorsal spine. So the tip is slightly away from the spinal cord. We use a flexible ball tip filler to feel all the walls during the trajectory, formation of the trajectory, and tap of 4.5 and 5.5 for a 6.5 screw insertion has to be there. Yeah, so this is how we make an entry with the entry out. You can see at the intersection of the two lines, I am opening the cortical bone, and here we have to feel the bone below. So feeling a bone is extremely important in this case. If we are slightly lateral to the usual, and it may pass the anterior wall of the anterior cortex of the transverse process, and hence we can get a soft spot in such cases if we are more laterally. If we are more medially, we have to feel the bone as well. If we are not able to feel, there is a soft spot, so we might be feeling a soft spot medially, and there will be a giveaway there. So there are chances of a medial breach and neural element injury in such cases. So feeling at the time of making after making entry is extremely important. So here this is how we feel for the bone in the base. So after this, I will insert a Lenke probe. So you can see there are measurements how much the way we have to how much the depth we have to go. So we insert Lenke probes in two parts. So after the entry in the cortical bone has been made, we feel the bone down below. Then we use a straight Lenke owl twice. So first parts go 2 to 2.5 centimeters so that it just crosses the pedicle and reaches the vertebral body. And again at that time we feel the walls, all the walls. Reinsert after the trajectory is okay. We reinsert the Lenke owl again up to 4 centimeters if our accepted measurement of the pedicle screw is up to 5 millimeter extra. Suppose a 45 pedicle screw is to be inserted, we go up to 4 millimeter with a straight Lenke code. So my assistant is continuously telling me how much I am inside.
Keep the video running, Dheeraj.
Right, sorry. So this is approximately 2.5 centimeter I am already in. Now I am feeling all the walls here with the Lenke with a ball tip feeler, and this is a flexible ball tip feeler with a stout or a stiff ball tip feeler. You won't able to feel all the walls. Another tip here, I advise you to go deep and come out while feeling instead of pushing deep inside and trying to feel the walls. So go deep and come out and feel all the walls. So here all the walls are fine. Again, I am reinserting the Lenke probe. So this is approximately 35 to 40 millimeter. So again, I am filling all the walls, starting from medial, inferior, superior, lateral, as well as the anterior wall. So this is approximately 35 to 40 millimeter screw. And I have tapped the wall. So tapping is extremely important, and we have to tap if for a osteoporotic we have to tap 2 millimeter lesser than the size of the screws, and for a normal healthy bone we tap approximately 1 millimeter lesser. So for a 6.5 screw, in a normal adult with a healthy bone I will tap 5.5, but in an osteoporotic I will tap for 4.5 tap. Okay. After tap, we have to again try to feel for the walls because the trajectory has been widened up, and if there is any breach, we can pick up early. Yeah. So show what. So this is a screw. It's a dual-threaded 40 millimeter screw. What we have measured just now. The proximal more threaded part goes inside the pedicle, while the distal part goes inside the cancerous bone. So pedicle screw insertion always has to be with both hands. Left hand for a right-handed surgeon is to get the right trajectory, and while the right hand for a right-handed surgeon will be just allowing the screw to pass with a gentle rotation movement. So backward screwdriver just for final getting a right length and further tightening. So this is what after all the full screws have been inserted, we align with the screw, all the screws with the head adjuster. Insert appropriate rod after this, appropriately measured rod after this. You can so this screw is slightly insert on a slightly medial entry point. And this is the standard intersection technique which I have just demonstrated. So this is a lordotic rod. And never forget to final tighten all the knees. So this is a torque limiting screwdriver or 12 Newton torque. And if required, we can compress at the end. Yeah. Thank you.
Great, Dheeraj. Can you give us a little bit of indication before we go on to Abhilash's thoracic screws on what pointers you want to give anybody who is digging pedicle screws as to using two hands, as you said,
Yes.
is it only for your screw insertion or also for your awl and your pedicle
Yes,
finder?
yes. Very good question, Satyan. So every time in spine, I always try to do especially the critical steps with both of my hands. So one hand is guiding me and as acting as a counter to prevent further pushing or if there is a miss direction of the screw, it will avoid inserting it in too deeply. Also, I use the two hand principle also while doing while using my Carrison forceps or Carrison Ranger as well as my pituitary. So two hands in for a delicate spine surgery is extremely important. Otherwise, we can end up with some major complications.
Great, Lanchan. Srivastav sir, you have trained many budding spine surgeons. What is the commonest mistakes which people make when they start out during instrumentation?
Yeah, actually, the most important thing that each the bone model is different, but in a real patient, the anatomy might vary. So even the plain X-ray gives a lot of ideas. So pre-operatively, all these things should go in the mind of the operating surgeon. Okay, how this anatomy is different in this patient. So point of entry is extremely important. If you start in a different point which is not the center of the pedicle, there are high chances of perforation. So try to reach to that particular point which you have thought of, and then one should go inside the pedicle, and as very nicely described by Dr. Dheeraj, that try to palpate the walls nicely and go slowly. Let it remain supported with your other hand. It is a very basic principle of all spine surgeons that when you're doing the surgery, it should not go inside suddenly and cause some complications. So this is extremely important. It was discussed earlier also that you try to be little lateral and don't violate the facet joint. That is extremely important and that is the cause which is nowadays being told about the adjacent segment degeneration. So one should not try to damage the proximal facet where your implant will end. Don't keep the rod too excessive long, which is causing impingement of the proximal facet. And this medial angulation is important. So your trajectory is right. The length of the screw is adequate, and the size of the screw is also extremely important. You should not try to put a smaller diameter screw in a large pedicle. It will be like a rope in the well, and there will be fast failure of that fixation. So these points are important, and it was very nicely told by Dr. Dheeraj.
Great. So you brought up some very good points. I'll just reiterate, always study the anatomy of the patient before you venture into surgery. Make sure you know where you're putting the screws so that you can plan it out in your head beforehand. Always follow the basic steps, two hands, and go in step by step. No shortcuts to be made. Proper size of screw, adequate size, not too long, not too short, not too big, thick, not too narrow. Adequate size, right direction. Even the rod size has to be correct, not too long, of course, not too short either. And follow the steps, go step by step, and you'll be fine. So we'll go on to the next part, which is insertion of thoracic screws, which would be a little more the next step after lumbar. And over to Abhilash. Abhilash, can you demonstrate, show your video on demonstration of how to insert a thoracic screw, pedicle screw?
Yeah, good morning all. I request the team to start my recorded video. Good morning all.
thoracic pedicle screws. Let's dive right in. It's a useful skill for a spine surgeon to master. There is a learning curve associated with this, which is why we attend basic spine workshops, sawbone workshops, cadaveric dissections, fellowships before we insert our first screw. Different techniques have been described, ranging from image-guided, that is C-arm guided AP lateral screw insertions, to the modern state-of-art navigation-assisted screws. What I will be describing today is the freehand technique, which relies on anatomic knowledge and that particular skill which separates us orthopedic surgeons from lesser mortals, that is the feel of the bone. So, very quickly, across different levels of the thoracic spine, you have vasculature in the front, lungs and pleura anterolaterally, and ribs lying lateral to the pedicle. The spinal cord is ensconced with by the thoracic spine. It's in very close proximity with the bone. Now, when we think about entry point of the pedicle screw, you've all seen these really, really confusing, busy diagrams, and which makes you wonder, is putting a thoracic pedicle such a daunting task? So what I will be attempting today is to show you a technique which ensures that your screw is in the pedicle at least 95% of times. So quickly, on a bone model, you divide the facet joint into lateral 1/3 and medial 2/3, drop a vertical line. Draw a line along the superior ridge of the transverse process where it meets the lamina. The intersection of these two lines forms the entry point, which corresponds to a straightforward trajectory of pedicle screws in the thoracic spine. It can be easily appreciated in the coronal section, where you divide it into lateral 1/3, medial 2/3 of the facet joint, and the superior ridge of the TP where it meets the lamina. That intersection forms your entry point. The medial lateral angulation is around 15 to 20 degrees in the thoracic spine. At T1, T2, T3, you would want to go at least 25 to 30 degrees medial. I've made a sawbone video because that is what we would have done had it been a proper physical conference. So this is the spinous process. This is the transverse process. This is the inferior facet. This is the superior articulating facet. Now, while you subperiosteally dissect, you go along the spinous process. Avoid getting into the interlaminar space. You dissect it inferiorly into the inferior facet, laterally across the lamina, up to the vertical stub of the transverse process. And you end proximally in the lateral aspect of the superior articulating facet and the medial aspect of the superior articulating facet. Please make note, as you can see in a sawbone, your superior articulating facet is never completely seen. It is covered by the inferior articulating facet of the superior vertebra. So basically what you are going to expose in your surgery is the entire facet joint. So it is very imperative to expose the lateral aspect of the joint, to divide it into medial 2/3 and lateral 1/3. And you drop that superior ridge of the TP where it meets the lamina in this line. That will be your entry point. You decorticate it using a high-speed burr or a ronger. If you are right there, there will be a blush, a pedicle blush that you can appreciate. Now, as I mentioned, 15 to 20 degrees mediolateral angulation, and superior inferior angulation is 90 degrees to the plane of the lamina. You can use a 90-degree ball tip probe. You can place it on the lamina to get your direction for a superior inferior angulation. This is a special Lenke probe, which is curved distally. It's very easy to discern this from a straight probe. For the purpose of this video, I shall be demonstrating the gear shift technique. You start with the concavity facing laterally, proceed down the prepared entry point. You go to avoid the medial breach of the pedicle. If there is no sudden give way, rotate it 180 degrees so that the concavity faces medially, and you can then safely go into the body up to 30 mm. Always, always, always sound the pedicle, feel for the medial, lateral, superior, inferior, anterior borders. After that, I under tap by 1 millimeter. I use a tap for easy passage of screws, and any sort of misalignment in the trajectory gets corrected as soon as the threads of the tap grab the cortices of the pedicle. Again, I'll stress on the importance of sounding the pedicle, especially in the proximal part, where you have to feel all the walls, the pedicle and distally for the anterior wall. An adequate size screw is then inserted. I put 4.5 millimeter screws at T1, T2, T3. Rest of the spine you can safely put 5.5 millimeter screws. I put 6.5 millimeter screws at 10, 11 and 12. The same technique which I showed you on the sawbone, this is as it happens in an actual dissection. This is a video courtesy Dr. Dheeraj Sonawne. Now the facet is beautifully exposed here. This is a lateral extent. So you divide the entire facet joint into lateral third and medial 2/3, where this line and the transverse process where it merges into the lamina superior ridge, this becomes your entry point, which has been shown on the opposite side. So beautiful demonstration of the gear shift technique. Curve faces laterally, then the curve facing medially. Always remember, superior inferior angulation is 90 degrees to the plane of the lamina. You can see brisk pedicle bleeding there. This is the most important step to avoid any breaches. Feel. Proximal part of the pedicle for the walls of the pedicle, distally for an anterior breach. Under tap by 1 millimeter, easy passage of screws and correction of any misalignment. Again, medial, lateral, superior, inferior, and anterior walls. This is the single most important step in detecting any breaches. So there are complications associated, as you may have imagined. Medial breach can cause cord injury, inferior breach can cause root injury, and anterior breach can cause vascular injury. So in summary, going through the steps again, you have to meticulously dissect the spine to delineate your anatomic landmarks. Remember, lateral 1/3, medial 2/3 junction and the transverse process lamina junction. Intersection of these two lines forms your entry point. Use your gear shift technique to avoid any medial breaches. Always sound the pedicle. Under tap by 1 millimeters. Sound the pedicle again after tapping. Insert the screw and always check that screw with shoots. Remember, 15 to 20 degree mediolateral angulation, and superiorly inferior is perpendicular to the plane of the lamina. Thank you so much.
Thank you, Abhilash, for a smooth presentation. Dheeraj, I want to ask you, between these two types of screws, which one do you prefer, and or is there any difference at all?
Okay, so there are two types of screws for thoracic pedicle screws insertion. One is a standard trajectory, and another one is anatomical screws. So the standard pedicle screws go parallel to the anklet in sagittal plane, while the anatomical screws go along the pedicle anatomy and directed slightly inferiorly. The advantage of the anatomical screw is 5 millimeter longer, and it is biomechanically more stronger. So I usually prefer standard screws with a described entry point with an intersection technique, what just Abhilash has demonstrated. The anatomical screw I preferred to insert as a salvage method if the standard screw is not already in misdirected somehow. Yeah.
Abhilash, do you always expose the facet joint when you put in the thoracic screws?
Yes, except for the proximal screw, I always dissect out the facet all the way to the lateral extent. That gives you a perfect way of making your lateral 1/3, medial 2/3 discerning. Once you put all the screws, when you're going to the proximal screw, you have fairly a good idea as to how your screws are going in harmony. So there you can expose only the lateral aspect of the facet without burning the capsule. And there you again just follow the ridge of the transverse process. And then by looking at the screws which you've inserted inferiorly, you can get a good judgment as to where you are. So except for the proximal screw, I usually expose the entire facet.
Nice. So Srivastav sir, exposing the facet, does that help you in any way to determine the angulation? Is that something you use?
Actually, as nicely mentioned by Dr. Abhilash, the laminae gives you good idea. You know what should be the direction of it. You need not open the whole thing. And gradually, if you have any doubt, one should not hesitate in opening the normal anatomy to see. Okay, if you had any doubt. Otherwise, as you grow, you learn how to do with the minimal opening, and one is able to do it. One point I would like to make, that when you are inserting a screw, the later 1/3 of it, you should try to nibble the outer cortex of the transverse process, because that has a tendency to push the screw in more medially. It pushes the thing more medially. So that time, sometime in osteoporotic bone, one can find problem that he has perforated, in that way. So outer cortex, and that also can be used as a graft. So the outer cortex, so you find that your screws are nicely sitting there. So that is important, more so in adult young patient. So that cortex is quite thick, and that might push your screw in the mal direction.
Yes, sir.
Yeah,
Sir,
that's
I
a very
have a
good
recent
point.
experience.
Always, so when I'm putting my screws, so that the tulip sits properly. Once I've made my entry points, tap the pedicle before inserting the screw, always take a ronger, nibble out the transverse process. It does not matter. And then you put your screw. So that gives you a good play even for your tulips.
Yeah.
Yes, sir.
Abhilash, there's
It
one
is
question
important for
from,
both the scenario. In a stronger bone, the transverse process might still push because the transverse process is stronger, and it might push the screw slightly medially and compress the cord. Also, in osteoporotic bone, since the bone is softer, still it might be pushed. The screw might be pushed medially. So always
Well,
it's better to remove the TP.
take a few delegate questions. But Dr. Ronak Milton wants to know about the screw diameters, which you use at different levels usually. So I'll ask Abhilash your take on that. Of course, it depends on the size of the patient and the size of the pedicle, but in general, what is the screw
If you
diameter?
want to go by rule of thumb, T1, T2, T3, that's the proximal thoracic spine. I would put a 4.5 millimeters screw. This is just a rule of thumb. This all again depends.
4.5 to 5.5 at that level. Okay.
Below T3, you can safely go 5.5 mm screws.
In an adult,
Nearer
yeah.
to the thoracolumbar junction, I basically tend to put those bigger 6.5 mm screws. So
6.5.
10, 11, 12, you can safely put the huge big pedicles, which can easily accommodate your screws. This is just a general rule of thumb.
And in the Dheeraj going on in the lumbar spine, usually 6 mm, and in the sacrum.
Yes. So always lumbar spine, most of the pedicles are in a normal individual. So they are easily accepting 6.5 screws. Even in L5, most of the time we try to put a slightly bigger screw if we can, up to 7 millimeter.
Dr. Hassan has asked about the acceptable rod length beyond a screw head. Srivastav sir, we mentioned that the rod length should not be too much, but he wants to know how much should it be.
It is better to keep always at least a centimeter.
Minimum 1 centimeter.
5 millimeter to centimeter. Most problem you can face if you have a polyaxial screw. Sometime when you are measuring the length, the head of the polyaxial screw in this direction, and later on while tightening it goes more, cephalate, and you find now your screw has your length of the rod has become less, which should not happen. So I think when you are taking the measurement, it is always better to shift the proximal part of the rod in such a way that your tulip you have already kept in cephalate direction, you take the measurement, and reverse on the caudal area. Now, one more thing about the direction you are asking. Medial and lateral is okay. What about the proximal and distal? Usually, if you see the dorsal spine, it is kyphotic. So your proximal vertebrae will be slightly, it will be caudal direction, and the distal thoracic vertebrae will be slightly in the cephalic direction. It will change when you are treating or you are pushing a screw in a deformed spine. So all these things has to be taken into consideration. What is the alignment of the spinal column at that area?
Great. So, sir, I'd like to summarize our session here. We have about the pedicle screws. Very important points which were made was to understand the anatomy of the patient before you get in, so that you know what you are dealing with. All the planning of your direction, mediolateral, cordocephalad, size of the screw, everything has to be made in your mind before you go in and start doing the surgery. Do follow the steps, no shortcuts. Do your two-hand technique, do them step by step, and you will be fine. So I want to thank all our panelists. Srivastav sir, thank you for being there with us continuously. Dheeraj, my co-host here, and Abhilash, and also Dr. Ingalalekar, Dr. Zaveri, who have just popped out. Thank you, everyone. And over to you, Uday.
So thank you, Satyen, Dheeraj, and all the panelists for warming the delegates up for the entire day. So few announcements for the delegates. The faculty as well as the delegates, do please visit the trade stalls and have an interactive session with them as well whenever you get time throughout the day. The delegates, we encourage them to ask as many questions as possible on the chat box, so that let's keep this thing interactive rather than a one-way talk. The certificates for the program shall be uploaded at the last day, 20th. So just make sure that you stick around and enjoy the feast. We'll be starting strictly by 12:30 for the next session, and you don't want to miss that after a great start by Satyen and Dheeraj. Everything that you want to know about cervical spine surgery is going to be there in the next session. So please make sure that you take a break of 10 minutes and join us back again by 12:25. Take a moment's break, free your legs, free your arms, come back. And I tell you, you don't want to miss the next section. Okay. So see you around at 12:25. We have some filler slides for you. For those who have recently joined, they're going to show you how to navigate through the platform, the virtual platform that we have. And that will be playing continuously throughout. If you have questions, we all are there for you. So meet you at 12:25. The next session starts sharply at 12:30. So don't delay it. We are going to stick strictly to the time. And 12:30, we start with the cervical spine workshop. Thank you, all of you. Please do join immediately at 12:25.
Thank you.
Very nice first session.
Thank you.
Thank you, sir. So the technical team, can they play the filler slides for the delegates?
Sure, sir.
Hi friends, I'm Ram Chadda. I welcome you for the Bombay Spine Society Annual Conference, BSSCON, 19th and 20th of December 2020. We are having 4 fantastic pre-conference workshops a week earlier on the 13th of December. I want each one of you to take your time out and join us for this one-of-a-kind mega virtual event. We are sure you'll have so much to contribute. The interaction, the international faculty, excellent Indian faculty, workshops which are going to help you evolve with your day-to-day practice, and finally, the culmination in a state-of-the-art congress, a meeting where every unanswered question of yours will have a solution. Please join us. Bombay Spine Society welcomes you. We look forward to having you in large numbers, being a part of BSSCON, Bombay Spine Society Annual Conference this year, 13th, 19th and 20th of December.
Please do join us on 13th December for a very informative and well-planned spine workshop, followed by a very well-structured main conference on 19th and 20th December, where you will be able to interact with galaxy of distinguished spine surgeons. Do join us. BSS will be eagerly waiting for all of you.
Welcome to BSSCON 2020, the first annual meeting of the Bombay Spine Society. The program on 19th and 20th will be highly interactive. We have an excellent academic program with eminent faculty from both India and across the globe sharing their knowledge and experiences with us. We look forward to interacting and welcoming you on December 19th and 20th. Do register for BSSCON 2020.
BSSCON brings to your homes the who's who in spine surgery from across the world at a mere $1,000. Not only that, you get to attend the pre-conference workshop on the 13th with the meeting on the 19th and 20th of December, which is going to be a star-studded, absolutely top-of-the-heap weekend for you. So be there or be square. See you soon.
We are proud to announce that we are organizing our first annual conference. This is history in making. So this will be held on 19th and 20th of December 2020 under the leadership of one and only Dr. Vishal Kundani, under the stewardship of Dr. Srivastav. I welcome you all to please attend the conference. So please register as soon as possible and enjoy the recipes of the conference. Thank you.
Please join this conference and enjoy the academic feast put to you, not just from Bombay, but also from our national as well as international faculty. See you there.
Welcome to BSSCON 2020. Let the festivity begin.
So 5 more minutes to go, delegates, for the cervical spine workshop. We are going to discuss all the complex stuff that you thought was complex, but I'm sure the faculty is going to make it look very simple and very straightforward for most of it. Again, some announcement. Please make this as an interactive session. Ask as many questions as you can. Clear all your doubts by typing in the questions in the chat box. We guarantee you that each one of your questions will be answered by our esteemed faculty. We won't leave any stone unturned in driving home the complete nitty-gritties of the cervical spine or any of the workshops that we have. In exactly 5 minutes, we'll be starting our cervical spine workshop. If you are fresh from the break, do join us at 12:30 sharp. Meanwhile, do visit the trade stalls at least once and interact with the trade personnel. And let's start this session at 12:30. Please start joining the platform, delegates, for all the delegates. If you have any queries, please get in touch with either me or the VAMA guys. The joining link, you just have to put in your email for the delegates. That's about it. Any queries you have, any difficulties for joining the platform, please let us know. Two-minute countdown for the cervical spine workshop. Please do log in. All the faculty and all the Bombay Spine Society faculty and the moderators are ready with the program. Do join in, do log in, do participate interactively, ask in your questions. In exactly 2 minutes, we shall be starting the program. So welcome all the delegates. It's exactly 12:30. We're going to start the next session on cervical spine workshop, anterior, posterior instrumentation, everything. I do welcome my moderator for the session, Dr. Sandeep Sonane, Dr. Ashok Rathod, to take the proceedings from here, and please welcome the panelists and your faculty.
Thank you, Uday. Thank you very much for giving us an opportunity to conduct this particular session. And a very good afternoon to all of you. Moving on to the second workshop of the day, that is on cervical spine instrumentation. We all know that cervical spine is a very critical area of the spine where the margin of error in surgical procedures is very less. And here there's an attempt to discuss all the tips and tricks which are important in carrying out these surgical procedures. So this workshop is purely on cervical spine instrumentation. So we would request all the delegates to ask us all the questions which are pertaining to this particular instrumentation techniques. The rest of the things like decision making and everything can be discussed as we go along next week in the main conference. So let me invite my co-panelists over here, Dr. Ketan Badani, Dr. Ashok Rathod, Dr. Samir Darvi, Dr. Mihir Bapat, Dr. Kshitij Chaudhary, Dr. Tushar Rathod, and Dr. Ayush Sharma. And before we move on to the surgical techniques, it's important to understand the anatomy in a nutshell. So we have Dr. Kshitij Chaudhary, who would be discussing the critical anatomical landmarks or anatomical issues which are involved in carrying out these procedures safely. So without much ado, can I have the first talk by Dr. Kshitij Chaudhary to start?
Thank you very much, and I'm honored to be a part of this pre-conference workshop for the first ever virtual Bombay Spine Society's annual meeting. And my task today is to show you applied anatomy for instrumentation of the cervical spine. And we are predominantly going to focus on posterior instrumentation, and I hope in this next 15 minutes I'm able to give you an introduction for all the talks that are going to follow after me. So let's begin with the occipital region. So the surgical anatomy of the occipital bone, you want to know that there are three nuchal lines: the supreme, the superior, and the inferior. Supreme is not so prominent. These nuchal lines converge on the external occipital protuberance, and there is a midline crest that is running downwards from the external occipital protuberance. So if you flip the bone around, you will find that the external occipital protuberance corresponds to the confluence of the sinuses, and the superior.
Can everybody see the screen?
Yeah, we can't see the screen. Can you allow me to share? Because because the Finder window is shared.
Right.
So is it? Are you
and
allowing
Dr.
me
Kshitij
to
Chaudhary
share?
be allowed screen sharing?
Okay. All right. So let me start again.
Right.
Thank you very much. And so the surgical anatomy of the occipital bone, you want to know that there are three nuchal lines: the supreme, the superior, and the inferior. Supreme is not so prominent. These nuchal lines converge on the external occipital protuberance, and there is a midline crest that is running downwards from the external occipital protuberance. So if you flip the bone around, you will find that the external occipital protuberance corresponds to the confluence of the sinuses, and the superior nuchal line corresponds to the transverse sinus. So here you can see the transverse sinus and the confluence of the sinus that corresponds to the superior nuchal line and the external occipital protuberance, and you will appreciate that your instrumentation has to stay below this vascular structures so that you don't injure them with your screws. If you shine a light inside the skull, you will find that the thickest portion of the occipital bone is around the external occipital protuberance. So the area that is best suited for putting screws is this inverted triangular area that is below the superior nuchal line, in this region more or less closer to the midline crest. So here in this case example, you can see that this is the external occipital protuberance and this is the midline crest. So your instrumentation is going to be in an inverted triangle below the external occipital protuberance or the superior nuchal line in this fashion. This is a keel plate where the screws go in the midline or the keel of the occiput. Now there are other variations of the occipital plate. You can have screws that are placed laterally, but laterally the occipital bone thickness is quite thin, and to make these two constructs equivalent, you'll have to place 3 screws on either plate on either side to make it equivalent to a midline plate, which can be strong enough if you put 3 screws in the midline. Bicortical screws have much more strength than unicortical screws, and at the external occipital protuberance, you can, because of its thickness, you can put a unicortical screw and have the same strength. Coming to the C1 or the atlas vertebra, so when you are dissecting on the posterior arch, trying to expose the lateral mass, don't dissect too far laterally on the superior border of the C1 arch, because you will hit the vertebral artery beyond 12 to 15 millimeters. So the entry point of the lateral mass is at the base of the posterior arch in the middle of the lateral mass like this. And sometimes you have to sacrifice the C2 ganglion to visualize this area, but mind you, there is a lot of venous plexus around this area, and you can have a torrential bleeding here if you are not careful. Another peculiar anatomy here is this overhang of the posterior arch, which can force your trajectory of C1 screw to go upwards like this. So if you put a screw like this, you are more likely to violate the OC1 joint because it dips down like this. So you might have to burr down this area to make sure that your screw trajectory is pointed towards the lower part of the anterior tubercle like this. You can see the anterior part of the C1 lateral mass is posterior to the anterior most part of the anterior tubercle by about 7 millimeters. So when you are putting a screw, you want to stop short of the anterior arch, because if you go all the way anteriorly, your screw is going to come out somewhere here, and you have the internal carotid and the hypoglossal nerve right in front of the lateral mass somewhere here, a little laterally. So the direction of the lateral mass screw also is a little bit medial, especially because this screw is stronger if you have a bicortical purchase. So alternative entry points are such a kind of entry point where some try to notch the posterior arch like this so that your entry point shifts a little bit superior, or you can pass a screw directly through the posterior arch like this, where you can see on this x-ray the screw is going through the posterior arch directly into the lateral mass. For this you require the posterior arch to be of sufficient thickness. So if you put a screw directly through the C1 arch like this, you can avoid dissecting the venous plexus and putting your screw close to the C2 ganglion. But you have to be careful of this anomaly when you are putting such kind of a screw. This is the ponticulus posticus, and it's seen about 15% of patients. You can easily identify this as an arcuate foramen like this. During dissection, have not anticipated this anomaly, and you want to put a posterior arch screw somewhere here in the middle. The screw directly will go through the vertebral artery if you don't account for this anomaly. The C2 or the axis vertebra again is a unique vertebra. What is more important here in the posterior instrumentation is this region. The superior articular facet is not exactly over the inferior articular facet as it is there in the rest of the cervical spine. There is an offset here which makes this area of bone elongated, and that's called the pars of the C2, where many of the screws are inserted. People use these pedicle and pars of C2 terminology interchangeably. By definition, pedicle is this small area of the C2, and pars is the part of bone that is between the superior facet and the inferior facet. That's why it's called the pars interarticularis. So this is a pedicle screw, the screw that goes across the pars and reaches the pedicle of the C2 vertebra. Pars screw, as the name suggests, is in the pars, which is also a shorter transarticular screw. And a laminar screw goes into the lamina of C2. As you know, the C2 lamina is quite thick and the largest lamina in the cervical spine. The problem with the pars of the C2 is that the superior articular facet is deeply notched by the vertebral artery sometimes, and the notching has quite a bit of variation, ranging from minimal to such deep notching, which makes the putting of screws in this region quite dangerous. So if you have a very high riding vertebral artery like this, which reaches very close to the superior articular facet, then putting screws here can sometimes be dangerous. So there are two measurements here that you have to remember: the internal height, which is the distance of the vertebral artery cave from the top of the superior facet, and the isthmus height or the pars width, that is the distance of the vertebral artery cave from the dorsal surface of the pars interarticularis. So if you have a vertebral artery cave that is too tall or too high, then you can still pass a transarticular screw like this because there is room behind. But if you have a vertebral artery cave that is too posterior, this will make the isthmus height smaller or the pars width smaller, and in these cases the transarticular screws can be a dangerous screw if there is not adequate room to negotiate the screw through the pars. To identify these anomalies, you need to do multiplanar reconstructions either yourself using softwares like Horos or Osirix, or sit with a radiologist in the department to get these multiplanar cuts which are in line of the screw trajectory. So like this, you can see here you are getting a plane where you are able to pass this screw without interrupting the vertebral artery cave in this first example. But in the second example, you can see that the vertebral artery cave is in the path of your screw before it reaches the lateral mass of C1. So planning is extremely important. So sometimes the vertebral artery notching not only is too high, but it can be too medial as well, like you can see in these pictures. And in these cases, the C2 pedicle screw also can sometimes be dangerous. So that for that also you should be able to do multiplanar reconstructions pre-operatively on CT scan to make sure that you have adequate room in that path of the screw to place it safely without injuring the vertebral artery. And many people think that the par screw is a safer screw, but par screw is just a short transarticular screw. So par screw is a safe screw as long as you stop short of the vertebral artery cave. And if you stop short of the vertebral artery cave and don't reach under the superior facet, that screw is going to be a 14 millimeter or a 12 millimeter screw, which is a very weak and small screw. So that's why more a preferred instrumentation, if your pedicle screw is not possible, is a laminar screw, where invariably the C2 lamina is thick enough to accept a good screw in this particular direction. The course of the vertebral artery is important to understand. We have already seen the V1 segment can have such anomalies such as high riding vertebral artery. The V2 and V3 segment can also have anomalies like this, and there is an enormous variation here, and it's important to recognize this, because if you don't recognize this pre-op on a CT angiogram, you can get into real trouble. So this is an example of a persistent first intersegmental artery where the artery is going underneath the arch of C1. Here you have a fenestrated VA where it is going below as well as above the C1 arch. And here you have an anomalous origin of the pica, where if you injure this artery underneath the C1 arch, you can get a cerebellar infarct or a pica syndrome. In this case example here, the surgeons recognize the persistent first intersegmental artery and have skipped the area completely. But this patient was not so lucky, where they did not do a CT angiogram pre-op. And here you can notice that the foramen transversarium is very rudimentary and there is a deep notching here. This anomaly, if you ever see on an axial cut, you can imagine the vertebral artery is here, and instead of going through the foramen transversarium is actually going inside the C1 ring rather than going through the foramen transversarium. So choose wisely. Some screws are risky with respect to the vertebral artery or anatomy. Some screws are safer, and you have to know pre-operative planning on CT scans, and sometimes we do get 3D printed models to help us make this assessment. Coming to lateral mass screws. So lateral mass screws, here you want to know the anterior relationship of the lateral mass. Here you can see the nerve root is closely approximated to the anterior part of the lateral mass, somewhere in the middle of the lateral mass, and the vertebral artery is in front of it. So if you look at it more obliquely, there is an area here that is a safe area for your screw to come out if you want to do a bicortical lateral mass screw. So this area is safe. If you put a more horizontal trajectory, it might reach the nerve root if it is bicortical. So in the coronal view, the vertebral artery's relationship with the lateral mass is in the medial half of the lateral mass, way anteriorly. So your screw should be directed outwards for that reason. If you direct the screws straight or inwards and they are long enough, they are either going to hit the nerve root or the vertebral artery. So if you look at the surface anatomy, the entry points for these screws are you have to divide the lateral mass into 4 equal quadrants, and the entry point is 2 millimeters medial and inferior to the center of the lateral mass, and the direction of this screw is directed outwards and upwards like this towards that safe area which I showed you a few slides before. On the lateral view, the trajectory of the screw is parallel to the facet joint like this. So this trajectory can be easily obtained if you touch your drill bit to the inferior spinous process. Automatically you will go in the right direction. Coming to the C7 lateral mass, is here in this diagram you can see that the C1 lateral mass is so much thinner than the main C5 or C4 lateral mass areas. So the fixation in C7 with a lateral mass is quite poor, and most of the time C7 is the lower instrumented vertebra of your cervical instrumentation or the upper instrumented vertebra of your upper thoracic instrumentation. So the ends of your constructs have to be strong. So C7 ideally, if you want to end your instrumentation, there should be a pedicle screw, and the pedicle screw in C7 is safer because here you can notice that the vertebral artery is not in the transversarium foramen of the C7 as it is at the upper level. The problem here for the C7 pedicle screw is that the entry point of this is quite variable. C7 vertebra is a transitional vertebra. Some C7 vertebrae look more like thoracic vertebra, while some look more like cervical vertebra. Some may have an additional rib or something. So this anatomy in this region is kind of in transition and variable. Most of the time the entry point is about 2 millimeters below this joint line, somewhere in the middle, and it is directed quite a bit inwards, about 25 to 30 degrees convergent angle. Because the entry point is variable and you want to get a best screw at the end of your construct, you don't want to do trial and error here, and most of the time to pass C7 pedicle screw, I do a laminoforaminotomy, feel the medial border and the superior border, and take my entry point and pass the screw. Sometimes you can get a good true AP picture if you have thought about this beforehand and make sure that the table or your Mayfield or your tongs are not coming in your way, and you can identify the pedicles like this and put the screw in the AP, because you're not going to get a lateral view many times because of the shoulder overlap for a C7 pedicle screw. And lastly, when you are putting C7 pedicle screws along with C6 lateral mass screws, these tulips are so close to each other that they can touch each other. I am skipping C6 lateral mass screw and going to C5. That's about it. Thank you very much.
So thank you, Kshitish. Thank you very much for a very informative talk. So before we move on to the first talk in the surgical techniques by Dr. Samil Darvi, just a question. Can you just tell us what is the difference in, because there's a lot of confusion regarding this, what is the difference between the entry point in a par screw, a transarticular screw, and a pedicle screw?
So the par screw entry point is the same as the transarticular screw. So the entry point for the par screw or the transarticular screw, par screw, there is a little variation. You can choose. Transarticular screw is a retrograde kind of a fashion. You take an entry point which is at the just at the inferior border of the inferior facet, but the entry point is decided by the path in the C2 pars where it is going, which you want to project forward towards the lateral mass. Whereas pars, there is a little bit variation. You can get a really short screw in the pars if you stop short of the vertebral artery cave. But for a C2 pedicle screw, the entry point is on the superior border of the lamina. If you take a line drawn from the superior border, and then you again want to draw the medial border of the pedicle, and then retrograde fashion, you want to see
where it intersects that area and take. So the key point to understand for these screws is that these entry points are not fixed because the anatomy is variable. So the entry points are completely visual for the C2 pedicle screw. And on the lateral mass screw, on the lateral view, it is based on the fluoroscopy. And on the coronal view, it is based on what your intraoperatively medial wall of the pedicle that you are able to visualize. So you have to take an entry point according to what your intraoperative findings are.
Okay. Thank you very much. So we now move on to the next talk, the first one for the surgical techniques by Dr. Samir Dalvi, and it will be moderated by Dr. Tushar Rathod. So can we have the first talk, please?
Good morning, and I'm here to tell you about the anterior fusion in the cervical spine, and I'm going to straight away start my presentation. Anterior cervical discectomy is truly sort of a gold standard operation, and it is first described by Smith, Robinson, and Cloward in 1958. And all of us would be doing it. The question always arises: what are we going to do to fill in the gap? Basically, it's a direct decompression. It's visualization of the nerve root. There's no recurrence, and you get a good foraminal decompression. The problem is, what do we do inside? We can put in a bone graft alone, which was really what they all did in the beginning. But then there are newer things. There's a cage. You can put a plate to support your bone graft. You have cage screw sort of devices like the 0P. In fact, you can also put nothing. That works as well. And then you have the disc arthroplasty. The bone graft is simple. It's cheap. You can get a good chunk from the iliac crest, and the fusion is almost guaranteed. But there is this question of a bit of donor morbidity, and there have been cases of extrusion and collapse if it's not done properly. And the patient, of course, needs to be immobilized. The other option then was to put in a plate. The plate actually has as good as 100% fusion, and there was no extrusion, no collapse, nothing. But of course, there was a cost, and there was a prominence, and many patients complain of dysphagia following that, as well as an adjacent level problems because of the plate prominence. If you look at plating versus no plating, in this paper, the fusion was 100% with plating, but the clinical outcomes were, there was no difference, and there was more blood loss in the plating. The double level plating, of course, is better because again, the fusion is 100% versus 75%. Those, again, the clinical results were the same. But if it's not plated, there were incidences of graft collapse and kyphosis. That brings me to my favorite, which is the cage alone. Here, there is no collapse, where the cage can't collapse, and there is no donor morbidity. But of course, there is a cost to the cage, and the cage can sink, leading or subside. And there may be non-union, though I haven't had it. And if you look at randomized controlled trials, there has been no difference. Then they devised this kind of device, which had screws which were countersunk inside. So this is to give fixation as well as not provide, not create a sort of dysphagia. But of course, this has its own cost, which is quite a bit. And I really think it's not necessary. Though it looks nice on x-rays, but I don't think it's really required. Then you come to disc arthroplasty, which is a different, I'm not going to even talk about it. Because it's supposed to preserve motion and limit adjacent level disease, but it's really, really expensive. And I don't seriously believe that it's any better than what we have. Last but not the least, there are people who actually don't put anything inside, and the clinical results are absolutely comparable. There is no bone graft complication. Most of them actually go on to fuse, but the x-rays don't look good. And there haven't been really very, very long-term follow-ups. So let's look at the steps. First thing, you would have to do a good discectomy. So no matter what you want to put in, your primary procedure should never, ever be compromised. You have to prepare the end plate well, because that's where your fusion is taking place. You need to size your cage and then place the cage. And then I like to put mosselized bone graft anteriorly. Now, the end plate preparation is very important. It actually is not a discrete step. It is part of your discectomy. So when you start doing the end plate removal. And here is a concept of optimal removal. So if you take out too less, there'll be a non-union. But if you take out too much, there is subsidence. And I'll show you in my next slide. The other thing is you need to shape it to accept the cage, because the vertebra is cup-shaped, but the cages are often flat. So you need to give some sort of shape. If you look at the disc, the end plate, there are two end plates. There is the bony end plate and the cartilaginous end plate. And the point is that the cartilaginous end plate has to be completely removed, but the bony end plate should not be removed because that would lead to subsidence and also it will lead to bleeding during the surgery. The apophyseal ring, if you maintain it, forms a good support. This is a very important instrument, which is the sort of distractor which you need to put in, because this distracts, this opens out and allows you to remove the disc properly and do your surgery. And after preparation, essentially this is how a cage goes in. So let me now go to our video for this. So these are the set of instruments which are required. And as you can see here, I've already put in the distractor and I've started removing the disc. You need to have a very, very nice set of sharp curettes to do your surgery, because that's what really saves the day. Remove the cartilage. Like I told you, the end plate preparation is not all done at the end, nor is it all done at the beginning. You remove it, you don't want bleeding. Once you remove the end plate, you remove your discectomy. I like to remove these osteophytes. And as you can see with the punch, I go superior to the PLL and remove the osteophyte. This gives you decompression, gives you access, and also gives you bone, because I don't take any bone from anywhere else when I'm doing this operation. So I use this 45-degree punch, 1 millimeter or 2 millimeter. I would have, initially found that plane out, but I essentially use the foot plate as part of my finger. You remove all the disc from the PLL. No matter what I'm doing the surgery for, I like to remove the entire PLL. This is controversial. There are people who don't remove it all, but I believe in removing it all because, that's the way I have been taught by my teacher. So you need these angled curettes, and you can get some very nice sets from the companies where you have a bayonet as well as an angle, which is very important, because if you don't have a bayonet, it comes in your vision if you're doing it under the microscope, which you should. I think anterior cervical should be done under the microscope. So now I've entered below the PLL. You can see I made a rent in the PLL. You can start seeing the cord over there. And these punches with the golden tip are the special cervical punches with a thin foot plate, so they won't damage. This is a very technical step. And if you can see me removing the PLL as well as the posterior part of the disc, and that you can start seeing the things below that. The microscope is really very, very important for this, because that is what gives you the differentiation of the various colors and the layers, because there are many layers there. There's the posterior annulus, posterior disc, then there is the PLL, and then there's the dura, which is blue. And obviously the last thing you want to do is cut or damage the dura. I don't require an assistant for this. I do it myself. I hold the suction. Those are the cages. The sizers are on the top and the cages at the bottom. That's what a cage would look like. It would have some serrated edges, and it would have a central area to keep your bone graft. And they have various sizes, but they would be a sort of a different shape for caudal and cephalad, because the shape is different. The caudal one would be more flat and the cephalad one would be curved. So here you can see the disc is completely removed. You can see the cord, and that's the way it is shaped. And I first put a trial. Now, what's very important here is with the distractor, you should not over distract. There is a tendency to be able to over distract, and post-op your X-ray will look very bad. If you're putting an 8-number cage in an Indian, you are doing something wrong. It can never take 8. It would be 5 in sort of smaller patients, 6 in most, 7 as an exception, right? So I'm just doing a trial to see whether it fits snug. If you want, you can actually release the distractor at this point in time or make it slightly less, because you will otherwise be fooled into putting too large a cage. If you put too large a cage, these patients tend to get sort of pain from the facet joint. So you're looking for a snug fit. That's probably the cage on the holder. You can see there's a guard there to prevent it from going deeper inside. And the depth of this is usually fixed. And you need to lightly punch. If you're heavily hammering, there is something wrong. And if it's going in too easily, also there's something wrong. So you go in till the foot plate hits the vertebra. And that would be sort of your end point. Having done that, you give a wash, you look at everything. I would do two imagings. One would be during the sort of with the trial, and the other imaging would be after putting the final. I think it's very important to do imaging because intra-op, because you don't want a shock later on. Just the lateral is enough because we are not worried about mediolateral placement. This is not a disc replacement. It's not that demanding. What you need to have is good bone. And I like to put bone graft anteriorly. And many people ask me about it, but that bone graft which you put anteriorly doesn't go anywhere. In fact, that is what gives rise to the fusion, which you can see. So this is how you assess fusion. You look at the bridging trabeculae through the disc. But what really is nice is the sentinel sign or the bone graft in front of it, which is what we do. And there are Bridwell's criteria as well. My fusion rate has been excellent, whether it's 1 level, 2 level, or 3 level, and I have a follow-up on more than 50 cases. So guys, this is a sort of my technique of doing the anterior cervical discectomy and fusion. And my time is up, so I'm going to stop here. And I welcome any questions anytime during the session. Have fun.
So, Samir sir, very informative talk. I would ask 2 questions to you since there are no questions currently in the chat box. First thing is, what is your take on a titanium cage versus a PEEK cage? If there's a cost issue, how do you take it?
I think the literature is a bit equivocal about it. For the cervical spine, there has been no issue. For the lumbar spine, there are some people who prefer a titanium cage because these, PEEK cages have been giving some problems. But PEEK cage has the same modulus of elasticity as bone. I actually prefer to have a PEEK cage with the markers because you can see the bone graft and the fusion very, very well. And there is a, a titanium cage Indian will cost 6,000 and this thing will cost 10 or 12,000. But I like to use I like to use the see-through cages.
And second question, when beginner is doing and if he accidentally removes the bony end plate and if there is some subsidence, how do you salvage that? How would you advise? Would it go with the cage or should just a graft? How would you go with it?
No, so if the bony end plate is removed and he's really realized that the bony end plate is badly removed, then you don't wait for subsidence. Then I'm afraid he may have to use a plate in that case if he doesn't want the cage to sink in. And then you can use a bone. Then you might as well use a bone graft and plate, because if you want to save on cost, because I think cage plus plate is a bit too much.
Okay.
Yeah.
And what are the maximum levels you have done with the PEEK cage standalone?
4. Okay. Yeah, I'm a great believer, and believe me, it took me nearly 10 years to get all of you all to believe it. 10 years ago, you used to laugh at me, and then 5 years a little belief, and now you guys believe me.
And what
all are standalone.
Post-op immobilization protocol do you recommend?
Just a soft collar for 3 to 6 weeks.
Okay. Thank you. Thank you very much.
Thank you.
Samir, just one question. Sure. The biggest concern for us is that, when you're putting a standalone interbody device, the biggest thing that we are worried about is that whether it will get expelled. So what are the steps, that critical, important steps that make you believe that, or you take so as to prevent expulsion of this interbody device? Because sometimes in a lordotic spine, the anterior part just opens up and the posterior part is still narrow. So how do you plan these things?
See, the thing is that we are operating in degenerative spines. We are not doing it for trauma. I think the indication is very important, and there is no pre-existing instability over there. So if your cage fits snug, even in the supine position, when you are extended and you are doing the surgery and your cage fits snug, I don't see any, I've got more than 50 documented cases, but I've done more than 130 actually. And not even one, because what happens is they don't move. They just don't move. Once the patient wakes up, the weight of the head just keeps it in. And those thoughts are just not there, that he'll cough it out. Plus they have serrated edges, so that also helps. Oh yeah, the anterior lip you slightly keep, Sandeep. The anterior lip you slightly keep. Yeah.
Yeah. So the indications are purely degenerative. It's a non-traumatic. In all traumatic cases,
Absolutely.
You definitely use a plate.
I will not trauma. I will never ever use a standalone cage. Please, if nobody should go away with that message. And in the spondylotics, it's even so. When you ask me about the 4 level, although nobody has it, but if a young patient has a 4 level soft disc, then I would not use a standalone cage. No, the 4 level which I did 2 of them. They are these really spondylotic, terribly spondylotic spines. So they are so stable because they're posterior, even the facets, everything is degenerate and fused. So they're rock solid stable. So you can easily put standalone cages. In a younger patient, I wouldn't do that.
Thank you, Samir. Thank you very much. Message taken. So now we move on to the next part of this procedure, that is the plating technique, to be given by Dr. Tushar Rathod, to be moderated by Dr. Ketan Badani. Over to you, Tushar.
My talk is going to be on an anterior cervical instrumentation, mainly a cervical spine plating. This talk is going to be into three parts. The first part will discuss various plates and basic biomechanics. Second part, what are the approaches, tips and tricks while doing a cervical spine surgery anteriorly so that it helps in anterior-cervical plating, and what are the mistakes to be avoided. And third part will be the video itself. Why do you consider a cervical plate? So there are situations like an infection, tumor, trauma, where standalone cage or a graft may not suffice because cervical spine plate provides a rigid fixation. It also prevents the excessive graft subsidence, and as it is located anterior to disc space, it prevents a graft extrusion. Cervical spine plate helps in preventing a segmental kyphosis, and especially when one does a multi-level corpectomy with adequate contouring of the cervical plate, one can give a good amount of lordosis. Especially when a multi-level fusion is planned, literature shows that the cervical plate has a higher fusion rate with a reduced need of bracing. The fixed angle plates were the first plate which were designed with respect to anterior cervical spine. They are called fixed angle because the screw holes and the screw are locked in a fixed position. So after having a purchase in a proximal and distal vertebra, the problem with this particular plate is they prevented a compression across the graft site. And this prevented the natural loading which used to occur with across the graft site, so had a higher pseudoarthrosis and a implant failure. This led to the designing of a new idea called buttress plate, where rather than spanning a proximal and distal vertebra, they tried to just support the inferior vertebral plate by doing a buttressing across a stud graft. However, whenever the graft used to extrude, they used to take a plate along with it, and this used to have a higher tracheoesophageal injury and a catastrophic complication. So it is no more recommended. Then came a dynamic plates. They allow graft settling and they were theoretically appealing. However, a strong clinical evidence regarding their clinical efficacy is lacking. There are two types. One is a slotted hole, where there are slotted holes in the plate, which allow a longitudinal excursion of the screw along the plate, and thereby it permits a collapse. Or second is a telescoping plate, where the plate itself telescopes and allows a collapse across the graft site. Here you can see a slotted hole which is located in the
So have we lost the voice there?
Yeah, I think voice is not there.
Dr. Ayush?
And this led to the advancement and development of
Sandeep, this is Dr. Gautam Zaveri.
Plates, which allow a limited
While we
subsidence
wait for
without
Tushar to join back,
translation of
can
the
you hear me?
screws. You can appreciate the screw toggle in the
Okay, but I can't hear
screw
him at
hole
all.
and thereby permit a limited amount of subsidence. And this also allows a good desirable load sharing between the implant as well as the graft. Because they are circular in shape, they can allow a good amount of toggling ranging from 0 to 35. After going through the nature of various plates, one also has to understand that there are certain biomechanical and anatomical aspects. First we'll discuss the caudal end plate of the cephaloid vertebra is a concave as compared to the super end plate of the caudal vertebra. So to fit in an appropriate size graft, one has to make it in a square shape or a box face. And for that, it's very important that anterior-inferior edge of the cephaloid vertebra is to be removed. This not only helps in a proper fitting graft to fit in, but it also allows an increased good visualization of the neurological decompression. One can use a Casper pin to get a good distraction as well, which should be in a central part. There are few basic tips regarding the plating that I will discuss right now only. One is the length of the plate. Understand that your proximal and distal hole should be as close to the respective end plates as possible. This will do two things. This will prevent a adjacent or impingement of the plate on the adjacent disc space, and second, you will get an oblique trajectory to pass on, which will increase the length of the screw and a better hold. Second is, as a beginner, one will struggle with the fitting of appropriate size graft. This occurs because of an inadvertent fear of a vertebral artery injury. One has to understand anything and everything between the two uncovertebral joints can be excised, and this will allow good vertebral interbody spacer to fit in. Third thing is the plate should be in the midline. There are various ways one can palpate the chin or a sternal notch, but the best way is to see the uncovertebral joint and plate in center. Another way is to make your plate perpendicular to the end plates. It's very important that you contour a plate in a proper lordosis, and the screws should always be directed medially, convergent, and unicortical. We don't need a bicortical purchase. The anatomically Smith-Robinson approach is the one which we commonly use, and it exposes the entire subaxial spine from C3 to C7. There are basic things one has to do while giving a proper position when one is planning for a plating. Most important is to give a proper interscapular pillow, which will give a good cervical lordosis and extension. Avoid excessive extension because it is going to cause a foraminal narrowing and a stenosis. So common mistake is to hyperextend the neck. That should be avoided. One can give a reverse tendon position to decrease the blood loss. I usually like to fix it in this particular position, in a head in a neutral position, or one can turn the head to the other side. But make sure that you are plating in the midline. If you plate obliquely, then you are going to lose the range on the opposite side. And attraction can be helpful, especially when one is doing a corpectomy and putting a strut trap in between. So once you complete your interbody work and decompression, you will be at this stage. You will have a self-retaining retractor which are placed on either side, both medial and lateral. And you can additionally use a self-retaining retractor proximally and distally, making it essentially as an assistant-less surgery. We commonly use a Casper pin because it gives a graduated distraction of the disc space and helps in interbody work. One has to make sure that the entry point for the Casper pin should be in the center part of the vertebral body so that they should not come to the side and compromise the screw holes for the plating. Once you complete your interbody work, then you will take out these Casper pins and place a plate. Your interbody graft does not need to be too much behind the plate. It should be hardly 1 or 2 millimeter behind the plate. Once you place your interbody graft, the plate introducer is important. A lot of sets have a plate introducer which hold the plate on both sides. That compromises the view or field of vision. So this is the ideal one where the plate introducer is being introduced through the hole and there is a side handle so that you get an unobstructed vision of the plating surface. It's important that your plate should sit very flush to the vertebral bodies and give an adequate amount of contouring or lordosis. There are various pre-contoured plates which are available. Second part is that once you placing the plate in the central, you can use a sternal notch as a reference point or a mandible chin as a reference point if head is in a neutral position. However, the both-sided uncovertebral joint is the one which I use as an intraoperative landmark. Another way to know your plate is that your end plate should be perpendicular to your plate. Thereby, you will get a plate exactly in the central part of the vertebral body. So once you place your plate and see another thing which we discuss is to place a stationary pin so that the plate will be held in a one particular place. The second part is the length of the plate. As we have already mentioned, that plate length should be as minimum as possible so that your screw hole should exactly, proximal and distal screw hole should be just exactly adjacent to the end plate, respective end plates. You can see this is the interbody graft and your screw hole exactly coming at the edge. So there are two advantages. One does not encroach the proximal healthy disc space, proximal or distal disc space, and second, you will get a longitudinal oblique trajectory which will also increase the length of the screw. Now, this is how one can joystick with the help of plate holder and the stationary pin is holding. Now, second part, because you are having a hold in this particular area, the opposite screw will be passed so that you will fix the plate in a one particular position. Now these are self-drilling and self-tapping screw. Again, you can see the screw is given a medial convergence and is upward directed. There is no need to take a bicortical hold as we discussed in anterior cervical plating introduction. Usually the length of the screw is determined during the interbody work. We can do it preoperatively as well. We usually use our nav hook and measure the anteroposterior length of the vertebral body intraoperatively, and we use 80% of the length of it. Normally it is 14 millimeter to 16 millimeter screws are commonly used. Again, there are two types commonly in the set, have a 3 mm and 3.5 screws. If your screw get, usually we introduce 3 mm screw. If your screw get loosened, then you can introduce 3.5 screw as a rescue screw. So again, you can see a medial convergence and inferior directed screw so that you will get a good hold in the screw. There are locking mechanism which one can use to lock the screw, but if you have enough oblique trajectory, sometimes they don't lock. So in that case, don't try to hammer or try to very forcibly use, because in that you may cause a disruption of the locking mechanism. And this is how the plate should be flush at the end of your surgery. And one has to take a check shot in a fluoroscopy and confirm the position, length of the plate as well as the size of the screw. Once it is complete, one can use complete the longus coli closure in the midline. However, most of the time it doesn't come. It's okay even if you leave it like that and keep a gel foam paste, but make sure that you have good hemostasis and there are no bleeders which are left inside. One can keep a drain usually in the prevertebral area so that there should not be any hematoma collection. And at the end of the surgery, the platysma and subcutaneous tissue are, this is a platysmal stitch, and in the end, you can repair in a subcuticular manner to have a healthy scar. Thank you for your patient listening.
Thank you, Dr. Tushar Rathod, for an excellent presentation and excellent video. I do not see any questions in the chat box. I would like to ask one question, that what steps do you take, to reduce the prominence of the plate? Because the prominent plate is going to irritate the esophagus, and there are problems. I have faced those problems a few times. So what are the steps you take to reduce the prominence and protect the esophagus from the plate?
Yeah, it's a very important question. The first thing is that your plate should be a low profile plate. We should not use a much plate. Second, when you are doing a surgery, there are a lot of time osteophytes which make the plate very prominent. So, and these are mostly the anterior-inferior cephaloids of the cephaloid end plate, and that should be burred out. And third thing is the adequate contouring of the plate. If your plate is straight, then it's going to the inferior screws and plate will be off the vertebral body if you don't give a proper lordosis. So these three steps are very important, and well contoured plate will prevent a visceral injury.
And you said the longus coli is very deficient. Of course, after dissection, not much is left. But any other thing you do to create a soft tissue, interface in between the plate or anything?
So again, as much as possible, you try to get a longus coli approximation. If it's not coming, I usually keep a gel foam piece horizontally cut, which is of minimum thickness, not a very thickness, and then you close it over that. You make sure that your screw should not be too much prominent; they should not jet out beyond the plates.
And one more thing, many a times, the plates are not, the length of the plate doesn't meet your requirement, like what you want is the upper end plate, the screw should enter the upper end plate. Then supposing the plate available is a little longer, then how do you manage? What do you do with the screw trajectory and things like that?
It's a very tricky question. Again, as we discussed, we trim out the inferior edge of the cephaloid vertebra. So the length of the cephaloid vertebra is smaller as compared to the caudal vertebra. So when you want to air the plate, keep it on a downside more so that you will have a longer plate on the downside vertebra, and that will not impinge the caudal disc space. So it's important that if you have a longer plate than required, then keep a plate shorter on the cephaloid vertebra, and you may keep it longer because of the size. And second thing is the trajectory, as you rightly discussed, you should come from the end plate and go horizontal obliquely, so you'll get a good purchase.
Yeah, that's a good tip. That's a good tip. And last one question I want to ask, that we are working around very vital structures, the esophagus, trachea, the vessels on the side. What tips do you have, special tips to avoid inadvertent injuries to these structures?
Yeah. It's a very, again, important question because we have a self-returning retractors, which if are not released continuously, they give a continuous traction on these visceral structures and they may cause a recurrent laryngeal now continuous compression. Second is esophagus, which is being continuously retracted, so they make it more prone to the injury. So it is very important that you release this traction or the retractors intermittently. It is always better in KM. We have our residents, so which anyway get tired and they leave the retraction. So that is actually healthy. So one has to be very important when he is placing the retractor. Second, the self-returning retractor, the spike should be beneath the longus coli, and they should not go beyond the longus coli into the esophagus or in the carotid side. That is very important.
Yeah.
Okay, thank you. Thank you, Dr. Badani and Dr. Tushar, very much. We are slightly behind the scheduled time. So from the anterior procedures, now we move on to the posterior procedures, the most commonly done surgery, that is the posterior lateral mass screw fixation. Dr. Ayush Sharma would be presenting his video and Dr. Mihir Bapat would be moderating.
In this talk, we will see techniques of lateral mass fixation. If you have to know any technique, it is most important to understand the anatomy first. So when you are looking at the lateral mass while operating, you are looking from the posterior view. And this is what you are likely to see. This is for the box here is the lateral mass, which is bounded superiorly by the superior facet. Inferiorly, the borders are made by the inferior facet. The lateral border of the lateral mass makes the lateral border, and the medial border is defined by the lamina of the cervical spine. If you look at this from posterior, it looks like a square. But if you look at the three-dimensional structure of it, the lateral mass is like a flattened cube. Now, this is a small video on a bone model which will show us how it looks in three-dimensional. So, this is the bone model of a subaxial cervical spine. And as I told you, the superior border, which is by the superior facet, the inferior border, which is made by the inferior facet. This is the here will come is the lateral border. And as you go more anteriorly, you see the relationship of this with the nerve which is coming out from the pedicle, and then we have the most vital structure, which is the vertebral artery. Normally, when you are planning to place a lateral mass screw, you choose the entry point somewhere in the center. You go laterally and cranially, 30 degree. So what exactly it means is when you go in this direction, you will realize that you are away from the two most important vital structure here, which is the nerve and the vertebral artery. So see, this is the trajectory you are taking. So you are quite away from these two important structure. And anyway, you are very far away from the cord per se. Sometimes we take an entry which is quite down to get a better trajectory, but you have to remember that the lateral mass are very, very flat. So you do have a risk of a dorsal burst out if you're starting somewhere in the lower 1/3 corner of the lateral mass. Lateral mass fixation remains our workhorse of posterior cervical spine fixation. No matter what you're doing a trauma, infection, anything and everything, lateral mass is one of the cervical spine fixation is one of the most common fixation that you will do. It could be as simple as this pure lateral mass fixation, or it could be part of a hybrid fixation like this. You might need to fix the cervical spine after a long decompression, as you can see here, or you have to augment posteriorly because you have done more than 2 levels of corpectomy. In some cases, after treating an infection or a tumor, if you have compromised the structure of the cervical spine, again lateral mass fixation can come handy. What are the contraindication of doing lateral mass fixation? There is no absolute contraindication. But in certain cases where the anatomy doesn't permit you, or there is a destruction of a lateral mass, you might prefer other type of fixation. As you can see here, the lateral mass screw here was very, very small. And you look at the pedicle screw, we had a humongous pedicle screw. So we preferred a lateral mass screw on the opposite side, but on this side, we went for a pedicle screw. Again, sometimes it could be a variation in anatomy. As you can see, here the lateral mass screw trajectory was just coming to vertebral artery. It was very, very small lateral mass. So we went for alternative fixation. We went for C2 rather than putting a C3 lateral mass. In cases of C7, sometimes the lateral mass screw can be very, very small. Again, if you are having a very massive construct on top, you are better off with a pedicle screw than going for a lateral mass screw. If you are planning to correct a cervical kyphosis, as you can see here, then the strength of the lateral mass screw might not be great enough to get a correction. And that is the time you might have to add an anterior construction. So this is what we had to revise because our lateral mass construct failed. If you look at the various techniques in the book for insertion of lateral mass screw, there are many in number. You can use a Magel, you can use Anderson, you can use an Ann. So most of them, what they describe is you start somewhere in the center, you go 20 to 30 degree cranially, and you will get the trajectory. Now, the most important thing which determines this anatomy and determine the structure is the course of the vertebral artery, because that is the most important thing in cervical spine. So the safest trajectory for sure is you start in the center, you go like this, and you are away from the vertebral artery. But you understand that this is not the longest trajectory which is possible in lateral mass. So if you want to take a longer trajectory, you can start somewhere down. But that means that there is small risk of you coming in the vertebral artery. So you're starting somewhere down here. You need to have a very, very sharp and good angulation to get the trajectory and not to damage the vertebral artery in the process. We look at a small video in a real patient how lateral mass fixation is done. One of the most important tricks is to take away the spinous process before you start putting your lateral mass screws, because these spinous processes are bifid spine. So basically, it will hamper your direction. It won't allow you to get the trajectory or direction you want. This is the cranial end. This is the caudal end. This is the left side. This is the midline. I am standing on the right side of the patient while trying to put the screws on the left side. I have just marked the medial border of the lateral mass, and I have just marked my starting point. So this is a small technique to just make sure it keeps you aware of the surrounding. So if you look on the model, we saw this is the medial border of the lateral mass, which we have marked with a cautery. I prefer a high-speed burr, and we go with full speed and then start drilling. Because if you start on the lamina, then you might wobble up. So if you see, I am going full speed, taking an angle of almost 25 degrees while going also. But what I do, I let the tip of my burr sink in. So once the tip of the burr has sink in, it prevents or it reduces the chance of a dorsal burst out, because I am now deep inside the lateral mass, and this is where I will try to get the trajectory I want. So now I am giving the angle of the cranial caudal angle. Most of the time can be defined by taking a lateral shoot. It is always a good idea to get a lateral shoot to look at the cranial caudal angle and then do your drilling. So what I'm doing is I'm letting my burr sit on the lamina below, and this itself is guiding me to the trajectory. Every 2 millimeter, I am feeling the cortex coming back, and then again I am going. So this allows you to put a safe lateral mass screw. If my tip of the burr has gone deep enough, I will stop. If the tip has gone till here, means I have already gone up to 16 millimeter. So I'm using a Midas Rex burr. So if you see this is almost 14 mm. So if I'm gone at that depth, I'm fine. But if I don't get that depth, then I'll go bicortical. That means I'll pierce the opposite cortex as well. But in this case, this was a good enough length because it was coming up to 16 millimeter. So we stopped it and we felt for the integrity of the lateral mass. And once you feel all the corners, then you are sure that you have the trajectory is good. You can use this ball tip probe to get the length of the screw, and then you go in the same trajectory where you have drilled and you finish placing your screws. In some cases, you can go bicortical, that gives you a better strength, but also puts the vertebral artery and the nerve at certain amount of risk. At this stage, we'll see a C-arm shoot just to make sure that we are in a good trajectory. And this is the final CT scan showing that lateral mass were in a good position. So thank you. So that was the end of the presentation.
Hello.
Yeah.
Ayush, can you hear me?
Yeah, hello. Yeah, please tell me.
Yeah. This is Dr. Mihir Bapat here. It was an excellent talk on lateral mass. I think it's very clear how to put a lateral mass screw. Before we have some questions coming up on the chat, I would like to ask you, when you plan a lateral mass fixation, do you measure each lateral mass on your preoperative CT scan?
No, not each lateral mass in a routine case. But if there is something like if you find some aberration, then I do prefer going to CT. Like the case I showed you. Now, if you look at the X-ray itself, it tells you there is there is something wrong. Like you'll get an idea that one of the lateral mass is looking slightly weird, and one of the lateral mass looking slightly bigger. Those cases for sure. But if you find in the X-ray everything looks decent, maybe not for each and every case, but anywhere I have a doubt, even a single doubt, I won't mind going into CT scan. And sometime you will be surprised what you will see and find in the CT scan.
Another question for you is, have you had instances, because you advocate this long course to get a better length of the screw, have you have instances where you needed to revise your trajectory because it didn't suit well on your fluoroscopy?
Yeah, so there could be. So normally it is the craniocaudal trajectory which you see on fluoroscopy, and the medial to lateral is in your control. So you're starting down, you have another shot. So if you see that's what I was telling. So if you understand the 3D anatomy, so if you're starting down, there's a problem with it, you find that there's something wrong, you can go to the midline, like the center of. So at least you will have two shots. I don't believe in most of the lateral mass you can have at least two trajectories. So starting down is not a bad idea. And if you feel it's not a good trajectory or something amiss, there's no shame in putting a shorter screw. I don't feel that way. But make sure you at least get a 12 mm length. And of course, you can go bicortical. That gives you some more strength.
So suppose you have had to revise a wire that you have put in, or a drill, you have to change a direction. Would you consider putting a higher diameter screw, or do you still put in a 3.5 mm screw? What is the role of salvage screws in your experience?
So sometimes we know the lateral mass completely bursts out, and there is no. Sometimes you cannot salvage. Then you have to think of other ways. You can go up, down, or if there is small mismatch, or you just change a trajectory and feeling loose, you can go for a higher screw. But in not every cases you can just simply increase the diameter from 3.5 to 4 mm. In sometimes it's a complete burst out, and sometimes you just have to leave that level and maybe go a higher above or below, depending upon what you are doing.
So, extrapolating from what Kshitij mentioned, in the C7, would you prefer to use a pedicle screw or a lateral mass screw?
So exactly. So C7, as I showed you, if you are in a long construct, definitely C7 for me is a pedicle screw. But you are doing something like you are doing some 1 or 2 level or something like that, and if you're getting a good lateral mass, that's fine. But if I'm in long construct, at the end of the construct, as I showed you in my talk as well, definitely you should try for a pedicle screw. And C7 pedicle screw, as it is showed, is not that technically complicated as compared to the other pedicle screw.
Perfect. In your experience, have you had any incidents of a screw touching a nerve root, or any sort of incidents where you had to revise your lateral mass fixation?
So of course, if you're doing a certain number, sometimes we had to revise. But most of our doubt was because the screw, there was simply when we drilled it, it was very osteoporotic, and the lateral mass just burst out. So there was no salvage, and you have to skip the level. We never had it till now. We have seen a clinical problem with a screw. Sometimes we have seen in our CT the screw looks very, very close. But fortunately, till now, we never had a clinical problem with the screw when it comes to touching the nerve or the vertebral artery.
Thank you, Ayush. I think we are bang on time. It's been an excellent talk and an excellent discussion. Thank you. And over to Sandeep.
Mir, just a couple of things because there are delegates watching. One of the few things that I would like to mention here is that make sure when you're putting lateral mass screws, you put it from the other side, right? If you're putting lateral mass screws on the right side, make sure you're putting the screws on the left side. You're standing on the left side. The second thing is that the inferior spinous process gives a good idea about the angulation in the mediolateral direction, and the superior facet. If you can put a small flat dura into the superior facet, that will give you a better idea about the superior-inferior direction. So these are some of the tips that you can use intraoperatively before you go on to fluoroscope. Okay. So thank you very much. Now we move on to the next talk on posterior C1, C2 transarticular fixation. Dr. Samir would be moderating this talk. So can we have the talk?
Yeah. Hi, Sandeep. Without wasting time, I'll ask you to start your lecture, and then we can have discussion at the end.
A very good afternoon to all of you. And in this video, we will have a look at a few tips and tricks for the insertion of the posterior C1, C2 or transarticular screw fixation. Now, this procedure is basically indicated in cases of a reducible atlantoaxial dislocation, or before inserting this screw, you need to do certain maneuvers like a release maneuver where you mobilize the C1, C2 joint, do a capsular excision, remove the osteophytes, and then insert the screw. But the basic prerequisite is that you need to have the joint in alignment before you insert the screws. And these indications could be trauma, tuberculosis, or multiple other etiologies, and in rare cases, the congenital ones. Since it's one of the most commonly performed procedure, it's important to know what are the contraindications. And vascular anomalies is one of the most important contraindication, the commonest of which is a high riding vertebral artery, essentially because it comes directly in the path of the transarticular screw. There could be other anomalies like the intersegmental artery or the fenestrated vertebral artery, and these by themselves could have disastrous consequences, especially while exposing the C1, C2 joint complex. Bony abnormalities is another contraindication where you may not be able to identify the exact entry point or depending on the anatomical landmarks. For example, when there's a fusion of the C2 and the C3 vertebral bodies, or there is dysplasia of the pars, or there is fusion of the OC1, wherein the landmarks for identifying the exit of the transarticular screw becomes difficult. Thoracic kyphosis is another contraindication, wherein the hyperkyphotic cervicodorsal region doesn't allow the surgeon the optimum trajectory which is needed for insertion of the transarticular screw. So it is mandatory that before you do this procedure, there should be a good set of instruments and implants. So you need to have, because the first chance is the best chance for inserting a transarticular screw. Once you create a channel or you have any issues in the instrumentation where you have to remove the screws and reinsert, then probably you might have to compromise a bit on the hold of the screw. So the first chance is the best chance. So you need to have good long guide wires which are of sufficient length for your colleague or assistant to hold this wire whenever you're inserting the screws. So you need to have cannulated drill bits. You need to have cannulated taps. Although I prefer a self-tapping screw. And obviously you need to have cannulated screws, so which could be partially threaded or fully threaded. So the advantage of a partially threaded is that obviously it gives a good compression at the joint complex, which obviously may have an impact on the healing or fusion at the C1, C2 joint. My personal preference is a fully threaded screw, which has a good hold on the pars as well as the C1 lateral mass. And the trick here is that when you're putting the screw, to avoid distraction at the C1, C2 joint complex, make sure that your colleague or your assistant is giving sufficient counter pressure on the occiput when you're actually tightening the screw. So that is good enough for you to have a good hold and prevent distraction. Don't do this procedure if you don't have a good C-arm. Ideally speaking, this procedure has to be done under a biplanar fluoroscopy, because you need to have orientation of the direction in the coronal as well as the sagittal plane. And you need to have a good X-ray, preferably with a radiolucent head attachment. So that's the position of my patient. In this case, it was a partially reducible AAD. And on the AP view, you can see that there is no rotation and there is no translation of the cervical spine. So you need to understand that the position of the C1, C2 joint has to be perfectly reduced position. So the lower cervical spine or the cervical dorsal spine has to be in flexion to give you the optimum trajectory, and the upper cervical spine has to hyperextend so as to reduce the joint. So this particular case was operated with a small incision. So you start the incision 3 to 4 centimeters in length from the tip of the C2 downwards. So you don't actually need to expose the C2 tip or the area proximal to it, because you want to preserve the muscle attachments at the C2, which are very important. So the area of exposure is actually distal to it at the C2, C3 joint complex. So you need to expose the C3 lamina, the inferior half of the C2 lamina, going laterally onto the C1, C2, onto the C2, C3 joint. So that's what I am doing. This is just to orient you that the C2 spinous process blends laterally into the inferior articular process of C2, which you have to expose. You need to expose the C2, C3 facet joints. And if you follow this, the midpoint of C2, C3 facet joint proximally, you will walk onto the pars. Make sure that you expose the medial margin of the pars. You don't have to go to the lateral margin of the pars, because the vertebral artery is in close proximity. And the feasibility of whether you can do a C1, C2 transarticular has to be decided preoperatively. It is never intraoperative. So you don't have to go and expose the lateral margin of the pars. So that's what I'm doing. I'm exposing the C2, C3 facet by a small incision. So that's the C2, C3 facet. As you can see over here, that's the C2 spinous process, the C3 spinous process, and that's the C2, C3 joint and the medialmost margin of the C2, C3 joint. So this is one important landmark. The medialmost margin of the C2, C3 joint has to be exposed for you to decide the optimal entry for this particular screw. So the entry which has been described is around 3 millimeters in line with the pars. So what I do is that I expose the pars, follow it distally, mark it with a cautery or a marker pen. So that's the medialmost margin of my pars. The entry point is 3 millimeters proximally and around 2 to 3 millimeters medial lateral to the line which I have drawn. So that gives me sufficient amount of bone medial to the entry point for the screw to have a hold on the pars. And remember, the medial most margin of the pars is a good cortical bone. So that is the best hold that you can have for a screw. My entry point is slightly different. What I do is that I expose the medial most margin of the pars, follow it distally onto the inferior articular process, and as I said, then I mark my entry point by a retrograde trajectory. Before I make a hole, I check the entry point on the lateral C-arm view and make sure that the entry point is right in the middle of the pars. Sometimes if you follow this, you can very well err with an entry point which is very superficial, and then you try to angulate the screw in the substance of the pars and land up in the inferior most margin of the C1 lateral mass, which is not a good hold. So make sure that this is one of the ways in which you can have a retrograde trajectory. Many times I find that my screw sometimes is visible at the tip of the C2 superior articular process, which is quite okay. So it's a sort of a in, out, in trajectory, which is still good and has a good hold, rather than having a screw which lands up in the inferior most quadrant of the C1 lateral mass. So you might have to take a separate percute entry for passing the guide wire, which is not needed if you have a big incision. Make sure that your guide wire is always held by your colleague or your assistant. So while passing the guide wire, I keep a flat dura on the medial margin of the pars, and the angulation in the sagittal plane is decided on the lateral C-arm view. So once I place a thick sort of a dura on the medial margin of pars, I know where my medial margin is, and the supero-inferior extent or the angulation in the sagittal plane is decided on the lateral C-arm view, where I want to land up at the tip of the C1 anterior arc. Not distally and definitely not proximally, otherwise you are going to enter the OC1 joint. A certain tips and tricks, if you find that you cannot reduce the C1 to C2, in this case, since you're not exposing the C1 arc, a better way is to push on the C2 spinous process to correct that last bit of residual angulation for you to get an optimal trajectory. But what I have found is that a partially subluxated joint, partially in the sense around 10 to 15% of subluxation of a joint, is a good trajectory to have. So the subluxation is actually good to have a good hold on the C1 lateral masses. In this whole issue of having a good reduction, we frequently hyperextend the C1 over C2, and that causes over reduction of the joint, which is not the desirable position. So the perfect position is where you slightly push the C1 anteriorly, make it subluxate by around 10 to 15%, so that you have a good enough optimal contact of the C1 C2 joint. There's no kyphosis at C1 C2, and more often than not you will land up in a good trajectory. Another tip of reducing the C1 C2 to C1, I put a loop around the C2 spinous process, pass that wire below the C1 arch and pull it posteriorly to reduce it. So that's one thing that you can do, especially if you are exposing the C1 arc. And that's the position of the wire on the AP view. So it's right in the center, around 20 degrees of 15 to 20 degrees of lateral angulation is preferred if you are having an entry point, what we just described. However, if you want to go straight, you have a more lateral entry point, and you can still land up in a straight. The advantage of having a lateral deviation of the screw is that you get a longer length and it is a much safer screw. So that's on the AP view. Here you can see on the lateral view, you land up at the superiormost margin of the C1 anterior arc, which is a antero-superior corner of the lateral mass. And then you can pass in your screws to the standard method that we all have learned over a guide wire. So you can tap in first, holding the guide wire at all the time and putting a screw. So that's the final position of the screw. In this case, you can see there's no kyphosis, a little bit of subluxation of the joint, but still having a good hold procedures. High riding vertebral artery, the incidence is almost 25%. 1 in 4 patient has a high riding vertebral artery, and that is one of the most commonest vascular anomaly which is a hindrance for the transarticular screw. Or there could be other anomalous vertebral artery variations. For example, if you're exposing the medial margin of the pars, then the first intersegmental or a fenestrated vertebral artery can very well come in your field, and you can land up injuring it. So CT angio is mandatory before you embark on this particular procedure. So that's about the procedure. Thank you very much, and we can have the questions during the discussion session. Thank you.
Hi, Sandeep, am I on?
Yeah, I can hear you.
Yeah. Excellent exposition. I must say that to the point that there are no questions at all from the delegates, but because you explained it very well. So just a few things which I just want to know. What is your mandatory imaging before you do this? Like, what are your mandatory imaging modalities before you take up a patient?
Pre-operatively, it has to be CT angio is always mandatory, or an MR angio. In addition to that, the patient usually comes to with an MRI. If it's a case of a dysplasia, then obviously I would like to get a detailed CT scan done. Okay. Before I take the incision, it's always a biplanar visualization as to what amount of reduction I have got, because many a times under anesthesia, these things might just open up.
Right.
If it's a partially fixed AAD, I would rather do a release and then give hyperextension to the supraaxial spine.
Okay. So pre-op, you will always do a CT, an MRI, X-rays, and a CT angio.
Right. If I'm planning a transarticular screw.
Yeah, obviously we are talking about transarticular. Now on table, like suppose you are able to get a reduction, but in the reduction the position is such that you won't be able to pass a screw. Sometimes you just don't get a reduction. You have to really hyperextend, and then you can't get in a screw. Do you change your plan? Is there anything you do?
Yeah. So there are times where I have landed up putting a transarticular screw on one side, and the other side was really dysplastic, where I could not put in either a transarticular screw or a C1, C2 lateral mass screw. In that case, I have just abandoned the procedure, put in a nice tricortical graft, and protected the patient, which is good enough. But yes, a C1, C2 lateral mass screw is always a salvage option if a transarticular fails.
Yeah, Dr. Senthil Kumar is asking, how do you position your neck? He wants some more details on neck positioning. I think it's a crucial part of the operation. I think most of the operation, you win the battle before you even take your incision, I think.
Right. So as I said before, the most important thing is achieving most of the reduction. Almost 90% of the reduction has to come before, and a little bit you can do later on. So what I do is that I make sure that my cervicodorsal spine is in a maximum amount of kyphosis, and the supraaxial spine is sort of in extension. So it's like a tuck position, So that gives me a good reduction of the C1, C2, as well as allows me a good angulation for the guide wire to go in. But then sometimes you can land up in hyperextending, because if it's a very supple mobile AAD, and in that case you might have to change the position of the supraaxial spine to a little flexed position to subluxate the joint and then put in your screw. But the kyphosis in the cervicodorsal spine is mandatory. Otherwise, you may not be able to get a good optimal trajectory for the guide wire.
And how do you manage to get the trajectory? Because it's really quite a struggle to get it so vertical.
So what I do is that if I'm fine, first is the important is the entry point. So the entry point has to be as low down as possible, right in the center of the mass. The second thing is I use a small drill sleeve, when just at the tip of the entry point, and my guide wire goes to that small drill tip where I'm maneuvering it. So because the guide wire is quite long, it becomes very difficult to angulate the guide wire exactly where you want to exit. And with this small drill guide, you can actually manipulate the guide wire and angulate it quite well. So always in all cases, I use a small, especially small guide, sort of a guide where the guide wire goes inside and I can angulate the guide and control the angulation.
And what about your preference? Like, do you prefer the partially threaded screw or the fully threaded screw?
I have tried a partially threaded screw, but I think it really doesn't matter as long as you don't prevent distraction. So whenever I prefer a fully threaded because it gives me a good hold on the pars also, the rear part of the joint. The only thing is that intraoperative distraction can be prevented by giving firm pressure on the occiput, and that prevents distraction. But again, said that over tapping or creating a bigger channel, I usually avoid it because I want to have a good hold on the pars also.
Dr. Ketan Badani is asking, what are the precise instruction you give to the radiologist for the CT angio? Is there anything specifically you tell them?
So initially we used to rely a lot on the radiologist, but nowadays with all these softwares coming in, we can actually ask for a CT angio and reconstruct the images on Orthopaedics and all, and actually find out whether there's any incidence of a high riding notch. A high riding vertebral notch doesn't mean that there's a high riding vertebral artery. Many times the notch could be high riding, but the artery could be absent in that particular notch. It could be much lower down. In that case, it's much better. It's a safer bet to put a transfer.
Okay, so I have two. I realize the next one is waiting in line, but I have two small questions which are really important. Intraop complications, just two in short. If you put in the guide wire and you drill and you tap and it really starts pouring blood, what do you do? In short.
So in that case, I would just take the guide wire out and see as to how much amount of bleeding it is there. Sometimes a little bit of the venous ooze, which also comes out through the screw hole, is quite a bit, and it scares us. But I would rather go in and put in the screw and abandon the screw on the opposite side. And maybe
that is my second question. If you can put a screw only on one side for whatever reason, okay, what do? You just leave one-sided screw, or do you put a wire, or what?
So there are instances where I have left the other side without putting any instrumentation. The most important thing is good grafting. So I make sure that I graft all these patients quite well, because what's going to give us results in the long term is the grafting part. So in all these cases, I use a tricortical ilectress graft, which fits into the C1 and C2.
But you are not exposing. Sandeep, you are not exposing the C1 arch, because the way the classic operation. The classic Maggles operation has a 3-point fixation. It has 2 screws and a galley wire in the middle, and that's how we used to do it. So if you're not
in case I land up in a case where I have to put in only one screw, I would always expose the C1 parts and C1 arch and put a good graft over there.
Fine. So I think we are run out of time. We'll take more interesting, excellent talk. You're obviously a master. Yes,
Samir. There is a small trick in the positioning when someone, like one of the delegate has asked. You can just put a small chin support, to give that tuck position, or just to get that slight flexion of the occipital cervical junction there. Yeah. Is May speaking, or like I have to start, Ayush?
Yeah. So Ashok, I think Mihir has a talk in between.
Okay. So can I share my screen? I think that would be better.
No, you can't share your screen because Ayush has to start the presentation of Dr. Mihir Bapat.
Acha, okay. No problem. Yeah.
And Dr. could be moderating the session. Yeah.
Yeah. So am I up next, Sandeep?
Yes.
Yeah.
Okay. Come here. Go ahead.
Yeah. So for the delegates, it's more of a bone model with all the steps highlighted for the C1, C2 lateral mass fixation. So please pay very close attention to it, because the surgical video will just depict what you see on the bone model. Ayush, can you put me on?
Hi, we're going to talk about the C1, C2 lateral mass fixation in this particular video. The positioning of the patient is extremely important. If the neck is extended, then the occiput tends to overlap on the C1, C2 joint, and exposure of the C1, C2 joint is extremely difficult. Therefore, one should position the patient in a military tuck position, where the occiput is a little flexed. So it allows you to approach this area here by opening up the C1 C2 joint. The midline exposure begins from the upper end of the C1 and the exposure extends up to the spinous process of the C3. This allows you a view of your C2-3 joint, the C1 C2 joint, and the lamina of the C1, the lamina of the C2, and the pars of the C2. The C1 posterior arch needs to be defined. The C1 arch has the following parts: a flat shaped portion from the midline which extends laterally to about 1 to 1.5 centimeters. Here the arch starts becoming a little ribbon shaped. This is your surface marking for your lateral mass. Above this is the vertebral artery. Below this is the C1 C2 joint. While exposing this portion, one should be very careful not to put a sharp instrument or a cautery above the C1 arch, because there is a danger of penetrating the vertebral artery. The next step is to define the C2 lamina, the C2-3 joint, the pars of the C2 which extends to the lateral mass of the C2. All this can be exposed subperiosteally to minimize bleeding from the epidural plexus. There are two important landmarks. One is the medial border of your central canal. This can be defined, and a small cotton pledget can be placed here so that you know the medial boundary of your pars, and you can actually go to the edge of your vertebral artery foramen so that the dimensions of your pars are clearly defined. There are two structures which directly hamper the exposure. One, the yellow shaped thick C2 ganglion that comes right across your C1 C2 joint and overlaps the lateral mass of the C1, and a thick epidural plexus which, if not controlled, can cause torrential bleeding. This epidural plexus extends along the C2 pars, across the C1 C2 joint, goes under the lamina of the C1 and overlaps the C1 lateral mass. Once you identify the inferior surface of the C1 lateral mass by sharp blunt dissection using a periosteum elevator, the undersurface of this should be gently dissected along the surface of the bone to separate the epidural plexus from the periosteum. This is an important step in controlling the bleed. A soft cotton pledget placed there along with this retractor will allow you to expose this part of the lamina without any bleed. Using a kerrison forward, a notch is then made into the inferior lamina of the C1, which allows you an entry over the top of the underlying C2 ganglion, which will then be retracted to approach your C1 lateral mass in this quadrant. A small cotton pledget can then be inserted there, and with the help of the periosteum, the entire C2 ganglion can be retracted inferiorly. A drill sleeve can then be placed onto the lateral mass of the C1, which is now exposed, and a drill through the drill sleeve will allow an atraumatic safe entry in the C1 lateral mass. This entry will be directed a little superiorly along the direction of your C1 lateral mass, and either 0 degrees angulation in the coronal plane or 5 degrees angled medially till you get a give way on the opposite side. One has to be extremely careful while drilling the opposite cortex, because the internal carotid artery could be lying abutting anterior to the C1 lateral mass and can get injured if the guide wire goes through and through. The C2-3 joint should be defined. The entry of the C2 par screw is about 3 to 5 millimeters above this joint, but this can be clearly defined by exposing the pars during your soft tissue dissection. So once the entry point is in line with your pars, a burr or a drill is used to open up the mouth of this entry. This can be made a little larger. After that, the drill enters through the cancellous bone of the pars. To avoid using a drill because of a danger to the vertebral artery or a medial breach, one can actually use a blunt torcha or a probe, which can be manually pushed with gentle rotatory movements through the cancellous bone of the C2 pars up to a desired length. It is better to measure the lengths of the C2 pars as well as the C1 lateral mass in your preoperative planning.
Maybe we can't hear your voice.
These are just representative slides. Let them go through.
So just keep on speaking here.
So after the entries have been made, the desired lengths of the screws used and the C2 par screw as well as the C1 lateral mass screw is then inserted along the pre-drilled holes. An important addition to the armamentarium of C1 C2 instrumentation is a C1 reduction screw. This becomes important in two ways. One, you can put the screw into the C1 lateral mass even if there is an unreduced atlantoaxial dislocation and use this screw to reduce the atlantoaxial dislocation in a controlled fashion. Second, you can protect your C2 ganglion and the C2 ganglion irritation remains low during the insertion of the screw. This is important because most of the patients would complain of occipital headaches if the C2 ganglion remains under compression. So here we have used a Technoshine C1 lateral mass reduction screw in the pre-drilled, pre-tapped C1 lateral mass insertion hole. So the screw is inserted into the position. As expected, there is a little bit of step as the C1 lateral mass is positioned anteriorly to the entry point of the C2 pars. Now this step is easily negotiable with a C1 lateral mass reduction screw as explained earlier. A rod is then captured in the C2 screw first. The anteriorly positioned C1 lateral mass gives an offset to the rod which can be easily reduced using a C1 lateral mass reduction screw. To complete your C1 C2 lateral mass fixation.
So the contraindications to C1 C2 fixations are all relative. Most important is that you should have an intact C1 mass and a good vertebral artery anatomy to put in the screw. And it is one of the safest techniques to use, very smooth, and in a very controlled fashion. You can tackle almost all pathologies of the C1 C2 joint, including basilar invagination. So to just go through the steps of the surgical video, can you have the surgical video there? It's just a few slides more.
I've been stopped actually. I need to regain control. I was stopped, so no, 1 second.
No, it's a separate video, I think.
This one?
Yeah. So So this is a burr drilling on the inferior edge of the lamina. Then you see the lateral mass of the C1. You enter into the lateral mass as shown in the bone video. This is the direction of your drill. We have not used a sleeve here just to show where the lateral mass is. So that's the entry point of your lateral mass screw as the flat lamina becomes a little spindle shape. Once you have drilled, the measurement should be actually pre-operative. It should not be intraoperative. And once you have put your C1 lateral mass screw as seen there, you should follow just the steps of exactly what was shown in the bone video. It is exactly what you're going to see intraoperatively. And that completes your lateral mass fixation. A both-sided fixation is going to give you almost a 360-degree control on your C1, C2 joint. And like I said, you can tackle almost all pathologies very effectively. Thank you.
Yeah, Mihir, nice session and a nice video of your C1, C2 separate fixation. Any questions, Ayush, on the chat box? Yeah, a small trick. Mihir, would you like to C2? Would you like to have the purchase of the anterior cortex? If you take your entry a slightly little higher up, like along the supralaminar line.
Sorry, purchase of the anterior cortex.
Could you get me?
No.
Cortex of C2.
Anterior cortex of the C2 articular process, or you want an anterior cortex?
No, the body. Of your C2 screw,
you're putting
a separate C1, C2 screw.
So you're
only putting a pass screw.
Yeah,
and not the pedicle screw. Okay, not the pedicle screw.
Here I demonstrated a par screw. Didn't have time to demonstrate a pedicle screw there.
No problem. Any questions?
So I think, thanks Ashok. I think you can go on with your video on occipital fixation. That's the last of the series.
Yeah, Ayush, can I share my screen? Ayush?
You can go ahead and share. Please go ahead.
Is it in there?
Yeah, we can see it. We can see you. Please go ahead.
Okay. In those affections of the craniovertebral junction, especially with instability that requires the stabilization almost going up to the occiput, like in this case of TB spine, involving the whole of the atlas and sometimes involving even occiput C1 joint, or in cases of atlantoaxial instability, there is already C1 occipitalized anteriorly, posteriorly. Then these are the cases where I don't think there is any point not to include the occiput in instrumentation, because occiput not only offers a solid anchoring points, it offers multiple anchoring points, in fact, there. So it's very important. Before I go into the details of the technical intricacies of how to put occipital screws, let's a few slides on the anatomy. If you look at this, a line passing through the vertebra, the cervical spine, the head, almost 3/4 of the head is lying anterior to it. So the extensors, the short and the long extensors had to work over time. So they are actually really strong. So we can take advantage of these well-developed extensor muscles, to cover our instrumentations. The short extensors like the occipitals attached to the inferior nuchal line, whereas the trapezius and other long extensors are attached to the superior nuchal line. So our field of area usually lies below the external occipital protuberance there. So if we keep the plate below the external occipital protuberance, usually it will be well covered under the muscles there. So now external protuberance is also an indicative, or it's a landmark which is indicative the confluence of the sinus as well as of the tectoral membrane which separates the cerebellum from the cerebrum. So our plate usually lies just below the external occipital protuberance. So our area of interest is around the inferior nuchal line and the thickened area around which we can put our plate or even a spatial occipital plate, as you can see it here. There. Okay. If you look at from inside, that's the confluence of the sinus, and that particular sinus which runs along the tectoral membrane gives us a relatively safe area between those cerebellar fossas, which is quite thick, and we can use it for our screw purchase. Okay, so that's the thickness is the widest in the midline, but then it slowly goes on thinning out as you go more and more laterally there. So we have to adjust your plate so that we can get the maximum use of the midline thick areas. So you will have to converge your plates, sometimes one plate short, one plate long, or you will have to profile your plates in such a way there. So the moral of the story here is that if you want to put a slightly longer screw with a better hole, then try to go as close to the midline or the thicker as possible there. So these spatial occipital plates are preferred mode of fixations in the occiput, because as you can see in this post-operative setting, there is a good assembly of the screws, as you can see in the central thick area there. So the technique of occipital fixation, basically I'll divide it into two parts. One is a drilling of the screw hole, and then the second part is how to do rod contouring and the rod capturing there. So in the screw holes, there it basically requires a sleeve and a drill, which can be either you can use a manual or even a power drill. But what is more important is it requires a guard there. Like as I already told you, sometimes it can be thin to the extent of 6 to 7 millimeters. I usually start with 8 millimeters guard there, and then which can be gradually increased to 10, 12. So if that's the skull and the occiput, I make the pilot entry hole with the burr there, and then put the sleeve and the guarded drill, and we start with this thing. So like that's the way how I go ahead, put a sleeve and the guarded drill, start with 8 millimeters, drill it, check it with the ballpoint probe, the inner cortex is still intact, increase the guard to about 10, again put it, again check it with the ballpoint, the inner cortex, inner table is still intact, then again delete by increasing the guard to about 12 millimeters. So slowly keep on increasing the guard and start drilling the inner table, and obviously multiple times you'll have to keep on checking it till you see the soft dura fill. Accurately measure and plate. Now after that, it comes the rod contouring, which is usually around 80 to 90 degrees of the bend there. Now if the reduction is already acceptable, then obviously we fix the rod in situ there. But in certain cases where there is a residual subluxation of C1 and C2, but still correctable on pressurizing the C2 spinous process, then you can use under-contoured plate or the under-contoured rod to achieve or to improvise our reduction facility. For example, in this case, a scenario of an irreducible fixed AAD where there is a spondyloptosis of C1 over C2, which I usually do a transferal anterior release of the longus scoli, the C1 capsule, then use the periosteum to manipulate the joint, and then use the puka to distract the C1, C2 joints like here, and then turning the patient prone after making this fixed AAD into a hypermobile AAD. As you can see it on this video, there. So then we turn the patient, and then this using this under contoured plate, which while fixing onto the occiput will help us improvising the reduction. As you can see, first left hand slide, there is a slight under correction or under reduced dents there, and then when we approximate the plate onto the occiput, you get a beautiful anatomical sub-basal reduction of the dents, as you can see it even on the post-operative CT scan. So this is how you can use the under contour plate there to achieve a better reductions. Yes, when you cut the plates, you will have to see to it can no sharp portion is jutting out under the muscles or even under the skin. There you can put the graft there. Another mode of occipital fixation is the wire there, which can be used as an augmentation or a salvage mode. Sometimes if your screw becomes loose in the occipital, you have delete learn, then you can connect it between the two holes. You can pass your wires, or sometimes it can be used as a primary mode of fixations in children, especially. There, for example, in this case, this was a 3-year-old child with almost 8 vertebral body destruction there, where I have used wires through the occiput to anchor the upper cervical spine and used it as an internal splinting there. And you can put 2 or even 3 wires into the occiput, almost like a Mercedes-Benz type of fixation there. And the technique is again the similar, to create holes in the occiput there with a guarded drill. So one hole, you create a second hole, confirm it with a ballpoint probe, and then pass your wire underneath, and then you capture that to the rod or a hard-shell rectangle. If you have a good tables, you can pass it between the tables also, the wires, and you can use it to augment your fixations. The complications usually, yes, sometimes if you're a little aggressive or not, you might get a CSF leak immediately after drill. I think once you put the screw inside, usually more than 99% of these leaks get sealed off. If it still persists, yes, you can use a little wax around it and then put your screws, usually get sealed off. Another complication, since as I said, the skull is a subcutaneous bone, you might get a wound necrosis. So always stay subperiostomy. I use minimum cautery on the scalp. Yes. And those cases who needed a preoperative traction, just see to it the skin doesn't get softened before your surgery. Otherwise, you might have a big trouble. Thank you very much for giving this opportunity. Yeah, Mir, back to you. Thank you.
Yeah, thank you, Ashok. I think these questions we can take it if we have time later on, because we are really running short of time. So after going through all the instrumentation techniques, now we move on to the a couple of cases of complications. We already discussed a fair bit about cutout of the lateral mass screw. So we'll go back to the anterior cervical plating salvage option. We have Dr. Tushar who will be presenting a case, and we can have a fair bit of discussion once he finishes presenting his case. So can we have Tushar?
I'm going to discuss one of the interesting case of anterior cervical plating complication, which was quite devastating for the patient. A 27-year-old male presented to us almost 1 year following the index cervical spine surgery at his native place. At the time of presentation, he had a left-sided hand grip weakness, and interestingly, there was a discharging wound from the operative site, which was used to discharge the food and water content. You can see in the video, almost he drinks the water, the whole water tries to come out from the wound. There was a history of gunshot injury to his neck almost 1 year back. The details were not available. Clinically, you can see there's a sprouting granulation tissue from his located in the left suprasternal area with a fistula formation with a lot of scarring around it. I have purposefully not hidden the identity to highlight the features of Horner's syndrome in terms of enophthalmos, anhydrosis, meiosis, which was present on the left side of the neck, the same side of the approach, that is the left side the approach was done. Our patient clinically had a neurological left-sided weakness in the hand grip. The X-ray showed, as you can see, a loosened cervical plate with the inferior screw pulled out. And interestingly, the locking mechanism had dislodged from the proximal screw and had gone on the right side of the neck. Patient was kept with the RT2 for almost 1 year, and there was a copious frothy discharge with a foul smelling and salivary secretion, which also used to come. We referred the patient for a GI endoscopy. GI people planned for endoscopy and they noted a right-sided implant penetration from outside in the cricopharyngeal area, and they abandoned the endoscopy and referred back to us. We did a barium swallow which showed a dye leaking from the anterior aspect of the neck through the fistula. And the report came out to be a complex fistulous tract connecting the trachea, esophagus, prevertebral space, and subcutaneous tissue of the neck. The patient didn't have a cuff, so we assume that the tracheal component is not much. At this stage, we discussed the case with the GI people, and they said that there's no possibility of any reconstruction unless the infection is taken care of. And so they advised the implant removal. So before doing the implant removal, we did a CT scan to establish the fusion mass. And then we did a plan for an anterior approach to take out the plate. Since there was a lot of scarring on the left side and also the locking mechanism had got on the right side, there was no way by which I could have retried it from the left side. So I decided to do a right-sided approach. It's very important in this case when you are doing a contralateral approach to do an indirect laryngoscopy, so that one should know what is the status of vocal cord and what does not land in a bilateral recurrent laryngeal nerve palsy and permanent tracheostomy. Intraoperatively, moment we retracted the stud and tried to retract the tracheoesophagus, I could palpate both endotracheal tube and RT tube with my finger because of complete deficiency of posterior pharyngeal wall. The GI people were on standby, but they said that there's no need to do any reconstruction at this stage and you can carry on. We did a sharp dissection around the neck, the plate part. There was a lot of granulation tissue. We took out the plate gradually. However, the most difficult part was taking out that locking mechanism. There was a lot of fibrosis around that locking mechanism, and I struggled for almost 30 minutes removing that. The moment I used to try to grab it, it used to slip. I did a lot of fluoro IP lateral, but I could not, and I failed in removing that, and that locking mechanism slipped down in the neck. I hope that either it should be in the tissue or it should be in the lumen of esophagus, and it should go in that manner. Unfortunately, it entered in the pharynx and esophagus, and then a serial subsequent radiograph showed its passage along the GI, and it was excreted. The post-operative course was very violent and stormy for the patient. The GI people kept him NBM, so he lost a lot of weight because they didn't want even salivary secretion. We also had a right-sided wound which was discharging saliva. However, with a lot of antibiotics and nursing care, that stopped gradually. The extubation attempt also failed because the moment we used to deflate the cuff, he used to get a breathlessness. So we assumed that the pharyngeal wall was collapsing. So a planned elective tracheostomy was done, which was kept for almost 3 weeks, and it was gradually weaned off. Over a period of almost 1.5 months, the wound started to show heal. The right side healed completely. The left side wound had also healed, and the scarring also reduced, and discharge from the tract was persistent, but it was reduced in the quantity, and there was a persistent fistula. GI people at this stage said that they would try the conservative trial and kept him in RT. And however, he responded gradually, and over a period of next 6 months, the tract completely stopped discharge. There was an option of sternocleidomastoid flap repair, but since patient was responding very nicely, we tried it conservatively. Since this patient presented almost 1 year, we planned for a reconstruction, but whenever there is a wound infection, fever, salivary discharge from the wound, or features of mediastinitis, it's very important to address it on an urgent basis because it has to do with a lot of morbidity and mortality, and one has to be very careful while dealing with this injury and have a very high threshold of suspicion. Always do indirect laryngoscopy when you are contemplating on the opposite side when one side is already being operated. And there is no substitute for a meticulous surgical technique, as I had highlighted in a previous talk, that one has to be very careful when you are dissecting along the longus coli, and one should not take a cautery directly in the muscle and damage the sympathetic plexus lying around the muscle. One has to be subperiosteal to avoid the injury to the sympathetic plexus and hornus. Thank you for your patience.
So thank you very much, Tushar, for this case. Now, Aish, just 2 minutes. Give me 2 minutes. Just a question to all the panelists. So let's get Samir to answer this one. If you find that a plate has backed out, say maybe around 6 weeks after the surgery, what is your protocol? What are the things that you actually? What is your protocol? How would you go about managing this case?
See, a lot depends on my initial what is the indication, what is the reconstruction, and what is the overall stability. For instance, if it is a TB spine and I have done a anterior surgery, posterior elements have been intact, and there is just a little back out, then and I have used the bone graft, I would wait because that is going to fuse up. The most important thing is that I will not sit on it. I will look at it. I will assess what is the overall stability and what problem the plate is causing. If I feel the plate is going to cause a problem such as further catastrophic failure, or that plate is going to jut or go into something, then I have no choice but to go down and salvage it.
In fact, that way the bone graft is very...
bone graft is more forgiving. But
very forgiving.
But the plate is a problem. You see, it's the plate edge which can cause a problem. That worries me.
Right.
Usually, if it's a cage, unless it's really put loosely, the cage actually then goes inside. That's even better, the mesh cage.
Yeah.
But the plate is a problem. But I would keep an eye on it. I won't jump immediately on day one. I would try to see what else it was.
Sandeep.
Right. So, yeah, go on, Ashok. Yeah.
Sandeep, in fact, one take-home message to the delegate should be that the retraction of the esophagus should be closely supervised by the operating surgeon and not leave it to the assistant. Otherwise, he will just keep on retracting and go to sleep. In fact, what I do is, I tell the anesthetist to remind me to release the retraction every 15 minutes. My surgery may go on from 2 hours to 2.5 hours, fine. But I think every 15 to 20 minutes, I'll make a point to release the retraction for 2 minutes. I'll let the esophagus don't go into ischemic necrosis. I think probably absolutely important. And the retractor, the right angle edge should not be impinging to the esophagus. Has to be always sub longus coli. Yeah.
Okay.
I'm actually amazed at this case. I'm amazed at this case which was shown. I thought this patient would have died because they die because of mediastinitis and nutrition. I'm surprised. I mean, this is like a Guinness World of Guinness Book kind of case.
Yeah,
especially the video of drinking water.
I agree because no one.
One more question to Mihir. One more question to Mihir is: suppose you find that the plate has backed off, would you be tempted to go in and stabilize posteriorly immediately, or if you are committed to just instrumenting that particular level, or you still go in anteriorly and take a call of refixing anteriorly? Mihir? So I think Mihir is not around. Kshitij, can you take that question if you're around?
I mean, as Dr. Dalvi says, it all depends. It depends on the situation. If the plate is obviously loose, then you really don't have an option. So you have to go down and remove it before it causes a problem. But again, it depends on what the situation is and how the posterior elements are, how loose it is. But in general, if it is, if your construct doesn't have stability, the plate is not going to do anything. It's just going to get looser and looser as time goes by. So, it's better that it is taken off before it causes a problem.
Right. Okay. Any difference of opinion from all the faculties on that particular point?
Just
obviously, it would depend on what is the cause of failure, but I would always be tempted to go in and stabilize first before I actually venture into before I actually get into that part of revising the loose plate inside.
Dr. Sandeep, many times the locking mechanism doesn't lock properly. So do you always try to lock it in, or do you leave it sometimes?
So I don't rely on these locking mechanisms. As Kshitij said, the primary stability has to come from the graft or your anterior reconstruction, and the cage is just to supplement it. So it's not the locking mechanism which I'm relying on to give me stability.
That's a very important message.
One more thing I want to say. That
yes, Dr. Bhatari.
What I do is the longus coli, they're just frayed edges on the side. I create a sort of a mesh with Vicryl in front of the plate. Taking the edge, it's not possible to completely close it. So I create a layer, artificial layer between the, not artificial, natural layer between the esophagus and the plate, for long term prevention of esophagus related complications from the plate.
Okay, thank you very much. So now we'll move on to the next salvage option. Suppose we have a C2 screw which fails, or intraoperatively we will land up in issues like what Dr. Sameer asked me, and we are not able to put in the C2 screw. What are the salvage options? So Ayush, can you take over from here?
So let's talk about C2 laminar screw as a salvage option in C2 cervical spine fixation. We all are aware that the mainstay of C2 cervical fixation is the C2 pedicle screw and the C2 pars screw. But fortunately or unfortunately, both these screws, the trajectory is very, very dependent on the course of the vertebral artery. So if you look at the literature of risk of vertebral artery injury when we compared the C1, C2 transarticulate screw to C2 pedicle screw, it could be as high as 14.5% due to a high riding vertebral artery, or it could be 9.5% due to the narrow pedicle where you cannot safely pass a pedicle screw. And no matter which technique you use among any one of them, the risk is almost the same. So sometimes the course of the vertebral artery could be very, very acute. And if you see here, what is happening here is the vertebral artery is almost eating into the left side of the pedicle. And this is the dramatic representation of how the vertebral artery courses in this case. And it is almost impossible to pass a pedicle or a transarticular screw. And this is where the role of interlaminar screw comes in, because you are completely away from the vertebral artery. Now, this was one of our case. If you will see, it has the same course. The vertebral artery, there is a high riding vertebral artery, and I don't think it's almost impossible to pass a pedicle screw at this on the left side. On the right side, we had a fracture. So this we thought is best to pass a interlaminar screw. This is the small video of this case. So as I told you, let's look at some more cuts. So this on this side, as I told you, the right side there's a fracture, if you can see here. On the left side, we had the vertebral artery, which was coming in our way. So we felt let's go for a safer option, which is the interlaminar screw. Just a 30 seconds on the exposure. This is the cranial end of the C2. If you intend to pass a laminar screw, it's slightly different. The reason being, you don't really need to go to the lateral corners. All you need to expose is the lamina, because you need to understand the direction of the lamina on both the sides, and you can safely pass the screw. So this is what we are doing. We have already exposed the lamina on one side. And if you'll see that we didn't go quite lateral the way we have to go for passing a pedicle screw or a transarticular screw. And this is the C2. And once we have done on one side, we'll just expose enough on the contralateral side as well to get an idea about the anatomy and the direction of the C2 lamina. So this is what we are doing. We are just exposing the contralateral side. And again, as I told you, we'll just expose enough to understand the anatomy of the lamina. And if in cases you want to pass C1 screw with that is a different scene, and you might have to go and expose more. But just for passing the C2 laminar screw, this much of exposure is enough. Another important thing is, if you want to pass two screws, you have to make sure you have enough space for both the screws to go in. So if you see, we are starting right at the bottom of the lamina. We have used a burr, high-scored burr, to make the cortical hole. Once you have made the cortical hole, we have to make sure that there is no breach. Especially, you have to worry about the ventral breach. If you see here, the dorsal is in front of you, the cranial is in front of you, the caudal is in front of you. It is only the ventral breach which can cause a problem. Then we use a laminar probe, and you can just walk through the calcaneus bone And I use a calibrated probe so that we don't go more than 18-20 mm, and we check with the probe, with the pedicle feeler to make sure that we have not reached the opposite side. So this is what we are doing. We make sure that all our cortexes are intact. And most important, as I told you again, you have to worry about your ventral breach, because that is where the cord is, and that is the only danger. But imagine, out of all the 4 directions in this, while passing this through, there is only one direction you really have to be careful about. Rest is very safe. Even when you're passing the screw, again, you need to keep looking at the direction of the lamina, because that is what will guide you. The X-ray and everything looks very funny even if you try to take an X-ray. So it is completely the anatomy of the lamina, the direction of the lamina, your eyeballing and your feel of the screw going in the bone, which will help you put a safe the interlaminar screw. So this is how the screw goes in, and we just take a Siam shoot here, and this is how it looks like. And this was the case, and then we get a CT scan as well, just to see how the screw was, and it looks like a good screw. So this was another case, just few case example. This was a 32-year male. If you see, this is a type 2C odontoid fracture, and the patient even had a vertebral artery injury on the left side. So the index surgeon tried to put an odontoid screw on, and of course it failed. So what we did is we completely avoided putting the pedicle screw on the side of the vertebral artery injury, and we chose for a interlaminar screw. And this is what we could achieve. You see, this looks like a decent reduction. This is the post-op CT, and this is the whole left from the odontoid screw that was put initially. Again, this is another case where there was again a high riding vertebral artery on one side, and we had planned a OC2 fixation. So we chose for a interlaminar screw on the side of the vertebral artery injury. What is interesting here is, if you see the contour you have to give to put the rods, if you are planning a interlaminar screw, that is very steep, and this could be really challenging. One of the most challenging which I find putting an interlaminar screw, not putting the screw but contouring the rod. So you need to plan it well. And if you are a multi-level construct, then it really gets tricky. So you should be aware of this small difficulty which this screw can give you. If you look at the comparison of biomechanical stability between the C1, C2 fixation, this was a very good study. It's a in vitro study, so it was done on fresh frozen human cadaver, and they analyzed the data between the interlaminar screw and the pedicle screw, and they found that the stability of both the screw was comparable at 1000 cycles of axial loading. But the pull-out strength of the pedicle screw was slightly better, but that too was statistically insignificant. So at the end of the day, C2 interlaminar screw is safe, it is biomechanical stable, it is a good salvage option when you have a problem with the vertebral artery anatomy, or the bony anatomy itself is not good enough to pass a pedicle screw. So that's it. Thank you so much.
Thank you, Ayush. Thank you very much. So any questions for Dr. Ayush? So I have a question, Ayush, just one last one. How do you ensure that your screw has not cut the anterior cortex and gone into the canal?
So most important is you keep looking at the anatomy of the lamina. So if you are parallel to the lamina, it is like walking into a cortical bone, and you have to rely on the feel. So you move the direction of the lamina. If you see, you need to expose the lamina good enough to understand the direction. And if you are parallel to the lamina, there is very less chance that you will hit the cord which is on the ventral side. And that's why I think is the most important thing.
So Kshitij, any further takes on that, since you have a fair bit of work on interlaminar screw?
No, I think I agree with him.
It's a very good salvage method. We have used it in about 3 patients, and it's really good. The whole
my go-to screw after a C2 pedicle screw is a laminar screw. I almost never
Right.
use a par screw. So
Right. Strength wise, it is much better than a par
Yeah.
screw. I see.
Yeah.
I see. Yeah. Okay. Thank you very much. Uday is staring at all of us because we have short the time quite a bit. And I take this opportunity to thank all the panelists. We had a very interesting session. There was quite a bit of learning. And if you have any further questions, we can always take it on the chat box. So thank you very much. Thank you, Uday, for
Sure.
allowing us to conduct this session.
Yeah, Uday.
Thank
Yes,
you.
Sandeep,
Thank you. Thank you, Sandeep, and thank you all the panelists. So after the heavy duty cervical spine, we break for 10 minutes and then we'll join sharp at 3 o'clock for the minimally invasive spine surgery module.
Thank you.
Thank you.
So delegates, please join in. We are starting after 5-7 minutes. Please do join in. For those who have joined recently, those who are not there for the first 2 workshops, you just have to log in with your email ID. That's it, which was given for the registration. The panelist, the faculty can join with the different IDs. The delegates have to join by just email. Please do use the chat box to ask the questions to the faculty. All the questions will be handed over to the moderators and they will be taking the questions as and when you guys reach out to them. We'll be starting sharply at 3 o'clock. The session is going to be on minimally invasive spine surgery, all the recent advances from the cervical as well as the lumbar spine. And Dr. Nikhil Arbati and his team are going to moderate and shall be taking you through that. Please freshen up and join us at 3 o'clock sharp. So welcome back, delegates. Just 1 minute to go. And may I welcome the moderator for this session, Dr. Nikhil Arbati, to take over the session from here. Delegates, please do log in. Please ask as many questions as possible. We'll make sure that all of them are answered during the next 2 hours. Do have a blast. Over to you, Nikhil.
Yeah, thank you, Uday. And thank you to the entire BSSCON team. And me and Dr. Amit Sharma will be moderating the MISS workshop. This is the third workshop today. I think you both have, all the delegates have interacted very well with the first 2 workshops about the basic lumbar spine and the cervical instrumentation. So carrying on, we'll be going on to the MISS workshop. This will encompass all the minimal invasive techniques that are being done now, the tubular systems, the posterior tubular systems, the endoscopic systems, the MIST lift, the navigation and everything. And we have got esteemed panelists who are going to give talks on each and every topic. So me and Amit would encourage all the delegates, any questions that you have, please put it on the chat box, anything that you want to ask. Within this session, we would try to solve all your queries and doubts. Amit?
Yes, Nikhil. So we have a jam-packed session, and there are multiple talks. And I think we are starting with you, Nikhil. So Nikhil will be giving you an overview about the basics about the minimally invasive spine surgeries, and then from there we'll go further.
Yeah.
Nikhil, over to you. Please continue.
Yeah, thank you. Can I start my screen share?
Yeah, sir. Sure.
Yeah, so is it visible to all?
Yes, Nikhil, we can see it.
Yes. Yeah. Fine. So basically, this is going to be just a small talk. We have got the major talks going on. So what I just wanted to talk about is the basics and principles of minimal invasive spine surgery. So what is minimal invasive spine surgery? Does it always mean a small incision, less muscle dissection, less blood loss? We have got a lot of adjectives MIS surgery, and basically patients themselves don't have a true knowledge of what a true minimal invasive surgery means. So what is exactly the real concept of MIS? So in my fellowship, what I had learned about the minimal invasive was it's a targeted approach which should have minimal normal tissue displacement with maximal benefits and should help in early patient recovery. So these basically form the 4 basics of a minimal invasive spine surgery according to me. So first is a targeted approach. Always confirm the diagnosis and the level that you want to do. Especially if there's a multi-level degeneration and you're not sure what is the level. Apart from the clinical and radiological examination, what I do is you should always try to give blocks if you're not sure of the level. If it's a stenosis along with a disc prolapse and you're not sure what is the exact pathology which is causing the patient to come for a surgery, always have a proper clinical examination, ask him this thing, and you can also go for blocks in such cases. If you're not sure whether the stenosis is apparent in an MRI, get a CT scan done. Sometimes you can see a bony stenosis very well in a CT scan compared to an MRI. Always get a dynamic X-rays done, because you may end up doing an inappropriate surgery if there is a subtle instability. Just to highlight how it is, multi-level stenosis, if you're not sure, go for root blocks, which I always do, so that you are sure what is the main level which is causing the problems. If there is a stenosis along with a disc prolapse, always better to have the patient give a proper history, examine him properly to find out what is his problems, whether it's a disc radiating pain or it's a claudication symptoms. Where you have like this patient who had an alpha S1 subtle, stenosis and with a degenerated disc. If the patient had claudication symptoms, would have been wanted to do only a decompression, but on a dynamic X-rays had an instability. So you would land up doing an inappropriate surgery if the dynamic X-rays were not checked. Second is a minimal normal tissue displacement. So this does not mean that you should choose to do a tubular system or an endoscopic system for each and every case. You should also have an examination of the patient, his anatomy, and the MRI pictures to decide what is the best system to be done. If you have very thin patients, we get thin patients who may be just 35, 38 kgs, a very small skin to bone depth. Even if you're doing with a tubular retractor of a 4 centimeter depth or with a Macculus retractor, you will get the same results. In cases where you have a very small interlaminar window where there's a congenital stenosis, you're doing a decompression with the tubes, and if it's not appropriately done, you may be causing iatrogenic instability. as it is in this. A very thin patient, even if you do a McCullough's retractor decompression or do with the tubes, you will get the same amount of benefits. Or in cases like this, where there is a very small where there is a stenosis with developmental this thing, you will end up causing iatrogenic instability if you don't do it properly. So always see the patient's anatomy and the MRI pictures before going ahead with the type of technique that you want to do. Third is maximal benefits. So any kind of minimal invasive surgery should not only reduce your post-surgery analgesics requirement, but should also help in early mobilization compared to a traditional surgery. Apart from that, we also try to reduce the chances of recurrence and ASDs through a minimal invasive approach. As we know, we do it through minimal paraspinal muscle dissection and minimal bone dissection. And finally, the benefits of minimal invasive surgery and the basics is the patient should be mobilized as early as possible. If you're doing a transforaminal endoscopic discectomy, as Dr. Pradeep is going to tell, these are done under local anesthesia. The patient can be mobilized 2 to 3 hours after the surgery. So this is another basic and principle of a minimal invasive surgery, which I was taught in my fellowship. So to conclude, a minimal invasive surgery is an approach, approach to target the main problem. You should have a proper clinical assessment, a radiological examination, and any investigative modalities that you require to confirm the diagnosis before targeting that one particular level. Choosing the technique should not only be based upon the surgeon's experience, but you should also have a good idea about the patient's anatomy and the etiology, and should also look at the radiological films properly before deciding the approach. Thank you. Yeah, Amit?
Yes, so I'm going next.
Yeah, so we have, and he's going to talk about the armatorium, about the minimal invasive techniques, and the Huzu, and everything about the MIS techniques. So delegates, if you have any questions about this after the talk, please put it in the chat box. Over to you, Amit.
Suvita, can I be on?
Yes, 99 at BSSCON.com.
So, yeah.
Good. BSSCON 2020. Dr. Arbati has given you a brief overview about the minimally invasive spine surgery. I'll be talking about how these surgeries can be done with the help of the tube. The principle of minimally invasive surgeries are well known to each one of us. They provide less soft tissue dissection. The bleeding is less. The amount of pain the patient perceives after the surgery is less. Recovery is faster, and patients are able to get back to their work also faster. In the past, people have used these kind of retractors like curved Homan or McCullough retractor also, which is even now very commonly used. However, with the advent of newer technology and better understanding about the minimally invasive surgeries, most of the people have switched over to the tubes. So the tubes have basically two parts. One is these dilators. So dilators are, the advantage of dilator is that they are not going to strip the muscle off the bone. They are going to dilate the muscle. So the soft tissue damage is minimized. And you pass these dilators one on top of each other, and over the dilator you will pass your tube or a cylindrical retractor. Basically, whether it's a decompression or instrumentation, both kind of surgeries can be done with the help of these tubes. If you are planning to do a decompression, then the docking of the tube will be on the lamina medial to the facet joint. You do your ipsilateral decompression, and then you tilt the tube to the opposite side, and you can do the contralateral decompression also through the same laminotomy approach. In severe cases, you can actually dock the tube on both sides, right and left, and then do bilateral decompression individually. If you are planning to do an instrumentation surgery, wherein your aim is to do interbody fusion, the docking of the tube and dilators will be on the facet joint at the level of interest. So the dilators are passed one on top of each other, and then you confirm the location of the dilator with the help of your C-arm X-ray. In this case, the area of concern is L45, so the docking is done at the L45 facet joint. On top of these dilators, the tube will be passed, and so this is the area under concern. When you are fusing a particular disc level, the inferior articular process of the upper vertebra and the part of the superior articular process of the lower vertebra is resected off to get the direct access to the disc. And then you work in the axilla of the upper disc for your interbody preparation, and with the help of the same channel, you can do the decompression also. In fact, a cage also can be passed using the tube, and you don't necessarily have to enlarge your incision or do kind of convert it into a open surgery. There are certain other options also available, like these expandable tube which will open up at the very bottom, and these kind of retractors which is made up of two half parts of the cylinder, which can be opened up to get more access to the area where we are doing the surgery. The issue is that whenever we are using these expandable retractors, they provide some space in between from where the muscles can creep in, and that might come in your view and can obstruct your vision of the surgical field. The other major requirement for any kind of minimally invasive surgery is that you need these longer instruments, and preferably bayoneted ones, so that when you are working, the handle of the instrument and your hand is not coming in the vision, and it's not obstructing your view of the surgical field. To get, as we know that minimally invasive surgeries are done through a smaller hole, so the overhead light will not be sufficient to illuminate the surgical field. So we need some kind of magnification and illumination tools. Either you can use the surgical loops along with the headlight, or most of the time the surgeons are using these kind of microscope which will provide the necessary illumination and magnification to achieve the job. Thank you very much.
Thank you, Amit, for a very nice, lucid talk. So, Amit, just one question.
Yes, Nikhil, please.
So, while doing this minimal invasive surgeries with the help of tube, do you find the loop is better, or you find with the microscope it's always better to do ahead with it?
So microscope definitely provides a better vision, and magnification also can be more than loop has a fixed magnification. But with the microscope, we can kind of modify it depending upon the case. The other advantage of having a microscope is that what you are seeing, your assistant is also seeing the same thing, which will not happen with the loop and headlight. Yeah. The third thing is that you can do a good recording with the microscope. The only issue with microscope is that the good quality microscopes are very costly and they may not be available at every place. So just because somebody doesn't have a microscope, it shouldn't be an hindrance for him or her to from doing this minimal invasive spine surgery. So I think if you don't have access to microscope, then surgical loops and headlight
operations you can do with the help of loop. Yeah, good. Yeah. And
Nikhil, you are next. You are talking about the use of rigid tube for lumbar decompression. So please go ahead.
That's my talk. Yeah. So I'll just start with that. Suvida, can we just have that talk?
Yes, sir.
Suvida, can we just have that talk? Available. We have the rigid. Hello everyone. Today I'm going to speak about using the rigid tubular system for doing a lumbar minimal invasive discectomy or decompression. There are various types of tubes available. We have the rigid tubes and the expandable tubular retractor system. While for beginners, using the expandable tube may be good because with that you have an orientation of the anatomy, and using the microscope is also good. But as you progress further, using the rigid tube is much better and it can be used frequently for all cases. There are various systems available. We have the Matrix or the Spotlight system from Medtronic and Depu. We also have the Indian-made systems from Pitker and Jesco.
The very basic configuration of any rigid tubular system consists of the following components. A bed clamp. This is used for attaching the retractor system to the OT table. An assembly. This connects the bed clamp to the retractors. We have the dilators for dilating the muscles so as to create a field for placing the final retractors. And finally, the retractors, which are available in various depths and diameters. The Pitker tubes which are commonly used are available in diameters starting from 13 mm with 3 mm gradations and which finally reach up to 25 to 28 mm. They are starting from 4 cm depths and go up to 10 cm with 1 cm serial gradations. This is how the Pitker system looks like. This is the bed clamp with which you have the assembly connected to the OT table, you have the various dilators, and you have the various retractors. Now, what are the benefits of the rigid tubes? First of all, it prevents any muscle creeping. So whenever you're doing a discectomy, you don't require any further retraction. This gives you a complete closed enclosed field. Secondly, it can be moved cranial and caudally very easily and also medially to do the entire kind of decompression. You can do a superior, inferior decompression, and you can do over the top also. Also, when you're doing a T-lifts, if you want to jam in the cage and while using an expandable retractor, there are chances that one of the blade can come off. But unlike this, in a rigid tube system, it does not happen. And doing a posterior cervical foraminotomy also can be done very easily with the help of the rigid tube system. So, what are the landmarks for doing the tubular minimal decompression or discectomy? There are two places where we can dock the retractors. One is either over the spinal laminar junction or secondly medial to the facet over the inferior lamina. I use the docking point which is medial to the facet over the inferior lamina. And this is the thing where I would show for the beginners. So for this, after positioning the patient prone, take a true AP. The true AP is where the C-arm is where the spinous process is midline between the two pedicles. Now, once this is confirmed, then you mark a skin. You can take a marker and mark a line vertical just medial to the facet or pedicle of the level that on the side that needs to be operated. Thus, if you're doing an L4, L5 discectomy, mark the line just medial to the L5 pedicle or the L4-5 facet from the side which you're going to operate. Then you mark a horizontal line over the disc space that you're going to operate. Both the lines where these join each other, you place an 18-gauge needle over the junction of these two lines, and then you take a true lateral image. This needle will be pointing directly to the disc space. So this is how a true AP image should appear in a C-arm. Then you mark a vertical line just medial to the facet, and you mark a horizontal line over the disc space. The junction of these two lines is where you'll be docking the retractor, and this is where you put the 18-gauge needle. And after putting the 18-gauge needle, this is how it is there. This is where the retractor will be docked, just medial to the facet. And when you take a true lateral, this is how the needle is just pointing towards the disc space. What are the initial entry and steps? Now, once you have marked the entry point, after draping, you can take a 1 centimeter vertical incision. This should cover the disc space. After cutting the skin, reflecting the subcutaneous fat, then you reach up to the paraspinal fascia. Now, this paraspinal fascia you can cut with the help of a pottery. Just make a clean vertical incision, and then after that, you just put your index finger and try reaching up to the facet. Once you have reached up to the facet, then you can just push the muscles just medial to the facet so that you can dock the initial dilator. The initial dilator just should be placed medial to the facet, and once you have confirmed that it is firmly placed over the bone, then you pass the serial dilators till the required diameter of the retractor that you're going to use. So if you're going to use a 19 mm retractor, then the 19 mm dilator is what you need to pass. Once you pass the dilators up to that particular diameter, then you check the depth of the dilator which is over the skin and choose the retractor blade accordingly. After passing the retractor blade, then you connect to the assembly to the bed clamp. So this is how the steps appear. I have palpated the facet, reflected the muscles, passed the first dilator, docked it over the middle part of the facet. This is the facet, then passing the serial dilators up to the depth of the diameter, up to the diameter that I'm going to use of the tube. So I usually use a 19 mm diameter tube. So I pass the dilators up to the 19 mm. In between I do a wanding so that the muscles are not creeping over the interlaminar space. Then I check the depth of the dilator which is over the skin and pass the appropriate retractor. This retractor is just railed over the final dilator. There is no muscle which creeps in between this. These are very snugly fitting dilators. Now the assembly arm is connected with the help of various screw attachments to the retractor.
and it is tightened. And this tightening of the assembly arm will help in making the retractor firm and fixed over the place where you want to operate. With the help of the screwdriver, you can tighten the screw which connects the retractor to the assembly arm. And then the final tightening of this. So once this is tightened, this becomes a rigid system. It does not move, and you should take a lateral image to confirm that you are directly placed over the this space. Once you have placed the retractor, then you can bring the microscope in and just remove any soft tissue if it has crept in. And once you have removed the soft tissue, this is how it appears. Now this is the cranial portion of the body, and this is the medial portion. I usually start by using a burr as part of the superior lamina. This helps in saving time and also does a very smooth thing, prevents bleeding. I use a cutting drill bit of 5 or 6 mm diameter. So you can very safely use this up to the lowermost part of the lamina. Also, when you're using the drill, make sure that you do it in sweeping motion. Don't just jam it at one portion, otherwise you may suddenly give way. You can just suction out the bone dust, and whatever the bleeding which comes, you can just pack it with bone packs. Now, after you reach the lowermost part of the lamina, the innermost part, you can, with the help of kerosene punches, just nibble off the lowermost portion so you can start seeing the phlegm. Furthermore, if you feel you want to save time, you can use the burr very safely. As long as the phlegm is not exposed, you can use the burr. Now, as I had shown, the retractor blade, it can be positioned up if you want to push it more superiorly. You can very safely use the burr system to burr out the bone as long as the phlegm is intact up to the innermost layer of the lamina. So you can see the phlegm there in the interlaminar space. And with the help of the kerosene punches, you can nibble off the final innermost layer of the lamina. You have to keep on nibbling off the bone on the superior and then the lateral portion. The lateral most, you can take off the bone up to the medial part of the facet. Once you have done that, then you can see the space which is created between the superior part of the phlegm and the lamina, and you see the epidural fat and the vessels. And this is where you can push the ball tip probe and strip off the phlegm. Create a plane. Once you have created the plane, then with the help of 2 and 3 mm kerosene punches, you can take off the phlegm. Always take out the superior and the lateralmost part of the phlegm, because usually you require that much to be taken out so that you can see the traversing root and for the retraction of the root for doing the discectomy. So here we are removing the lowermost part of the phlegm. Once you have sure that you can see the traversing root going into the foramen, when your lateralmost removal of the phlegm and the inferiormost is done. Now next is when we start to do the discectomy. So for that, we push a nerve root retractor where we retract the dura and the nerve root, and you can just coagulate the epidural vessels which are seen over the disc space over the perineum. And any more additional bleeding if it's happening, you can just push a patty and push it superiorly so that the bleeding does not come in the way of a discectomy. That should take care of the bleeding. Then with the help of a 15 number blade, you can just make a small rent in the disc space, and with the help of appropriate kerosene disc punches, you just remove the disc. I also use a ball tip angled retractor so as to tease out any disc material which is stuck and which does not come out easily, does not pop out on making a stab incision in the disc space. With the help of the retractor, what you can ask your assistant or your junior to just push the disc material out, and this is the disc pieces coming out. Always try to make sure how much disc is coming out. Keep it in a water bottles in a bottle so that you can be sure that the amount of disc that is removed is matching with what is seen in the MRI picture. Keep on removing the disc space till you're adequately sure that the root is completely free and mobile. Young patient will have a very healthy disc and it may take a little bit of effort to take out the disc material. Once the entire disc is off, then I give a disc wash, intradiscal wash, by pushing a 1 mm suction cannula inside the disc space and just giving a good wash. So any floating pieces of disc material, if it's remaining, that is also comes out, and with the help of disc punch, you can take those off. Once done with the disc wash, you can just check with the ball tip handle probe that the root is free. You can see the entire pulsating dura and the nerve root. Then, once this is confirmed that it's adequately decompressed, take out the patty, just give a proper thorough wash and put a gel foam and pack it. And once this is done, then you can take out the tube and just finish it. Yeah. Yeah. Thank you, Amit.
Yeah, Nikhil, that was a fantastic surgical video. So one of the question I have, whenever we do these kind of minimally invasive procedure and you are doing a discectomy, and if you have an incidental durotomy, how would you deal with that?
So basically, it all depends upon whether it's a small rent or you have gone very deep. If it's just a small nick and you just have a superficial this thing, what I do is after the procedure is over, I just put a surgical over it and tissel and just close it with a watertight closure. You don't require anything. If it's a proper rent, it's gone deep and you have CSF coming out or sometimes a root, then in such cases, very seldom in such cases, you may have to convert it into open and suture the dura. But majority of the cases, it's just a small nick where you're while retracting or while putting the disc punch where you get it. And sometimes it's on the under surface, so it's not repairable also, even if you want to open it. So what I do is after finishing the procedure, I just put surgical mixed with gel foam over that area. I'm first tissel and then this, and then just would do a watertight closure and just observe the patient. That's it.
Secondly, if you have a significantly migrated disc, superiorly or inferiorly, then how would you change your approach so that you can tackle that part of the disc as well?
Yeah, so as I'd shown with the tubular retractors, once if you feel that the disc is migrated superiorly or inferiorly, after you have done the laminotomy, then once you get the root seen and you have done a lateral recess decompression, you can wound the tube upwards or downwards till you are sure where the disc is there. I mean, on the MRI, you will know if it's inferiorly migrated, it may sometimes be over the lower vertebral body or sometimes may reach even up to the lower pedicle. So you should wound the tube up to that much and do a bony resection with that. You are doing as such a inferior hemilaminotomy only. So you're not going to destabilize anything. And if it's superiorly, you can go up to as superior possible. If you want to do a complete hemilaminotomy, you can do that also. But you won't be destabilizing anything. Make sure that you reach where in the MRI picture it is shown that the disc is located. And still, if you're not sure whether it's reached there or not, again take an image after you have done this bony work to confirm that where you have placed the tube and where you're doing it, it's the appropriate thing.
Thank you very much, Nikhil.
Yeah. So now we have the talk, I think, from Dr. Arvind Kulkarni. And
dear friends, it's a matter of great privilege and pride to be a part of this great workshop. I thank Dr. Nikhil Arpati, Dr. Amit Sharma and the organizing committee for involving me in this workshop. This first slide is basically to highlight that tubular techniques are well established globally and to also reinforce the fact that one can achieve a 360-degree global decompression using these tubular retractors. Now, the crux here is to basically decompress the canal without harming the supporting structures, that is, the soft tissue structures, and without harming the lamina. Laminectomy is basically just an access to reach the intracanalular components. And how do you reach it? You reach it through these tubular retractors. Positioning is very important. I usually put the patients on horizontal postures. This is basically to support supports the chest and pelvis and keeps the abdomen free, and thus minimizes epidural congestion and bleeding. And most importantly, most vitally, the lumbar spine is in lordosis. That is, the patient is in his or her most symptomatic position, and if you decompress in this particular position, you've probably achieved a thorough decompression. Localization of the level is half the work done. It's very, very important, and it's we basically customize the parameters based on the patient's body structure and the morphology. The entry is lateral to the midline, ranging from about 1 to 1.5 centimeters, and this is based on the lateral image. This is basically based on the AP image, and lateral image is basically to take to localize the segment. So you introduce a needle that bisects the disc space and take an incision over it. Before you do that, I inject 20 cc of saline to soften the muscles to decrease the bleeding. And once I don't use guide wires because this can inadvertently penetrate the dura and cause a dural tear before you actually started the actual surgery. So we usually pass the first dilator followed by a series of dilators of increasing diameters. The length of the incision could range from 18 to 20 millimeters depending upon the size of the tube that you're going to use. The tubular retractor basically lands in the valley between the spinous process and the facet joint. The depth of the tube is determined by the dilators, which are markings on them. So the tubular retractor, the final port, is docked to the table. It is not a fixed angle tube. It can be tilted in various directions, above, below, medial, lateral, so that it helps in executing a thorough decompression. So you do a ipsilateral laminotomy, then you see the flavum, then you tilt the table to the opposite side. You also tilt the tube and the microscope to the opposite side, tilt the base of the spinous process, as well as the inner cortex of the opposite lamina till the lateral recess on the opposite side. You see the entire sheet of flavum from one end to the other. Then do a decompression of the opposite lateral recess, verify it with a nerve root probe. Then tilt the tube to the ipsilateral side. Again, do a thorough lateral recess decompression of the ipsilateral side. Again, verify it. So this depicts a video of a patient who has undergone decompression at L4-5. On the right is the cranial side, on the left is the caudal side. Above is medial, below is lateral. So you've done ipsilateral laminotomy. This is the ipsilateral flavum. Then you tilt the tube to the opposite side. That is the base of the spinous process that is being drilled. Once that is done, you see the flavum from one end to the other. You excise the flavum of the opposite side till you see the nerve root and go beyond it to make sure that you thoroughly decompressed it. And then tilt the tube to the ipsilateral side and do ipsilateral decompression. A curved ronger may be of extreme use here because that can help in doing a thorough decompression without causing any injury to the facet. So you check that both your roots, that is the contralateral and ipsilateral, are free. And as the tube comes out, the soft tissues fall in place, thus minimizing dead space. How do you achieve hemostasis? By positioning the patient appropriately, as discussed earlier, using local infiltration of saline, using a log cautery tape to elevate the soft tissues. The burr itself is a good hemostat. Again, the other regular components which we use in open surgery, bone wax, bipolar, gel foam. If you end up docking the tube superficially, you can keep, you can do repeated docking so that you don't exercise too much of soft tissues. When it comes to CSF leak, small tears can be managed with masterly inactivity and watertight closure. One could use fibrin glue, but if there is a large tear, don't get into a panic mode. Cover the roots with the patty. Do a distal decompression. Once a distal decompression is done, automatically you see that the rootlets get into the dural sac. Then you just have to go up the edges and inject fibrin glue. Some of these tricks and tips of this particular surgery have been described in our paper, which was published last year in Spine. What to do when there is a severe stenosis, what would one do when there is asymmetry of the facet joints, what approach should one take, how can you save facet on the ipsilateral side without injuring it, what would one do if there is an asymmetric, when there is an angulated spinous process, etc. These have been also highlighted in our chapters in these popular textbooks published by ASSI and MISAB. So what are the indications? Simple stenosis without any deformity or instability. Severe stenosis, it's very important. The facet joints are big in size when you decompress. Again, multi-level stenosis, where this is multi-level stenosis, 3-level stenosis. This comes with experience, all done with one incision. Again, in situations where there is stable degenerative listhesis, we have devised a scoring system as to how to decide whether to fuse or not to fuse in the presence of a degenerative listhesis. Obviously, when it is a very unstable situation, one would advise fusion here. In certain cases of degenerative scoliosis, where there are selective levels which can be decompressed, this is in stable degenerative scoliosis which does not move in lying down and standing position. Again, synovial cysts are great indications. Surgery to an adjacent level, so the patient has instability at L4-5, we are planning to fuse L4-5, and again the L5-S1 is stable and stenotic, so why extend fusion to L5-S1? So just decompress L5-S1. So some of the teaching points, some of the tips and tricks and how to select patients are described in our other publications on this particular topic. I'd be happy to take questions. Thank you.
Yeah, thank you, Arvind, for the wonderful talk. And we have another talk by him on the posterior cervical foraminotomy.
Friends, I would like to demonstrate this technique of posterior cervical foraminotomy using a tubular retractor with this particular case example. This is a 54-year-old gentleman, a known case of diabetes. He complains of left-sided upper limb pain, which basically involves the C7 dermatome. It's quite severe, and all modes of conservative treatment have failed. As I said, it's a C7 dermatomal pain. Swirling is strongly positive. On neck flexion test, he has complete relief of pain, indicative of foraminal stenosis. He has no motor or sensory weakness except for absent triceps reflex. There is no other neurological sign. Now, this is his X-rays. And you can see there is an osteophyte in the sagittal image at C6-7, and this is on the left side as seen here. If you compare the right and left foramen, the left foramen is quite significantly tight. So these are all the options that the patient has. So we decided to do a posterior tubular cervical foraminotomy in this particular patient. So this is how we went ahead. So it's not a very commonly performed or used technique. So the patient is, as described, he has left-sided arm symptoms. He has a positive swirling sign which gets relieved on flexion. So this is positioning on the table. The arms strapped, pulled so that the C6-7 level is seen well on imaging. So this is how the microscope is positioned. So it's very important to concentrate on this particular picture here. So what you need to do is you have to identify this Y. So the Y has two arms. So the one arm is the inferior border of C6, the other arm is the superior border of C7 laminae, and this is the facet joint line. So that is the vertical of the Y. So this is very important to identify. So you need to decompress these three lines, okay, sequentially to decompress the nerve root. So therein lies the crux of this entire surgery. So your tube has to land at this particular critical spot. So that is how the soft tissues are elevated using a long cautery tip. Redundant soft tissue is excised. It's basically fat and some loose muscle tissue. So that is the superior border of C7 lamina. This is the inferior border of C6 lamina. These are the two arms of the Y. So the laminae are quite thick and it needs quite a degree of drilling to reach the inner cortex of these laminas, wherein usually it is thinned out. So when you have bleeding coming from the cancellous bone, if it is troublesome, use bone wax. So that is the. So again, there is some more bleeding there. You should notice. That can be sometimes just managed with again bone wax. As shown here. Very important to have a bloodless field. It increases the elegance of the again bone wax. Very important to have. Very important to have a bloodless field. It increases the elegance of the operation. So once the lamina edges are thinned out, using a 2 millimeter Harrison bronzer, these edges are excised, and as they get excised, the neural structures get revealed to the lateral edge of the spinal cord and the nerve root. You can see the nerve root, the root of the nerve root. So you can see how significantly it is compressed. It looks purple and angry. Intermittently, you need to drill some more if you feel that the bone is thick, the edge is thick, and to go laterally, one might have to tilt the tube a bit laterally to reach the distal confines of the root. So using a nerve root probe, one can explore the foramen. So the tube is tilted laterally to make sure that the entire trajectory of the root, the entire root of the root is very well decompressed and the tubular retractor comes out. So this was done using a 14 mm tubular retractor, and this is an academic CT showing the laminotomy without causing any instability. So you described this technique at various platforms. What are the contraindications? Cervical kyphosis, and obviously if there is a central compression. So basically it is a road less traveled, this particular technique. It is an option in selected cases, not all cases. It is a motion preservation surgery. There is no implant necessary. You don't need an artificial disc or a fusion device. It's less extensive. The incision is so small. The soft tissue injury is so small. You also avoid all the complications of anterior approach, especially dysphagia, which the patients are not very happy about. Again, to conclude, it carries all the benefits of minimally invasive spine surgery, like minimal trauma, minimal pain, earlier recovery, lesser dependence on analgesics, shorter operative time, elegance, and an appealing cosmesis. Thank you.
Thank you, Arvind. Thank you for those talks. Do we have any question, Nikhil?
Yeah. So, Arvind, hi.
Hi.
So, very good talk upon the posterior cervical. So, for the posterior cervical, doing for a soft disc is better, or for stenotic is much better? I mean, which is the better indication if a beginner wants to start?
Yeah, so I think foraminectomy is a better option for a beginner, because you don't have to delve into the disc area, because it bleeds a lot. You should remember here that the disc herniation is usually the approach is through the axilla, not the roof, because it's just impossible to move the root, and you have to basically drill the upper part of the pedicle to reach the axilla, use your nerve hook and get your disc out. And you should have very good control over bleeding, otherwise it bleeds a lot. So I think initial cases, one should choose cases like this. These are very pinpoint cases, I can say, where patient has foraminal stenosis. He gets this patient complaint that he never slept supine for last 6 months. So it is like an indirect Sperling test, So, and when you flex his neck, the pain goes away. These are kind of cases. The selection of cases should be good. Even if you have a hard disc anteriorly, you don't have to touch it. If you have a foraminal stenosis, you just de-roof the foramen, the pain goes away.
Okay, so that's a good point. That's a good point. Any particular? Sorry. Yeah, Amit.
Arvind, do you do a CT scan beforehand, like preoperatively, to ensure that whether it's a soft disc or hard disc?
I think to an extent you get an idea with the MRI. Unless required, I don't do a CT. But post-operatively, this we did just to know how much of facet we compromised. So that was the reason we did this academic CT. Otherwise, I wouldn't do a post-op CT.
Okay.
Yeah, that's a good point.
Arvind, yeah. Hello, Ashok here.
Hello. Hi.
Hello. Hi. Arvind, do you have any experience of doing a laminectomy for multi-level cervical spondylotic myelopathy through this tube by moving it up and down?
I don't think I wouldn't dare to do it. Probably, I don't think it serves much purpose because most of the times when we go posterior, it is for a multi-level stenosis, and doing C3 to C6 or C3 to C7. I don't want to jeopardize a patient's capability to gain his neurology back. So I won't do it. I won't suggest also to do it.
Because I particularly raised this because I think in one of the cervical spine APSS Shairasi showed his cases of doing only laminectomy with his technique of exposure, where he preserves those muscle attachments. And then he says even in even in a sumo Pahalwan also, he did this without fixation, and patient is doing absolutely fine, no post-laminectomy kyphosis and all these things. So like in your technique, where we use the tubular this thing, and obviously we don't damage any of the interspinous ligaments or something. So I think probably it could be of use, but
yeah, but I think it also takes a lot of time.
That is true. That is true. Yeah.
I think these MIS techniques are good for focal lesions. I won't. Even doing the 3-level or 4-level TILIF, I would think it is a waste of time. Up to 1 or 2 segments is fine. Beyond that, it is gruesome in terms of time, energy, effort, and cost.
Yeah, basically the time requires a lot if you're doing multi-level through a MIS.
Yeah.
Nikhil, for the interest of time, I think we should move ahead. Next, we have Dr. Samir Ruparel. So anyone who is starting with the MI surgery, it definitely has some learning curve, and in the beginning, we are definitely going to face some challenges. We'll have some complications also. So let Dr. Samir Ruparel enlighten us with how to proceed with the thing in the beginning. Samir, please continue.
Yes, sir. Is my screen visible and I'm audible?
Yes, go ahead.
Thank you, sir. Very good afternoon to everyone. We have so beautifully seen the technical demonstration of MIS surgeries by the masters in the previous lectures. But when we as beginners, we start with MIS surgeries, the first thing that comes to our mind is how to reduce the learning curve. And that is what I'm going to speak to you about. So it has been proven well in literature that the tubular microscopic surgeries have perioperative complication rates of almost as high as 17 to 19%. And it has been, it can be due to any of the causes which have been listed over here. For example, it could be due to prolonged surgical time, dural injuries, inadequate decompressions, or facet injuries. Well, the recent literature that we have worked on, the learning curve of MEDs as well as the MIS TILIFs, the good part is that most of these perioperative complications can be effectively reduced by proper preoperative planning. And they are mainly restricted to the first 25 cases usually. So here are 5 tips in the first 5 minutes. Tip number 1, indication. It is very much necessary to know the source of pain, whether it is a disc, a facet cyst, canal stenosis, because that is what will dictate the MIS surgery. For example, if it is a far lateral foraminal disc fragment or even a facet cyst, it is better to dock the tube on the contralateral side to get the adequate trajectory. Similarly, as it has been discussed before, it is very much necessary to avoid complex cases in the beginning. Developmental canal stenosis, it becomes very much difficult to decompress these without harming the facets and the parts. In cases of severe facetal arthritis, the facet osteophytes may impinge very close to the spinous process, making docking of the tubes very difficult. Multi-level stenosis, it's very time consuming, and high level stenosis decompression becomes difficult without harming the dural structures. So very much necessary to follow the step ladder pattern. Initially start with discectomies, then go to lumbar canal stenosis, attempting the over the top decompressions, and then graduating to MIS TILIFs. Similarly, we need to get used to the tubular vision and operating through narrow passages. Getting oriented to the hand-eye coordination of the microscope also requires some time. So attend as many workshops as possible, lectures, read the articles, observe and assist the surgeries, and do first on a cadaver. Well, if you're not fortunate enough to have a proper formal fellowship training, then you can start docking the tubes in open surgeries, even use a microscope in open surgeries to get used to operating in narrow passages first. Tip number 2, the pathoanatomy and proper preoperative planning. Anatomic orientation is very much important to have that, because it is only this green line is what is actually visible through the tubes. You should know where the ligamentum flavum, the spinolaminar line, the nerve roots, the pars and the facets are. For example, if there's an up migrated disc or a downward migrated disc, it is necessary to warn the tube accordingly to target these pathological lesions. Similarly, there are variations in the anatomy which are very much easily seen on the pre-op scans. The spinous process may be inward projecting, which may make the docking very difficult. At the same time, it may be outward projecting. A properly docked tube might shift laterally. For sagittal, facetal orientation, tropism, all these things we need to see properly on the pre-op scans. Which nerve is getting affected? Are there any anomalous roots? Remember that MISS is basically a C-arm guided procedure. There should be a proper correlation in your minds regarding the radiological anatomy and the pathoanatomy. Tip number 3, intra-op preparations. A lot has been described about the armamentarium that is necessary, but it is always great to work with an efficient C-arm technician. It reduces the operating time to a great extent. This is because, we need to have true AP and lateral images. And if we have someone like that, we continuously work with a good C-arm technician, it helps. Similarly, always invest in long and bayoneted instruments, which are must before embarking on MISS surgeries. Achieving normal lordosis, protecting the bony prominences, keeping the abdomen free. This is because, if the abdomen is getting compressed, there is a lot of intraoperative bleeding, which is one of the enemies of MISS surgery. We need to keep the patient strapped because while attempting the over-the-top decompression, we need to tilt the table too. Tip number 4, tube docking. An improperly docked tube is again an enemy of MISS, which increases the surgical time, causes suboptimal decompression, may injure the normal facets or the nerve roots. So avoid guide wires. As it has been previously said, it causes inadvertent dural injuries due to piercing through the interlaminar space. Use a first dilator instead. The skin and the facial incision should be in line with each other. The angulation of the tube is also important. It should be in line with the disc space or target the pathology, be it at L3-4, L4-5 or L5-S1 levels. Last but not the least, the principles of over-the-top decompression. Preserve the ligamentum flavum. It acts as a protective layer to protect the dura until all the bony work is over. Avoid blind bites because this can cause dural injuries. And hemostasis. Now, there are 3 reasons for which the bleeding can occur. The first is the muscular. Don't bite it. It is always necessary to cauterize it. It automatically retracts away from the tube. The bony bleeding can be controlled judiciously with the help of bone wax and the epidural bleeding with the bipolar. Thus, always choose the right patient, plan the surgery well in advance, prepare for the surgery, and follow the principles of tube docking and over-the-top decompression. Thank you.
Yeah, thank you, Samir, for the well-done talk.
Thank you, sir.
Yeah. So, Samir, for a beginner, what are the main points you would want to just highlight from your talk, summarize? If you are just starting a new surgeries and you are just going to have a tubular system, should they use the rigid tubes, expandable tubes, and what are the cases that they should first have?
So I think starting with the expandable tubes is much more necessary than graduating to the rigid tubes, because this helps in getting oriented to the anatomy which one sees through the tube. And as mentioned in my talk, I think it is very much necessary to avoid congenital stenosis or those with severe facetal arthropathy or high-level stenosis, those patients with multi-level stenosis. I think we need to avoid these cases right in the beginning of the learning curve to avoid problems.
All right. And what about the magnification systems? I mean, you have been starting doing now minimal invasive regularly. Would you feel the difference, as I had asked Amit, with the microscope much better when you're starting with the initial cases?
Yes, I think I was very much, I would say, fortunate that during my fellowship, I had the training under the microscope. So it was a great thing. But yes, as Amit sir mentioned previously, that if someone is not fortunate enough to have the microscope, we can use in smaller setups, we can use the loops and the headlight.
All right. And I think doing a cadaveric workshops and all also help a lot in getting an orientation of the anatomy.
True, sir. True. Extremely right.
Right. Amit, Arvind, Ashok, sir, you want to ask any questions?
One quick comment, can I hear?
Yeah.
Yes. So one of the tricks I started with from going from an open to MI surgeon is first few cases what I did what exactly I do with open, put my tube just to get oriented and then do the surgery. That helps you get oriented instead of going through a tube directly.
Right.
Do what you do. Put your tube and then try to realize. And then slowly, within 4 to 5 cases, you'll get a hang of how does it look under the tube. That's just a small tip for us.
Yeah, that's a good point, Ayush. Very well. Yeah.
So next we have Dr. Akhil Tavri. As we know that for any kind of MI surgery, especially when instrumentation is involved, then percutaneous pedicle screws are one of the main armamentarium which we use, should be in our armamentarium to be used for spinal fixation. And Dr. Akhil Tavri is going to enlighten us about how the percutaneous pedicle screws are passed in lumbar spine. Akhil, please go ahead.
Hello everyone, my name is Dr. Akhil Tavri First of all, I'd like to welcome all the delegates to the BSSCON 2020 MISS workshop. The topic for today for me is fluoroscopy-guided percutaneous screws. So let's begin. Now, indications: percutaneous screws have wide range of indications for any instability, including fractures or spondylolisthesis in the dorsal lumbar or lumbar spine. It is extremely important for the 360-degree fusion surgeries, including the MIS T-lifts or the lateral lumbar interbody fusions, or the recently getting popular oblique lumbar interbody fusions. The advantages, as we know, is rapid post-operative recovery. There is less post-operative pain because there is less trauma to the back muscles. Also, the advantage for a fluoroscopy-based percutaneous screw is that good quality C-arm machines are now pretty much available everywhere. And also, there is almost 100% accuracy while doing the lumbar screws and greater than 96% accuracy in the thoracic screws. The disadvantage is, yes, it does take a longer time when we compare them to the open screws, especially initially when you just start practicing. Also, unlike the open, you do not have any surgeon control or tactile feel because you're unable to see the open anatomy. Very difficult to compress or distract. However, there are newer systems available. One has to be aware of how to do these things. And one important thing is one tends to get carried away and takes a lot of shoots, and thus there is significant radiation exposure not only to the patients but also to the surgeons. So equipment, it requires a posterior percutaneous fixation system. A lot of Indian and international companies are now available, making pretty decent percutaneous systems. We need a fluoroscopy unit. We definitely need Jamshedi needles, which are now a regular part of the posterior percutaneous fixation systems, and you need a radiolucent operating table. Most of the times a single C-arm is enough. However, if there are two C-arms, then it is definitely a luxury. Now, as you can see, the procedure position is prone, and we have to cover everything in a well padded manner. There should not be any pressure on the bony prominences. Two important things. One is that try to position the patient as much as in a position that you would want to fuse them, because then you have to work less, especially with the percutaneous systems. And secondly, you should ensure that there is free movement of the C-arm arc in the anterior, posterior, and lateral views, so that you don't get entangled with the urinary catheters or tubes or wires coming in the way. Now, the first step is to have a good quality C-arm, and the first step is to get or orient ourselves to a very good picture of a centered vertebra. Now you can see that this is a perfectly centered vertebra, and this is what you should aim for. Once we know at what angle you're able to obtain this, it's a good idea to mark it on the floor and also to indicate the angle of inclination, so that you don't have to take repeated shoots while you are doing the procedure. It does save a lot of time and a lot of shoots. Also, one has to be careful in degenerative scoliosis because there tend to be a lot of rotation. And as we know that we are relying only on the fluoroscopy, so it's kind of a blind procedure. So one has to be watchful of that. The second step is marking on the skin before we take the incision. So routinely we mark the midline, that is along the spinous process, the lateral pediculars as well as the interpedicular markings. Now for the dorsal spine, the incisions are usually placed just above the outer side of the pedicle. However, in the lumbar spine, because of the amount of soft tissue present and also because of the lordosis associated with obesity, in some patients, we tend to go more lateral, around 2 to 3 centimeters lateral to the lateral pedicular lines. Second important point, an important tip is once you do the skin incision, it is a great idea to also incise the fascia, because otherwise you will keep on fighting the fascia and can give you a lot of distress. Second is docking of the Jamshedi. Now, once we see a good view of the pedicles, we first like to go to the junction of the transverse process and the junction of the facet with the lamina. Once we reach that point, we gently mal it around 20 millimeters, such that we reach the middle of the pedicle and the inner side of the pedicle. We make sure that we don't encroach the medial wall of the pedicle. Now, this is a process which can take some time to learn. However, what I used to do is I used to first dock my Jamshedi on the transverse process and then slowly walk on it as I go medially. And once I start hitting the facet, just below that in the trough, that used to be the entry point most of the times. Now, as you can see that once you reach the medial part of the pedicle, that's the point wherein you take a lateral shoot. This is just to ensure that you have crossed the pedicle and you are somewhat in the vertebral body. Once that is done, we take out the inner sleeve of the Jamshedi and we put in the guide wire. Now, the guide wire has to be gently tapped. We have to ensure that we don't perforate the anterior cortex. Now, from this point onwards, all the position or the screws would be inserted in the lateral position. Once we have a good position of the guide wire, we take out the outer sleeve of the Jamshedi and then we start the process of tapping. Now, the taps are introduced till the pedicle as well as the upper part of the proximal part of the vertebral body. Care should be taken that while we are tapping, we do not push the guide wire and perforate the anterior cortex. Once the tap is done, that's the time wherein we start putting the screws. Now, very important is when we are trying to remove the tap before we start putting the screws, we should be aware that that's the time wherein the guide wire also comes out. So an assistant has to be holding the wire with a cocker so that it isn't misplaced. Usually the cannulated screws are used, which are 6.5 mm. We gently insert them and as soon as you cross the pedicle and go till the proximal part of the body, that's the time wherein you remove the guide wire. It is extremely important that you do not remove the guide wire either before or later on. If you remove it before, then there is a chance that we may miss the pedicle tunnel. And if we remove it later, then sometimes the end of the guide wire bends and then it is a big task to take it out. Once we put all the screws, that's the time wherein we do the measurement of the rod. A lot of systems have this rod measuring devices which we connect. Then is the time for rod insertion. Now, again, before the rod insertion, there are two types of systems. One is in which they directly place the rod while incising the fascia, and the other one is by making an incision proximal to the proximal screws. Now, depending upon what system you are using, usually it is not a bad idea to make a dry run with the rod so that you create enough space. Once the rod is put on one side, we try to put the rod on the other side. An important tip here is that sometimes in a true lateral view, both the rods will overlap and we won't be able to appreciate what is the exact length of the rod, whether it is adequate or not. So in such a case, you can just make the C-arm a little oblique and you will be able to beautifully see both the rods and judge whether the rod length is enough or not. This is followed by skin closure. You can see that the wounds look quite slick. They are very tiny wounds. And at this time, if you want, we can definitely go ahead and do the regular T-lift, requiring decompression of the dural structures as well as placement of the cage. So these are a couple of cases in which I did percutaneous screws and they worked very well. So a routine case of T-lift, we can see that there is an L4-5 spondy. The left-sided facetal effusion, patient had left-sided radicular symptoms, and we did something like this. Now, this is another case. Now, in this case, I ended up doing an O-lift. This was a failed spondylolisthesis who came to me with non-union severe back pain and radicular symptoms. I got a flex-X views, and you can see that the implant has failed. Initially we went from the front and we did the oblique lumbar interbody fusion. We can see that the spondylolisthesis has definitely gotten better, but still there is some amount of slip. So by overbending the rods and fixing it in the distal screw heads, we were able to take back the vertebral bodies behind and reduce the spondylolisthesis almost completely. And these are the post-op X-rays. So all in all, percutaneous screws, whether fluoroscopically or navigation guided or now recently robotic guided, they provide excellent primary stabilization of the spine. There are a lot of systems available which will allow multi-segmental fixation. There are very, very minimal intra and post-operative complications if one is cognizant and takes appropriate care. Patients usually have great pain control. Now, with regards to fluoroscopy, it can be done even in centers with just a regular C-arm or just requires good quality C-arm images. Yes, and one has to be careful about the amount of radiation that one is undergoing. Thank you.
Thank you, Akhil. Akhil, sometimes when we pass screws, even in the open cases, so after laminectomy, you can actually feel the pedicle from inside, and you can sometimes you can see that the pedicle has bursted. You know, like it has expanded, and those expanded ends can sometimes have sharp edges. And I've seen that some of these busted pedicles actually they are compressing the spine, the nerve root also in the vicinity. When you are putting these pedicle screws, so when we are putting an open screw, we are going through all the landmarks and like we are giving it a best shot. But when we are putting these pedicle screw percutaneously, chances of this kind of thing happening and we will never come to know. So what is your thought and experience about that happening in actual practice?
I mean, sir, so as already said that it is actually kind of a blind procedure. As you do more based on the there you do develop some tactile feel even while putting the screws. But I mean, during my fellowship training, when we used to do these percutaneous screws, we used to use EMG NCVs, actually, neuromonitoring also. Now, in India, generally for the TLIFs, we don't use neuromonitoring, so probably can be missed. But I think if we stick to the steps of doing things and placing it properly, making the pedicle tapping and everything, I think probably the chances are rare of such a thing happening.
Okay. Thank you.
Akhil, one more question. You feel that the medial perforation of while putting in percutaneous screw is more, or lateral wise you feel we tend to be more? I mean, because since you're passing the Jamshedi nail and then you pass a guide wire, always sometimes I feel that you tend to be a little bit more lateral than what you would do in a conventional open instrumentation. What is your
Absolutely, sir. I think that's a very good point. Actually, I should have probably spoken about it. So when we are using the percute screws, actually we are starting more lateral than a regular open screws. And the amount of angulation sometimes is quite crazy. I mean, we may be going like 30 degrees directed medially. I think with the percute screws, if you are not angulating more medial, then the chances of putting lateral is quite high actually. So we have to really go medial as much as possible.
Yeah, so that's what, while putting the Jamshedi, that is the main thing. Yeah.
Main thing, yes, absolutely.
Thank you.
And how much are you worried about this radiation exposure? You know, you have to take multiple C-arm shoots even for to put the Jamshedi, especially. You know,
I am very worried actually.
For every step, even for every turn of the.
Correct. So I think that's.
So, like, how do you protect yourself?
Yes. So.
And the patient.
So right now yes. So I mean, initial practice, I had a very low threshold for taking shoots, even for like very little step. But right now, as I said, for putting the Jamshedi, because that's the first thing that you enter, you tend to get lost. So for me, the first landmark is the TP of that facet. I try to put the Jamshedi tip over the TP and then walk on it and then go medially. Probably we also come to know the width of the TP, and from there, like the open technique, should be able to get an entry point. Until I am convinced that I am at the right spot, I do not take the shoot now. So probably per screw right now, for me, it takes around 3 to 4 shoots in all. And also I and my assistant, we do the one level together. So like if you are putting L3, it will be right and left at the same time. So you don't have to keep on repeating the steps again.
That's a good technique, Ayush. So as we know that with the percute screw, there could be a lot of radiation involved. So let's hear Dr. Vishal Kundanani. He is going to talk on the radiation risk with MIS surgery and how to mitigate it with the help of navigation. Vishal, please.
Thank you, Amit and Ayush and Akhil, for setting up the stage for the need of this talk, which is about radiation and role of navigation in MIS surgeries. And I'm sure we all are aware that all these MIS procedures, be it getting the tube in the right place, getting the right placement of the screws, be it placement of your tube in OLIF surgery, or for that matter, all endoscopy procedures and all pain management procedures that we all do right from the day we are out of our fellowship and ready to practice. All these MIS procedures, they are purely based on the accuracy of one thing, and that is imaging. And CAM is the only way that most of us use it, at least in the early part of our career. We do a lot of these CAM based procedures. We have come out of our training from orthopedics. We know how to handle CAM. But despite that, because of absence of tactile feedback that we generally get, or the visual feedback that we get of the anatomical landmarks of putting in screws, because of the absence of these, we generally tend to take multiple shoots to get the accurate placement of our tubes and accurate placement of our screws. And we all know that the success of surgery purely depends on accurate placement of the tube, like Samir highlighted. And the right placement of Jamshedi needle actually requires right placement of the needle on the pedicle eye, and that actually requires plenty amount of shoots. And there are various other steps where getting the guide wire right, tapping, getting the screw, getting the rod right, all these require shoots. And one T-lift sometimes doing in a MIS way may end up having 60 to 80 shoots, at least in the initial part of your days. And this improved accuracy that we often tend to achieve comes only at a cost of one thing, that is increased intraoperative radiation. And the better the CAM is, the more is the radiation generation. And the poorer the CAM quality is, the more is the radiation that is generated, not only direct but also scatter radiation. And all this increased intraoperative radiation puts you at risk. So sometimes when I talk about this radiation, people say, what's the big deal? It's okay. We are orthopedicians. I mean, there are cardiologists who are getting exposed to radiation far more than us. There are people who are doing angioplasties, angiographies. They get far more radiation. But guys, it is a big deal. And now it is very well clear that radiation has been used as weapon of mass destruction in wars. Today, it is also a weapon of mass destruction, and wiping out the surgeon is so easy by using radiation rampantly. And we all must understand that even in doses that are not permissible, when we are exposed to only mild amount of radiation, dryness of eyes, fatigue, tiredness, burning skill, numbness, and neuropathies are very, very well documented in literature, that even orthopedicians who do one interlock nailing per day with accumulation of radiation hazards. Remember that the hazards of radiation are cumulative. It is not that you take it today and by tomorrow you are okay. No, you cannot, even in divided doses, you cannot take X amount, because the hazards get accumulated and the free radical generated, they stay in your body for a very, very long period of time. And that is why these radiation hazards can get accumulated in your body over a period of time. And remember, we as MIS surgeons who are doing more than 4 MIS surgeries per month, which is a minimal number, like 100 cases a year, I think most of us young guys would be doing that number of MIS surgeries. We are all prone to developing cataract. We are all extremely prone to develop infertility. Most of us are young, and I'm sure all the young guys who are going to learn MIS techniques from these workshops are going to start practicing MIS very soon, if not tomorrow. But very soon you'll be starting practicing MIS. And remember, you all young guys, you are in the age of breeding, you are in the age of reproducing. The chances of you developing infertility, if you don't take care of, you don't pay cognizance to the radiation generation and reducing the hazards of radiation, you are probably prone to develop infertility very soon than later. And mind you, 11% is the risk of you developing malignancy of one or other formats. This is something that is really, really scary. But for being a MIS surgeon, you really don't want to die young. You don't want to die by cancers for sure. And this is something that is scary, and it is not coming purely from the anecdotal data that I'm coming up with. But this is all in papers. It is all published. It is there that radiation exposures during fluoroscopy by putting in pedicle screws during endoscopy, it is extremely, extremely high. And even simple procedures like vertebroplasty, they bring you exposure to radiation which is far more than permissible limits. And this accumulation happens to hazardous levels if you're doing more than 5 cases. And hand dosages, the dosage in the hand, because hand is something that remains in the field all the time while you're shooting for your Jamshidi needle, are 25 times more than your trunk, and the chance of you developing dermal ulcers or malignancy of the skin is extremely high. And all this is written, all this is on paper, as not only direct radiation but also scatter radiation, which comes by touching the patient and touching you from your back while your shield is in the front, is also one of the sources of you getting exposed. And the result of this is that the thyroid malignancies are on rise, abdominal malignancies are on rise, hematological malignancies are on rise. And if you are doing 140 any kind of MIS procedures, including pain blocks, vertebroplasties, MIS fixations, percutaneous fixations, endoscopies, you are at extremely high risk of developing a cancer. And this has been proven. And that is why, based on these, it has been recommended now, there is a specific conclusion that all spinal surgeons who are doing intraoperative CIAM-based procedures should be considered as classified workers. And what does that mean? Classified workers means you have to use occupational preventive measures as a mandate. You have to take cognizance of this problem during your occupation, and by taking cognizance, you have to weigh and work towards reducing the radiation. So how do we reduce radiation? Shall we not do MIS? No. The message is you continue doing MIS while reducing the hazards of radiation, while reducing the generation of radiation, and while reducing the overall cumulative problems of radiation in your body. How do we do that? The recommendations are straightforward. Minimize exposure time, maximize the distance away from the generators of radiation, and also use shielding always, not if possible, always use shielding. It is like wearing a helmet on construction site, wearing a fluorescent material when you're on the road, when your traffic police wears it, and then all traffic men wear masks every single day they are on the duty. And this, in the same manner, surgeons should always use all these measures, because these are the strong recommendations. So let's take them one by one. What is shielding? Use of lead aprons, thyroid collars, absolute mandatory, and eyeglasses, absolute mandatory thing. So invest in these things even before you invest in good forwards or rongers. Buy a nice lead apron, not a lead shield. Don't wear something that is only in the front. It has to be like a apron which comes from the back also. Remember, radiation enters from back, from side, and from front, from all the sides, and that is why the whole torso has to be covered. And there are now underwears also available, lead underwear and bismuth underwear is available for you. Yes, it is tiring during the surgery, but please ensure that you are properly covered right from top to bottom. There are eyeglasses made up of lead and bismuth, and you should invest in them. They are not really costly, 25,000 bucks only. Wear nice thyroid collars and maintain all these. We as surgeons sometimes wear them, but we don't maintain them, and often the lead inside them just gets broken, making it absolutely irreparable. So maintain these shielding portions, and they can reduce the radiation touching you by 97%. And this is something that we may pay attention to. Remember, we are lousy orthopedic surgeons and we do not know how to maintain these, and that is why these aprons, on one hand, you should wear always. You should also keep them straight. Do not fold them and break them off in your OT, which often is the case. At least in our OT, it used to happen earlier before we started having a MIS shield protection protocol, which is there in place in our OTs now. The downside of this is that though there is direct prevention, but the scatter radiation is always there. So the moment you take off with this, the scatter radiation always comes and touches you, which is 200 times more harmful than the direct radiation. Remember, it is the scatter radiation that causes more cancers. And that is why reduce the generation of radiation. How do we do that? Count your turns. This is a simple technique which is mentioned in Korean paper, which says that you should count the screw turns of how many turns does the screw actually reaches the bottom, and with 10 turns, like I'll tell you, there is a system, foreign MIS system, where 16 turns it takes, 16 half turns to get a 40 millimeter screw completely down the block. And that is why count the turns of your screw which you regularly use, reducing the requirement of radiation to get your screw in place. And then there are various forms of softwares. Just talk to your CIAM guys, ask them how can you use cone beam system. So use cone beam system. Every CIAM has a method to reduce the radiation dosages by using cone beam technique, reducing the amount of dosage required to get the same imaging. Reduce it. Say it's a single level TLIP, you can actually have only L4-5 seen, and the whole other area can be collimated completely. So use cone beam, collimators, and ultra low radiation softwares for your CIAM. This will reduce your generation of radiation by more than 80%. When it comes to using the source, remember the source down under the body is something that is recommended, because the source up can not only generate direct radiation to you, but also scatter radiation can be directly coming in touch with you other than being in touch with the patient. Yes, the quality of image because of table being between the patient and the Siam generator is there. However, the scatter radiation to the lower limbs is not so harmful, and that is why having the source down is something that is recommended. When it comes to taking the lateral views, always stand not on the side of generator. You should stand in front of the generator, because it's always said that the beam is going this way, so I will stand here. That's not a good thing to do. You should stand away from the generator, because if you stand near the generator, the scatter radiation can touch you more often than not. And that is why this is something that you all must follow. Increase the distance from the radiation. And of course, OARM, which Abhijit is going to tell us about, has reduced the radiation completely, because the surgeon's team can completely move away from OT while the OARM comes in, and that reduces and gives you a 3D imaging of the thing. So OARM is, Abhijit is going to talk about this. The best thing is that though all these measures are good, they are foolproof, reduce radiation by 90%. But the only problem is it doesn't reduces the generation. The requirement of radiation doesn't goes down. This overall generation of radiation, if I tell you that a MIS TLIF can be done only by 3 shoots, will you believe me? The answer to this is yes, because navigation actually gives you that just a AP, lateral and oblique shoot done for a single level MIS TLIF, you can do the whole MIS TLIF without having to check at all anything. Even your tube placement, everything can be done by total navigation MIS TLIF. And we have published plenty of papers on this. Maybe we can share those as well. So this is how navigation comes into picture, where it just decreases the requirement of radiation to the same surgery. How does it work? It's like a car sensor. It's exactly like a car sensor, where in your cars, there are sensors behind. And while you're driving or while you're parking your cars, the moment your car goes and touch or it's near the walls, there will be a beep coming up, or you can see on the camera while driving and doing the safe parking. And exactly in the same way, navigation works the same way. There is a screen there, and while you are putting in your probe, it actually guides you through on the screen, telling you that your probe is going medial, lateral, superior, inferior, how deep have you gone through, whether in the center of the pedicle or not, where is the starting point, without the need of a true imaging required at that time. Because you have taken one AP, one lateral, one oblique, it makes a screen, and on that screen, you can actually do video gaming with your probe, and which is seen on this. We'll be seeing some images there. And this is how this works. It also it can be simulated to Google Maps. Google Maps, where there is a map on which your car runs, and if your car is going away from the track, it not only tells you what is the safest and the easiest path to reach, but it also gives you a beep. The lady starts crying that wrong path if you're taking a wrong path on that way. And this is exactly what navigation does. It helps you to reach the right place, giving you real-time guidance, whether your screws, whether your implants are in the place where you intend them to be. And this can be purely done intraoperatively. For example, in this case, where a MIS TLIF was done for a large central disc with compression, we just took AP lateral images, and this probe is the actual needle, Jamshedi needle, which I am using on the skin of the patient, and I can see it on the screen. It is going through. Nikhil, one last minute, I'll just run through. Yeah. So these are just some examples how this probe looks. It is like a video game probe, and your probe can be simulated on the screen, and you can see how your Jamshedi needle is going in. You can actually determine the length of the screw that is required. You can determine the diameter of the screw. You can exactly place them subchondrally, bilaterally. You can also use them for putting cortical screws, particularly in salvage cases. You can check where your cage is getting placed. Another case where we did a 3D navigation. So navigation again is purely dependent on the imaging. You can either use a 2D imaging or fluoroscopy after the patient is positioned, or you can use a CT scans done pre-operatively and put them in the console and then do intraoperatively plan your screw placement. So these are just some examples how it works. The basic principle is the same, that you have created a map, and then your Jamshedi needle is like a car which you can get in, navigate in, and you can just work around and play around on the bony placement of your screws, and then it becomes simple. So it not only reduces the dose, it reduces the overall fluoroscopy time. In our study also, we have shown that it has reduced by 95%. The radiation dose goes down. The overall cumulative dose goes down by 96%. And this has been proven in our study of nav-guided MIS TLIF. And navigation not only is useful in MIS TLIF, but also we have got wings to fly, which we couldn't have dreamt of doing it. In every place, wherever Siam guidance is required, navigation can bring down the radiation, like in odontoid screw, again, a percutaneous done. In transarticular screws, we have been doing it so regularly, even in patients with absolutely unfair anatomy like this, navigation guided missed task was done for a child with absolutely tiny parts there with a high riding vertebral artery. C2 screws, we have been doing it for OC fixations, very, very bad OC deformities like kyphoscoliosis of the occipital-cervical junction. We have been doing using total navigation system, and that's how a fixation would look like. Cervical tumor excisions, this is one C1 lateral mass tumor just behind the vertebral artery, and we were able to excise the tumor there from the C1 lateral mass there. Cervical tumors in C7, and then these are some examples that come across. You can do osteotomy, completeness of decompression, you can do deformities, dysplastic medals, all can be done. On one hand, it reduces radiation, but it's a machine, it's a tool, and it has a learning curve. So we must understand, of course, it has a cost involved into it, and technician training is something that may take real time over a period of time. So the answer to all this is try to use everything that you can do to reduce radiation, stay protected, because unless you are warned and armed to protect yourself from radiation, you are exposing yourself to something that can be nasty for all of us. And we all young guys should take a pledge here that we are all going to do everything to ensure to reduce the radiation so that we all don't die infertile, or surely don't die of cancer early. Thank you so much. Nikhil and Amit, over to you.
Yeah, thank you, Vishal. So now, because of the little bit shortage of time, we'll go on to Dr. Amit Sharma's talk about minimal invasive TLIF. So till now we have seen about how to do minimal invasive decompressions, percutaneous pedicle screws, navigation guided screws. So this is going to handle the aspect of how to do a minimal invasive TLIF and an infusion. Over to you, Amit.
Spinal fusion is required for variety of spinal pathologies. And from minimally invasive spine surgery point of view, MIS TLIF is the procedure which is most commonly used. MIS TLIF provide all the advantages of a minimally invasive spine surgery, which ensures patient's early recovery and achieving the same job which we would do with the help of an open spine surgery. So the TLIF part, the transforaminal lumbar interbody fusion part, is done with the help of a tubular retractor, and then screws are passed with the help of a C-arm or navigation or robotic guidance in a percutaneous fashion. There are some steps to achieve this job. Initially, you do the retractor docking on the side where the patient is more symptomatic, on the side where you need to achieve more decompression. Interbody fusion part is done by passing the cage and the bone graft. Ipsilateral and, if required, contralateral decompression through the same channel can be done with the help of those tubular retractors. And after that, you pass the ipsilateral screws. If required, contralateral decompression also can be done by doing the facetectomy. And then after that, you pass the contralateral screws and the rod is applied. The very first step is to confirm the level which we need to fuse, and for that a needle is passed targeting the area of interest. You need to target the facet joint of the spinal segment which we need to fuse. So if you are fusing an L4-5 joint, then L4-5 facet joint should be your target, because the L4-5 disc will be more accessible from there. Initially, you pass dilator. So your dilator is kind of passed about 3 to 4 centimeter lateral to the skin, and it directly approaching the facet joint under concern. After passing all the dilators, you confirm the level again. Like in this case, we are trying to fuse the L4-5 joint. And once all the dilators are in, and then your level is confirmed, then you pass the tubular retractor on top of the dilators, and these dilators are then removed. After passing the tubular or cylindrical retractor, you confirm your level again before you start doing the facetectomy, because once you start doing the facetectomy, that's a step from which you cannot kind of go back, and you have to fuse that particular spinal segment. So if you look the spine surface, then you have to kind of remove the facet joint in such a fashion that you get all the bone. So your initial cut is starting from the lateral border of the pars, going medially towards the lamina. Your second cut goes down, and then this inferior facet of the superior vertebra will come out, and then part of the superior facet of the inferior vertebra also will be removed, so that you get direct access to the disc, as we see in this picture over here. Then with the help of your various instruments, you can do interbody work and then pass your cage and the graft. So if you look at the spinal surface, this is the facet joint which we need to kind of resect. and this is what you actually see in drop. So you have to have very good anatomical orientation. It's recommended that you be proficient in doing an open spine surgery before you directly jump for MIS spine surgery, because otherwise you will not have good orientation of the spinal anatomy, and then that might put you in trouble. So this is the kind of picture we actually see when we kind of dock on the facet joint. Various kind of retractors are available which can be utilized. Some tubular retractors, there are some cylindrical retractors which can be opened up. Let's have a look at this small video. It's a little bit on fast forward. So our skin incision is about 4 to 5 centimeter lateral to the midline. Needle is passed, level is confirmed. You take about an inch long incision in the paramedian fashion vertically after confirming your level. You need to aim for that facet joint. So after you take your skin incision, your facial incision and your muscle dilatation should be directed a little bit medially, because if you go directly downward, then you'll be landing lateral to the facet joint. So from this point onward, all your dissection and the instrument direction will be kind of directed slightly medially, because that's how you want it to be. That will give you a better access of the facet joint of the spinal canal for decompression also. You pass your dilators one on top of each other to dilate the muscles before you pass your tube on. And after you pass all the dilators, it's recommended that you confirm the level. Otherwise, sometimes your level confirmation with the needle is correct, but when you are putting the dilators in, your level might kind of get shifted. On top of the dilator, the tube will go in and the dilators will come out. Again, if required, here you can confirm your level with the help of the C-arm. It's very, very important that before you take your cut in the bone, you need to confirm the level. Otherwise, because it's a step from which there is no return. As we saw that this is the kind of picture you get once your dilator is locked in the correct place, and that the facet joint we are seeing on the right side, the cranial end, and on the left side, the left side is the cranial end, and on the right side of the screen is the caudal end. You resect the inferior facet of the superior vertebra and try to take out this chunk of the bone as a whole, because this can be utilized as a bone graft, and then you don't necessarily have to use too much of either bone graft extenders, or you don't have to remove the iliac crest graft. And then you see the superior articular process of the inferior vertebra. You have to remove part of the lamina also in the vicinity, because you would like to get more bone graft, and you have to anyway do it, because ultimate aim of the surgery is also to do the decompression to relieve the neurological symptoms. At this stage, if you want, you can remove the ligamentum flavum, or you can leave it also to be removed later on. And while you are doing your interbody fusion procedure, this ligamentum will protect your thecal sac. So part of the superior articular procedure also need to be resected, because once you remove that, only then you will get the direct access to the disc under concern. And part of the medial overhang of the superior articular process also need to be resected off, as we see right over here, because this will be the area where the traversing nerve root is compressed. So, and then again, more the bone you remove, more the graft you will have. So this particular step will decompress your traversing nerve root. So in this case, we are targeting L4-5, so L5 nerve root will be decompressed. You lift off the ligamentum flavum, and then once you do that, right above the superior articular process, underneath which the pedicle of the L5 vertebra is there, you will find the annulus of the L4-5 disc. All the epidurals need to be cauterized carefully with the help of a bipolar cautery, so you don't get too much of bleeding, which might obstruct your vision. The annulus is cut with some kind of sharp instrument or the 50 number blade. There are some box cutters also available, which will remove, like we see over here, which will remove a big part of the disc in one go. So you are able to work inside the discs in a better fashion. You have to remove the lip of the inferior as well as superior vertebra so that you get that square access to the disc. Otherwise, these lips will be overhanging the disc space, and the entry point will be narrower than the actual disc space, and then the cage which you will be able to put in might be smaller than the actual cage which is required for that particular disc height. Here the aim is to remove as much disc as possible. You can go all the way up to the ALL, because here we need to pass the bone graft, and then even after passing the bone graft we need to have enough space for the cage also to sit over there. Otherwise, if you leave your cage too much behind after passing the bone graft, this cage might kind of displace posteriorly and compress on the neurological tissue in the post-operative period. You remove as much of edge of the disc possible, and then you also have to prepare your end plates as you would do for any kind of spinal fusion surgery. When you are preparing the end plate, be careful that your instrument should not be sinking inside the end plate. Otherwise, your cage will later on not be stable enough. Once you have prepared your disc space, you pass the bone graft first, so that once you pass the cage on top of the bone graft, like done over here, this bone graft will not be displacing posteriorly. Once you passed your cage and you have ensured that this cage is in good position, it's sufficiently inside the interbody area, then you can proceed with your rest of the decompression by removing the ligamentum flavum. So that's the beauty of the tubular retractor. You can change the direction a little bit, and then you get more access now medially, so that you can achieve even the central canal, and if required, even the contralateral spinal canal decompression also. In fact, sometimes retract the neurological tissue enough so that you can see the disc on the other side as well. So what we are seeing is the ligamentum flavum at L4-5 on the right in the central spinal canal, which will be resected gradually to achieve the central canal decompression. The ipsilateral decompression has already been achieved by removing the facet joint and the part of the ligamentum flavum which was covering the traversing nerve root. If required, if you have to do, then you can expose the exiting nerve root also. In this case, that would be L4, but you don't necessarily have to do that every time, because if you expose the L4 nerve root, then you have to keep it protected from any kind of inadvertent injury. So after you remove the ligamentum flavum, you ensure your decompression, and that's how this T-leaf part is done. In terms of putting the pedicle screw, some of my other colleagues will be explaining you different procedures. So this is a typical incision we get after doing an MIS T-leaf surgery. There are some drawbacks, like if you are using a C-arm, then there are a lot of radiation. Even though you are covered that the patient is receiving the radiation, we need a good C-arm and very good OT table. Sometime while passing the screw, you might have facet violation, or if screw breach is happening, then you may not be able to know it intraoperatively because you are not accessing the screws from inside. And in the early phase, T-leaf when done in MIS way might take a little more time, like any other procedure would require some amount of training and expertise. So that is true with the MIS T-leaf as well. You can use navigation in OARM, but sometimes they are kind of little inaccessible to everyone, and there is also some amount of radiation hazard with all these procedures. Thank you very much.
Yeah, thank you, Amit, for the wonderful talk. And now we will call upon Dr. Abhijit. He's going to give a talk upon OARM assisted minimal invasive and open spine surgery. So OARM is the latest kid on the block, and it helps a lot for doing all your navigation guided surgeries. So I'll pass on to Abhijit for his talk. Abhijit?
Can you see my slides, Nikhil?
Yeah, you're visible, Abhijit.
And you can hear my voice as well, right?
Yeah, you're very much audible.
Okay, thank you, Nikhil, and thank you, Amit, for and as well as Vishal and team for giving me this opportunity. So we're going to talk about benefits of O-arm and O-arm-assisted navigation spine surgeries. So right now, on all these talks, we heard about guide wires getting misplaced in minimal invasive spine surgeries, the risk of misplaced screws, as well as the risk of radiation, which Vishal said that there is risk of cancer, risk of infertility, and we need to use lead aprons, thyroid collars, and eye shields and lead underwears. So all this can be minimized, and you don't need to really use this if you are using an O-arm. And we see what are the limitations of C-arm and X-ray based navigation. In this picture, you see if there is a patient with scoliosis and if the visibility is poor, then it is extremely difficult to put the screws under C-arm or an X-ray based navigation. There's a risk of neural injury with high degree of scoliosis and angular kyphosis. In high thoracic spine, you might have superimposed bony architecture, rib cage, shoulder, scapula might come in the way. Osteoporosis and osteoporotic bones, it is extremely difficult to visualize the vertebrae, and you might end up putting misplaced screws. And there is often associated deformity. Also in the craniovertebral junction, then often we see there are narrow and absent pedicles, and there is proximity to the neurovascular structures, including the nerves and the vertebral artery. So all these cases, the accuracy can be increased without radiation with the use of O-arm guidance navigation. You can do it either minimal invasive or open, depends on whatever you are used to. So there is a significant amount of literature available nowadays which shows that 3D O-arm based navigation has better accuracy as compared to freehand techniques. This is a short video on spondylolisthesis technique with an O-arm. So this is a patient placed on an Jackson table. This is Jackson table. We place a tracker on the higher level above the level which we need to fuse. Then the O-arm comes in. So this is the O-arm coming in, and you are standing outside the room, so you're not exposed to any radiation. I don't even wear a lead aprons. The technician is wearing a lead apron. We do spinning around. You see the asset navigation system there. The O-arm comes out and it's all over. You have 3D images in front of you. And then you start placing guide wires with a pack needle. The pack needle is a navigation-based Jamsheri needle, and the accuracy is 100%. Then now I'm going to skip this video here because this is same as a TLIF. Then I dock the tube right on the facet joint. I tend to use the quadrant retractor because I feel it is comfortable. I use a different incision for the quadrant retractor because in the minimal invasive with the O-arm technique, the screws are very laterally placed. So I feel comfortable putting the quadrant directly over the facet joint and then do the fasciectomy and decompression as seen in these pictures. And Amit has shown you before how do you place the cage and how do you do a decompression. So guide wires are placed, the tubes, the quadrant is placed, you do the decompression, and then you come back and start doing the screws under navigation. You don't need to wear a lead gown. Now you come back and you put the screws. The accuracy is 100% because this is a 3D CT scan inside the OT. You can measure the screw length accurately. You don't need to take any shoots for that. Your assistant or somebody can place the rods and it is done. So the accuracy is 100% without the risk of radiation. So these are the screws placed and the cage placed. And so as Vishal said in the previous talk, you can sometimes take 80 or 90 shoots in these cases. So in this technique, you have probably zero radiation because you are standing outside the room while the O-arm shoot has been taken. This is another minimal invasive TLIF in a high-grade spondylolisthesis using the navigation technique. Very easy. Place the guide wire, screws, and do the decompression in the cage. Now, this is another young child with congenital kyphoscoliosis. You see the angular kyphosis, and this is the CT scan. The CT scan, you see there is absent pedicles on the T4 on the right and T3 on the right. So if you do it under an C-arm-based technique, then you might end up damaging the neurovascular structures. And doing the vertebral column resection, VCR, is difficult in these cases. With the use of navigation, you can easily place the screws. You can do navigation-guided vertebral column resection, and the safety is ensured. So, and without any radiation exposure to you. So the accuracy is excellent, and the most important thing is you don't need to wear any lead apron or anything. You're completely free of all those gadgets like lead apron, thyroid collar, eyeglasses, lead underwears. And this is another patient, ankylosing spondylitis with Anderson's lesion. This can also be done with an minimal invasive approach. You can place 2 or 3 levels above easily with the guide wires. See, in this picture, you see under the pack needle, we are placing the screws. This is a tracker here. You can comfortably place 3 screws above, 3 screws below without any radiation. You put the screws and rods. Here I have done a cementing for the vacuum sign over there. And this is how the incision looks like. You can easily place the rod comfortably about 2 to 3 levels above and 2 to 3 levels below. Now, this is another child with syndromic scoliosis, 140-degree curve. Now, this is a large curve, significant degree of rotation. You might end up taking a lot of radiation while putting screws in these patients, or you might end up putting misplaced screws. So with the OAM guidance, you can do this case comfortably without a single shot, without any exposure to radiation. I just love this OAM for only reason is there's no radiation during cases. You're standing outside, you come inside, and without any radiation, you can comfortably place screws accurately. So you're not sweating during the surgery. This is the same patient after scoliosis correction with good result. Now C1, C2 subluxation in a 14-year-old patient. Now here you're worried about placing the screws appropriately, the pedicle screws, and the C2 pass screw as well as the lateral mass screws. See, the pedicles are very narrow. With the navigation, you can easily see the pedicles, you can see the size, you can see the position of the vertebral artery and comfortably place the screws.
Thank you, Abhijit. I think we'll stop here.
Sorry. Okay, that's it. Thank you so much.
Only one question and then I'll let you go. Okay. So basically, do you check the screw placement after they are kind of in the bone once the procedure is over, or this is just like one time thing only?
No, I don't check the screws because I know it's correct. Because since the OAM has been spin, I don't take another spin. Dr. Vishal Shetty tends to take another spin, but I don't think it's needed because you know that your placement is perfect.
And compared to a CT scan, how much is the amount of radiation the patient is going to receive with this one cycle of?
Yes, it is similar to one CT scan. Patient does receive one radiation equal to one CT scan.
Okay.
But since you are standing outside the OT, the surgeon is safe. But as you know that patients get CT scan all the time. So getting one CT scan for the patient is not a big deal. It's all about you that you should not get a recurrent exposure to a lot of radiation in the OT.
Okay.
I think this looks like the future.
Thank you, Abhijit.
How expensive is Abhijit?
Yeah, the OAM is disadvantage is it is slightly expensive instrument, and you know the pack needle is also expensive. But once you buy it, I think the accuracy is good, and we tend to reuse the pack needle, so you can minimize the cost once it is in.
Abhijit,
the OAM is expensive. It is 3 to 4 crores in cost.
Abhijit, hi, Nikhil. Can you unshare? Yeah. So we'll have the next talk.
Sorry, sure.
Yeah. Ayush. So now we have next talk from Dr. Ayush. He's going to give a talk about guide wireless MIS pedicle screw system. Again, the new kid on the block. Ayush.
Yeah, so something new and something even we have started using recently. So I'll straight away go ahead for the talk. So today we'll be talking about guide wireless minimally invasive pedicle screw, which is a new kid in the town, a completely new technology. So this was one of our cases. You see here what has happened is the tip of the tap has just broken in. So while we are trying to remove the guide wire from the tap, part of the tap broken and it is just blocking our entry to the pedicle screw. Mm-hmm. We tried putting the Jamshedi again or dislodging it with a tap, another tap, but that didn't work. So we had to put a lanky probe and just dislodge the broken metal. And so we could get the trajectory exact what we wanted and we could get away with the fixation. So anyone who has ever done a minimally invasive screw fixation will tell you that one of the two most dangerous thing about doing them is the guide wire and the migration of guide wire through the tap. If you look at the literature and look at the complication of percutaneous pedicle screw fixation, it would
as simple as this broken guide wire in the pedicle screw to migration of the pedicle screw, this migration of the guide wire, which is very, very common, especially if you are putting the screw in an osteoporotic fracture or osteoporotic wound. Or it could be as complex as this abdominal aortic injury, which happened due to the migration of the guide wire anteriorly, which has damaged and caused the aneurysm of the abdominal aorta. Of course, not our case. This is from one of the case reports. So if we look at the comprehensive literature review at complications associated with guide wire use in spine surgery, the risk and the complication can range from 0.4% to 14.8%. The complication includes guide wire fractures, just like the one we saw there. It could lead to CSF lead. If you have punctured the dura, it could lead to postoperative failure, to infections, or some of the other complications we just spoke about. Now, this is where this innovative system comes into play. It is called Hyperprime. It is launched by Dental, and it is basically a stylet-based minimal invasive system. So this is how the system looks like. So this is the stylet which comes out of it, and this is the control from the stylet. So it is a novel technique for putting the percutaneous pedicle screw, which eliminates the need of guide wire or the jump shade needle. This video will see how it exactly works. So this is the control for your stylet. So as you turn this knob, the stylet comes out, and this is calibrated. It can go from 1 millimeter to up to 6 millimeter. And as you turn it in the other way around, the stylet goes in. So it is surgeon's control, and you can choose depending upon the situation and scenario. So let's see how it exactly works. This is a small video. So the entry point and everything is like a traditional minimal invasive screw. This is like the dilators which comes in. You put on the dilators. Once you have put on dilators, then you put the screw with the stylet system inside. And this is a real-time video. Just like just to get the cortex, I'm using the hammer just to get the small entry inside the pedicle. Once I have done that, I'm just rotating the knob to get the stylet system out. This is what I'm doing, as you can see here. Once the stylet system is out, it is calibrated, so it can go up to 5 millimeter. I'm just trying to get a hole in the pedicle, and this is the seat shoot. So I'm the lateral border of the pedicle. I'm going enough so that I get a hole of the pedicle. So now I have the hole of the pedicle. At this stage, I will get another shoot. So I'm near the medial border of the pedicle like this time. So I'll just get a lateral shoot to confirm if laterally it is the same case or I need to change my trajectory. It looks like okay. So we'll go ahead with putting the pedicle screw. At the same time, I slightly redirect my pedicle screw at this stage. And then once I am good about the trajectory, I'll go all the way in. But before I put the screw finally in, I will reduce the stylet so that I don't go, the stylet doesn't go and hit up the cortex. This is what I'm doing here. So I have taken out the stylet back, as you can see here. And then we'll put the screw in, and then we take out the system. This is how it looks like at the end of the day. So this is, as you can see here, this is how it looks with the dilators, and this is a bare. If you also remove the system and the dilators, this is how it looks like. So you'll appreciate that it's a all reductionist. So the throughout the length of the attachment is a reductionist. So not only that, if you, for any reason, if you feel like augmenting the screw with cement, if it's a osteoporotic fracture or the hole is not good, you don't really need to do anything. You just introduce the system, which is inbuilt with the screws and adapters, and you can put the cement. The other thing is you don't need to have a separate incision like some of the other system in market today. You can pass the rod with the same incision without even having to bother about a separate incision altogether. So if you compare a traditional Jamshedi based or guide wire based system to this guide wire less system, what you will see that you are spending more time in targeting and placing this. That means you are likely to be more accurate, and the same time, some of the steps like tapping and guide wire putting that has gone out, so you are likely to be faster. So this is one of our cases, a lytic listhesis, which we operated, and we did it in lateral position because we wanted to do a OLIF in this case, and this is how the OLIF gauge went in, and then we use this MIS system to put the screws, and you can see this is how the wires are going with the stylet jutting out, and as we go in, we decrease the stylet so we don't puncture the opposite cortex. And this is what we got in the end. But one of the best part is we didn't have to flip the patient in this case. So normally, if you're doing OLIF, you flip the patient, paint it, re-drape it, and then put the screws. But because of the simplicity of the system, even although these were non-navigated screws, we could do the screw placement in the lateral itself. So it was a single position surgery. And if you look at this is the post-op X-ray showing the position of the K and the screw, and we got a decent alignment, and the screw looks pretty decent as well. So because of the low profile of the screw, even this is the sim for the OLIF in 2 centimeter. If you look at this incision, the startings are very, very small because the system again has a very, very low profile head. And this was another case, a degenerative scoliosis, where we combine
Hi, Nikhil.
Yeah.
I guess Ayush can have a voiceover.
Yeah. I think it's over.
I guess it's concluded. It's the last slide.
Yeah, I'm done. Yeah, go ahead, Ayush.
Yeah. The video is done.
Ayush, nice talk and a nice technique. So just one thing, while using this K-wireless system, what about the other facet, the upper level facet? Is there any chances of causing a damage to that facet and causing instability at the upper level, adjacent level? Because there was another system which had come from K2M similar way.
So there is always a chance, as you understand, even when you are putting a normal MIS screw, and inadvertently, if you are you're not taking care of your entry point, there is always a chance. And I think the chances of having this with this system is as much as you putting with the normal MIS screw with guide wire. So you have to choose your entry point correctly. But like I started with a open, like I'm an open surgeon and then went to MIS. Anyone who went with that feeling and you love the feeling of pedicle screw, this will give, instead of guide wire, you really have the feel when everything is going in. So that is where I think the trust of it comes to.
Okay.
Thank you, Ayush. So we are in minimally invasive session, and a minimally invasive session cannot be completed without talking about endoscopic spinal technologies, which is probably the least invasive spinal procedures. Can we have Dr. Sambhav Shah's talk on endoscopic interlaminar decompression for lumbar spine, please?
Good afternoon, everyone. I thank BSS for giving me this opportunity to present here today. So endoscopy was the whole transforaminal approach started off in 1973 by Cambin, and it took us so many years when finally papers were published about the interlaminar technique, mainly in 2006. And the interlaminar approach was developed because through the transforaminal approach, the L5S1 was quite difficult to access. And that's the reason why the interlaminar approach was developed. However, if you see the transforaminal approach, you're not very familiar with the anatomy, the way it is. The transforaminal approach is something which is a different approach, and the anatomy needs to be studied very well. You should be familiar with the access. However, we as spine surgeons are very, very comfortable with the old approach. We want to see a dura like this, and we want to see something similarly through the endoscopic approach as well, because it's just an adaptation of a technique which we already know. So we are more comfortable when we see the nerve and the dura in totality, rather than seeing it through the transforaminal view where you just see the base of the nerve. And if you see the learning curve of full endoscopic lumbar discectomy, the transforaminal approach was steep and easy to learn. The endoscope is fixed in the foramen, and once you are there, the entry is the most important. Once you are there, the surgery is very simple. However, in the interlaminar approach, the approach was very easy to learn because we are very familiar with the approach. However, it's very, very hard to master. And the reason is the flexibility of the endoscope. You can go inferior, superior, medial, lateral, which is also a great advantage. However, it's much more difficult to master this technique. Indications for interlaminar approach for me, I've left this slide blank, as anything which I can do through a micro minimally invasive approach to the tubes in the lumbar spine or thoracic spine or cervical spine, I can do the same through an interlaminar approach with my endoscope. But between a transforaminal and interlaminar, if I can do any level with interlaminar, however, transforaminal I mainly reserve for the 2, 3, 3, 4, 4, 5 level, and that too a foraminal, extraforaminal discs, or quite a big central disc. So if you see the above image, it's a huge central disc at L3-4 level. However, the lower image of the patient, it's a right-sided disc mainly, which has inferiorly migrated next to the pedicle. So I would definitely do this approach, the lower case, with an interlaminar approach. However, the above case, I did it with a transforaminal approach. So, but in general, my 70% of my work is an interlaminar approach. And in fact, I started my endoscopic studying, my fellowships, etc. I first started learning the interlaminar. The first scope which I bought was an interlaminar scope, as against people who first start doing transforaminal. So I'll start with a case which is a 30-year-old patient with a huge disc at L5S1, compressing the right nerve, and also inferiorly migrated. If you see the nerve root is pushed quite posteriorly. The first thing I would do is look at the X-ray of the patient, because that gives me a rough idea of the interlaminar space. Because in younger patients, you want to save as much bone as possible. Now at L5S1, this would be easily possible because the interlaminar space is much bigger. However, you see at the L4-5 level, the space is quite small. Then this, if I had to do the L4-5 at this level, I would definitely require my bow. So once the patient is in the OT, for discectomies, I usually break the table because I want to open the interlaminar space. However, if I'm doing a stenosis case, I would not do that. I generally maintain the lordosis because I feel otherwise you will end up under decompressing. So, but for a discectomy, definitely try and open up the interlaminar space as much as possible. In general, if the patient's head is here and I'm approaching the right side, my assistant stands opposite, as he helps me guide the instruments inside. My monitor, light source, camera are opposite me. My RF and my bird is towards the patient's end, and my irrigation is on the same side as me. That's the way I keep my theater. And the entry point, you start off with the AP. Here it's important to know that you don't square. Like for a transforaminal approach, you square the vertebra. You want the disc to be parallel. But for interlaminar approach, you go straight down. I see a huge interlaminar space here. If you see the L4-5 here as well, is quite big. So probably I would, if I had to do L4-5 in this patient, probably I would be able to do it. You try and take the entry point as medial as possible. Once you take the entry point, you take your stab knife and you cut until the fascia. Then you insert a dilator. With the dilator, it is one of the most important step, I feel, because with a dilator you can actually feel all the landmarks. So you can, if I'm doing a stenosis case, I would first want to feel the medial facet, the superior lamina, the slope of the lamina, the inferior lamina. You scrape off all the muscle through it, and then if I'm doing a revision or a stenosis case, I would dock it on the lateral aspect. And if I'm doing a discectomy with a big window, I would probably keep it medially. Once you are done with this, you put the outer cannula. Again, the cannula is one of the most important instruments, and it is basically your eye. It is what will show you inside the spine. And the cannula is usually a bevel shape like this. So depending on which direction the bevel is, that's the direction you see it. And you can rotate the cannula independently from the scope as well. And it's one of the most important instruments. So I start with the video once you are in. Obviously, there's a lot of soft tissue. I would definitely recommend you to use radio frequency first. In endoscopy, as a rule, whatever you're going to remove first, you use your RF because once bleeding starts, it's very difficult to control it. So you want to keep the bleeding to the maximum. Then I've made a rent in the flavum. And then with my outer cannula here again, I'm going to stretch the flavum. Flavum is elastic, it stretches very well. And I'm just making a slit in the flavum, which I'll show you on the post-op MRI scan. I'm not removing the flavum entirely. And I see the epidural fat here. And once we remove the epidural fat, we go down and see the dura and the nerve. As I said again, that there's a blood vessel. You see that small blood vessels also are very magnified. So radio frequency cautery is must, and it's very safe to use this. And now I'm trying to mobilize the nerve. You see that's the disc below. The white structure is a disc below. And I'm using my cannula now, the outer cannula, once I mobilize the nerve, to move the nerve medially. So the nerve is completely out of the way and I can safely remove the disc. That's the reason why the cannula is very important. So as you see here, I'm rotating the cannula. So my nerve is completely safe. Once we do that, we remove the disc. And once the disc is out, and when I derotate the cannula back again, initially I could just see the border of the nerve. But once I rotate my cannula, you'll be able to see that I'm seeing the whole nerve in totality, right from the shoulder to the axle of the nerve, the dura here. And this is how I would like to see my decompression and my discectomy. And I know that this patient's leg pain is going to be gone. At the same time, in transforaminal, I don't see the nerve like this in totality. Although it's a beautiful surgery to do, especially for foraminal, extraforaminal disc, but I still, interlaminar is my favorite. The incision size is just 4 millimeters and the patients are going home the same day. And that's the post-op MRI, very well decompressed. And what I would like to see is that this MRI was taken 4 days later and the lamina is absolutely intact, including the ligamentum flavum. So we went from the right side. What you see here is just the rent we made in the flavum, but otherwise the whole flavum is absolutely intact and you can't make out. Even the sequestered piece is well taken. The nerve root has gone back to its place and it's a well decompressed spine. This is what I love about the interlaminar approach is the flexibility. You can go superiorly, inferiorly, because zoom in, zoom out. Obviously, your hand maneuvers, etc., are very important. And it's initially it is very difficult. That's the reason why the learning curve is quite steep. But it gives you brilliant flexibility. You can rotate. And the same patient's MRI done 4 years later, there is no mention of any surgery in this. Even the MRI could not pick up that this patient was operated. Otherwise, you normally see in the MRIs, laminectomy defect, a laminectomy, adhesions, etc. But there was no mention of any surgery in the MRI report. Similarly, a case of a sequestered disc. Inferiorly, I'm just going to rush through a little bit more in this video. So main thing what I want to show you is that the anatomical landmarks are very, see, this is what you see normally. There's so much of soft tissue. So you want to use your radio frequency cautery before you start removing any material. And then this is what is important. And again, even in you see the way the camera rotates, you can go laterally, medially, you can see the lateral recess. You can use a nerve hook to remove out the disc pieces, to probe the nerve. So it's exactly the same instruments which are there. You can use a cannula to give downward pressure to milk out the disc as well. So you can do entirely everything, and the vision is just brilliant. And once you're done, again, I can see the whole S1 nerve, the axilla, the dura, right from the shoulder, go down, probing everything. And I know that these patients have not left anything behind, and this patient is going to do extremely, extremely well. I would recommend to start with such discs, big discs, one-sided leg pain. Sometimes really small discs, if you start, sometimes you just get lost whether I've done enough. You start probing the disc more. So a big disc like this, you're going to get a very juicy material. And then once you're comfortable, 10, 15 cases, that's when you start venturing out into migrated discs and huge discs like this. The main thing they've realized that conversion to open is mainly in the start, because identifying the anatomy. So obviously, if you're quite used to microscopic or tubular surgeries, then this will be much more easier for you. And once you've done these cases, that's when you start going into stenosis cases, like taking a simple unilateral lateral recess or a cyst like this, then going to bilateral over the top approach, and then venturing into significant stenosis like this. Even scoliotic patients you can definitely do with the stenosis scope. So again, you see here, because of the flexibility, you can go superiorly, inferiorly, over the top, on the other side. The indications are a lot, and just going to show you quickly how I'm identifying my landmarks in stenosis, where I have found the medial aspect of the bone, and then that's when you start burring it. The burrs are really, you need burrs for stenosis surgery. You cannot do anything without the burrs. And then you use your Kerrison punches, remove your ligament with Kerrison punches, and finally you see the whole dura, and you can beautifully decompress the nerve, and patients definitely will be pain-free. So always keep your tubes and open instruments on standby. Even now, even though I've done more than 150 cases, you never know what happens. Sometimes your instruments fall and you get stuck. In private practice, you cannot have multiple instruments lying around. You cannot have a lot of RF cauteries lying around. So always keep your tubes and open instruments on standby. And if you find any difficulty, just open the patient up, because eventually you want the patient to be asymptomatic. Thank you very much.
Yeah, thank you, Sambhav. A very nice talk about posterior interlaminar endoscopic decompression. So just for starters, the first few cases, alpha S1 would be a good level to start a disc.
Definitely, because alpha S1, you have quite a large interlaminar window. So usually majority of younger patients, you don't end up using the burr. You have enough space over there just to do a pure discectomy. So definitely start at the L5S1 level. Young patient, 35, 40-year-old with a juicy disc at L5S1 one-sided would be the first case to start with, definitely.
Perfect. Yeah. Thank you. Amit, any questions, or should we go to the next talk?
For the interest of time, I think
we should go to the next talk. Yeah, Nikhil.
Okay. So the final talk of today's MIS is the transforaminal endoscopic discectomy decompression by Dr. Pradeep. He's a regular doer of transforaminal endoscopic procedures. So we'll hand it over to Dr. Pradeep for this talk. Thank you.
Can I share this now? Share the screen?
Yes, Amit. Yes, Pradeep.
Pradeep, you have to share it. Yeah.
Is there? All right. So I'll be speaking about transforaminal endoscopic spine discectomy, basically. All right. So until now, believe it or not, this is the most minimal invasive technique available in current practice, where the most very minimal soft tissue damage and access to the whole of the spine. Rather, we can go over the top in interlaminar endoscopic, and we can do bilateral through single port approach. We can go bilateral decompression of the nerve root. So with the advent of recent optics and the newer burr technology, it's very easy to perform these surgeries. Here I'll be speaking mostly about the relevant surgical anatomy and the basic classification and the basic technique. So you can see here, the endoscopy is basically, we can do for the paracentral disc, and you can do this for the superiorly migrated disc. You can do this for the inferiorly migrated disc. However, as Dr. Sambhav mentioned, this the approach towards alpha S1 is a bit difficult, but we can get away with this if you are experienced enough. So approach is through, the basic approach are extraforaminal approach, where we don't enter into the lateral recess of the canal. Is far lateral disc. We have to just dock the tube over the disc, and it's very easy surgery. I think the far lateral disc can be done with the percutaneous endoscopic disc technique. Is the only most minimal invasive technique we have for such disc issues. Transforaminal approach can be done for the foraminal disc, which is just you have to dock there in the foramen and you will get the disc. Superiorly migrated, as I mentioned, inferiorly migrated disc. Paracentral disc is the most common, and to start with paracentral disc would be the indication for the initial say 50 or 40 or 50 surgeries. Central disc is a bit difficult, but you'll get away with this once you are experienced. Interlaminar already been spoken by Sambhav. So there's certain indication, this algorithm of managing such and through endoscopic technique. Interlaminar, of course, alpha S1 is ideal indication where paracentral or superior or inferior migration can be dealt very easily with this. But any disc in the canal, inferiorly migrated L4, 5 or above, or the central, or for that matter, in the foramen should be transforaminal would be the ideal indication for this. Extracanalular disc, where the disc in the foramen or the far lateral, I think transforaminal endoscopic would be the ideal and only technique which would do justice to this procedure. So if you just talk about general anatomy, we know this Camden's triangle, which is base is basically the traversing nerve root, superior border is by the exiting nerve root, and this is the superior plate and plate of the inferior vertebra. So basically from B to this length is basically 18 millimeter length we have, and from superior end plate to exiting nerve root almost 17 to 18 millimeter. So only we have this much of area to work on. So that means we have to be very precise about when we place our guide wire or when we target our pathology. So this is one example of inferiorly migrated disc where the disc is lying. This is a difficult case to start with. This disc is lying just behind the pedicle. In such situation, we have to obviously take care of the pedicle by burying the pedicle or pediculectomy or so. Surgical anatomy, and then so more lateral you go, the chances of entering into retroperitoneal space is very high. More steep you go, you probably won't be able to target the pathology. So this is the area where we have to target this thing. And this is the facet. If you just look at this, this is the exiting nerve root. This exiting nerve root we have to avoid. So you have to be between this facet and this much of space is only you have to work on. So if you have very difficulty in this scenario, if you dock your tube down like this, and you have to cut a facet bit to go more towards the thecal sac. If you dock your tube like this, you will not be able to see what is happening here. And if you take more medial entry, or you would be maybe much away from the target pathology. So what you need to do basically, you have to, once you reach there, you have to bring this thing down in order to reach more nearer to the central part of the disc or pathology. This is how we dock the tube, and by keeping the bevel part upwards, we can see, and the scope is 30 degrees, we can see all this area. So what we are doing, we are docking here at the annulus, and if there are any disc which is is entangled in the annulus or maybe subligamentous or maybe extruded, we can handle it. All right. So, as I mentioned, if you have really difficulty in, accessing to the central disc, we can cut this facet by doing foraminoplasty. We have certain sophisticated instruments for that, burr or so, and then we can, cut this, and we can reach as near as possible to the target pathology, like this. Had we not cut this facet, then probably we would have landed here, which would be much, much away from the target. There's certain anatomical limitation if you are considering transforaminal. Basically, if the canal compromise is more than 50%, I think once you're a beginner, probably you should not consider transforaminal option for such pathology. Always do it for mild disc disease and the pain is refractory, predominantly radiating to one side, and consider those cases only. For severe cases, always use microendoscopic or other conventional technique, or interlaminar is even better for that. You should
short enough time. Just we have got another minute or two.
All right, yeah. I'll just conclude. So this is high riding, high placement of the iliac crest, which is also one of the important anatomical consideration. The foraminal stenosis, which is the distance between the inferior part of the vertebra and superior articular process, you should always measure this before you go for any foraminal surgery. Otherwise, if it is narrow, then less than 5 millimeters, you should consider this foraminoplasty. This is how it should be. This is large, this is small. This is general anatomy. So basically selection of, as I said, simple paramedian disc on one side, predominant pain, refractory to other modality, I think should be ideal cases to start with. These are all high-end indication, obviously, which should be done once you're experienced. This is pre-op preparation. We should have good MRI, axial section, discography, flexion extension X-ray, delineate the foraminal this thing, and target and you should also consider the iliac crest height, and then only you should plan your surgery.
Pradeep, extremely sorry, but 5:30 we are going to start with another session and platform before that.
Give me a minute.
Nikhil, do you have any question for Pradeep?
Yeah, the endoscopic talks were really good, both from Pradeep and Sambhav. And I guess all the talks today from Dr. Arvind Kulkarni, Abhijit, Ayush, Samir, Akhil, Vishal, everyone talks were really very lucid, and they highlighted all the minimal invasive aspects very well. I would like to thank the organizers, Uday and Vishal, SK sir, for doing such a wonderful job and for giving us the opportunity. And it's been a really good workshop. And thank you, everyone. Thank you, Amit, for course.
Thank you, Nikhil. And I hand over the proceedings to Uday. I think the next session is going to start in just a couple of minutes. Uday?
Yes. Thank you, guys. Thank you for concluding this before the start of the next session. Thank you all. We'll wait for 2-3 minutes for people to relax a little bit. And we'll start off with the next session, last session of the day, based on osteoporosis. Whatever you have learned so far, pedicle screw insertion, minimally invasive way, it won't matter if the recipient bone is osteoporotic. And you need to know how to manage it medically and surgically, how to salvage if you have a problem in osteoporotic spine. So we are going to deal about medical and surgical management of osteoporosis and osteoporotic vertebral fractures. Just a quick break, and please do join us. In 2 minutes, we'll be starting. All the panelists of the next section are here. Just a quick 2 minutes break, and exactly at 5:30 we start the next session on osteoporosis, medical and surgical management. Thank you.
So sorry for rushing onto the delegates, but it's 5:30 and we are ready with the next session. Whatever you have learned so far, as I said, doesn't make any sense, and you can land up into a bad crisis if you don't treat the osteoporosis or don't have the knowledge of how to manage the osteoporotic spinal fracture. I do welcome the last moderator for the session, Dr. Priyank Patel, to take this session forward. Dr. Patel.
Good evening. Thank you, Dr. Uday Pawar. Good evening, everyone. Without wasting a lot of time and sticking to the principles of our Bombay Spine Society, I am quickly going to share my screen. Before that, I welcome all of you for the last workshop of the day. So we have a patient over here. He's a 71-year-old male retired banker, a heavy smoker with an active lifestyle. He came to us one day with back pain after a domestic fall. We got an X-ray at 3 weeks. It showed that there was a D12 osteoporotic vertebral fracture. We were treating him conservatively with our routine protocol. And at 6 weeks, he was not improving. In fact, he became incapacitated and was not able to perform his activities of daily living. A dynamic X-ray showed significant instability at the site of the fracture. We assessed further and we realized that this patient has an intravertebral instability because of a Kummel's lesion which was forming in the body. So it was a case ideal for vertebroplasty, and that's what we did. The procedure went across absolutely uneventful, and at 1 month post vertebroplasty, everything was perfect. The patient was happy, back to his daily living, comfortable in his life. However, at 6 months, the patient again came back with similar type of problem, and he was just not happy with what's happening. And when we got an X-ray, this is what we saw. The vertebroplasty started giving away. There was involvement of the adjacent level vertebrae, and that got us thinking that what really went wrong here, did we not investigate this correctly, or did we not treat the osteoporosis right, or what was vertebroplasty not the right choice in this patient? Well, let's get answer to all of these in Hard Talk on osteoporotic vertebral fracture with this elite panel of doctors. I welcome Doctors Ram Chadda, Abhay Nene, Chetan Badani, Raghu Prasad Verma, Abhijit Pawar, Agnivesh Tiku, Manish Kothari, Aditya Kashikar, Ankit Patel, and myself, Dr. Priyank Patel. Make sure you put in your questions in the chat box and we'll try and get all of them sorted before we go. Without much delay, I would invite Dr. Ankit Patel to tell us how to investigate a patient of osteoporosis. Ankit, if you could share your screen.
Since we can't see Ankit, maybe we can just keep on rambling about what went wrong with that patient, Priyank. Do you think it was an inappropriate decision to do vertebroplasty here? What does Dr. Raghu feel? Can you show that slide again? Until Ankit joins, maybe we can just carry this discussion forward. Dr. Raghu, would you have done a... Ankit is not here. I can't see him in the panel, which is why I thought...
Yes. So for me, if the question is directed to me, I don't think it was wrong to do a vertebroplasty there. If you asked me what probably went wrong was we were not good enough to treat the primary condition, because we have to realize osteoporosis is a medical disease. And you might end up doing a great surgical workup and surgical procedure, but if you don't back it up with good medical follow-up, you are inadvertently also going to end up having a problem. Second issue is, which could cross my mind, is whether you have something called as a little chronic infection at that site, because I saw some amount of involvement of the upper vertebrae. Barring these two, I don't think the procedure was wrong primarily for that particular case.
Dr. Ram, since Dr. Ankit is going to talk about investigations, do you get MRI for everyone who's got an osteoporotic vertebral fracture?
Well, particularly in this case, if you look at it, when we came up at 6 weeks post-index procedure, index presentation with a compression which had progressed, and you said he's a 71-year-old gentleman who's been a smoker. So smoker could also mean that his bone quality is going to be poor. Smoker could also mean that we are looking at a metastatic deposit. So these are two things that come to my mind when I hear a 71-year-old male as a smoker. Hence, I would probably in these patients do a complete workup, even rule out the possibility of a multiple myeloma solitary presentation, and then probably subject him to the invasive procedure. Again, to cut the long story short, in this case, we didn't fail as far as the mechanics was concerned because it lasted for 6 months. We failed as far as addressing the biology. Probably the biology beat us rather than the mechanics. And had we had a way to expedite improvement in biology, we may have not been able to sort of have this position. Or if you look at it, something else, whether we were too rigid with the type of cement or the amount of cement that we put in. These are thoughts that come to my mind. But truthfully, it's the biology that beat us and not necessarily the mechanics.
Very well said. Ankit is ready with this talk. So, Ankit, are you going to tell us what are the minimum investigations that we should do in a case of osteoporosis? Over to you. Thank you, Priyank.
Ankit, you need to go full screen and you need to unmute yourself, please.
In the meantime, let me ask Dr. Priyank. Dr. Priyank, it was your case, or you have shown the case. Do you feel that this cement which was put was sort of more than what it should have been, or it was appropriate?
So at the time when we did the surgery, I think it was absolutely fine because we followed the steps, did not push in a lot of cement, and there was not a lot of resistance. But like looking back, I think probably a little less cement would have been better, and maybe we should have augmented this fracture, which eventually we are going to talk about. Ankit, if you're ready, then let's. So I absolutely agree with Ram sir what he told us that I think investigations were not up to the mark, and we didn't address the biology. So Ankit is going to tell us as to how do we investigate a patient.
So
Ankit,
while on that, Priyank, you mentioned about resistance. Is there a sense that you get when you're putting in the cement? How much resistance? Does that decide how much cement to put in?
Not really. So one is the feel and the other is the watchful eye on the C-arm. Like as soon as you start seeing on the C-arm that the cement is backing up towards the pedicle site or it's leaking somewhere out, you know that you're putting in a bit too much of cement, or you see it breaching the end plate and going into the disc. So these are telltale signs which tell us that, okay, the cement is a bit too much and you should stop.
Dr. Agnivesh, is there a number of CCs that is appropriate, or it's on a case base? Dr. Ankit, we are waiting for you. Whenever you start, we will stop.
Yes, it is mentioned, sir, in the literature that you can put up to, there are various, as per the vertebral size, they have given maximum amount from 1.3 to 2 point something ml. I don't remember. But I think it depends upon fracture also. If you have a thin linear end plate fracture, you don't expect that 1.5 cc of cement is going to go into it. It's just sort of the fill which you get, and it should not be overfill and it should not be underfill also. I think it has to be at the...
Of course.
Abhay, what is mentioned in literature and absolutely right, what Agni has in fact taught me is that we can put in anywhere from 2.5 to 4 ml, depending on whether we're going lower thoracic or upper lumbar. However, something which we have used, which is non-evidence based and eyeballing, but it can be used. Normally, we put in a needle and we aspirate the amount of fluid that comes out. Very often, that pseudoarthrotic fluid gives us a volume, and that volume is actually usually adequate. And if you really study it, when you pull that down, the lucency, when you empty that fluid cavity on the C-arm, empties out almost completely. And if you've actually pulled out, let's say 3 ml or 4 ml, well, that's great. You can take that much cement. That's how I tend to sort of work and putting the cement in.
Fantastic. Dr. Ankit, over to you.
Good evening all. Sorry for the delay. Apologies. So let's move on and see how to diagnose and investigate a patient with osteoporosis. Whenever we try and investigate a disease, we need to do the differential as well. And here in osteoporosis, the differentials are hyperparathyroidism, Piquet's disease, osteomalacia, multiple myeloma, malignancy, and osteoporosis imperfecta. We should always be on the lookout for secondary cause of osteoporosis when we start foot investigation. a patient with osteoporotic fracture or osteoporosis in general. The diagnosis is based upon imaging like X-rays, MRI, bone mineral density testing like DXA, quantitative comorbid testing QCT, trabecular bone score USG, or nuclear medicine scans, bone turnover markers, and fracture risk assessment using the FRAX tool. The workup of secondary osteoporosis is quite extensive and begins with a detailed history and physical examination, followed by routine blood investigation, serum vitamin D3 levels, and specific investigations for men and women, which includes the hormone levels. Coming to the conventional X-rays, post-menopause osteoporosis, in this we usually see trabecular bone resorption and cortical resorption, whereas in senile osteoporosis there is only endosteal resorption of the long bones. In hyperparathyroidism, we have typical subperiosteal resorption, which is the loser zones. To note here is at least 30 to 80% of bone mass must be lost before a recognizable abnormality can be detected on radiographs. The indications for vertebral imaging are all women aged more than 70 years and all men more than 80 years of age if the BMD T-score is less than 1.0 in the spine, hip, or wrist. Any woman aged between 65 to 69 years and men between 70 to 79 years of age if the BMD T-score is less than 1.5. Postmenopausal women and men aged more than 50 years with specific risk factors like low energy trauma resulting in fracture during the adulthood, historical height loss of more than 1.5 inches or more, and recent or long-term glucocorticoid treatment. Conventional radiography, the DLS spine X-ray that we have shows generalized osteopenia throughout the spinal column, thinning and attenuation of the cortex and the empty box-like shape of the vertebral bodies, attenuation of the primary trabeculae and thinning of the secondary trabeculae, and vertically side appearance of the vertebral body, especially on the API radiographs. On a sagittal T1 scan of the MRI, we have ground-glass appearance of the MRI of the vertebral bodies because of marrow substitution by fat, as well as the biconvex shape of the intervertebral disc. Grading of the vertebral fractures due to osteoporosis can be done using the Kilo Copper score from grade 0 to grade 3 with graded loss of height. The hip X-ray can also be used for grading of osteoporosis using the same index, but the disadvantages here are it is subjective and affected by body posture, habitus, as well as the positioning of the limb. And here as well, 30% of bone loss should be present in order to have some significant visualization on the X-rays. Coming over to bone mineral density, there are two ways a BMD can be measured. One is ionizing radiation. The most common is DLA scan, and the second most frequently used one is the quantitative tomography, the QCT, either peripheral or central QCT. Non-ionizing radiation used is ultrasound, which is usually during camps. Indications for doing a BMD testing in women, it is the age more than 65 years of age and men 70 years or more. Postmenopausal women more than 50 to 50, between 50 to 64 years of age based upon the risk factor profile, and especially in women with an adult age fracture, low energy adult fracture. DXA should be done only at facilities which have accepted quality assurance measures and good calibration standards, and it's done at sites like spine, hip, wrist, and calcaneum. The DEXA scan is done using two X-rays of 70 and 140 kilowatts fired on the site of measurement with a lag of 4 milliseconds. The detector detects attenuation of the 2B and the algorithm calculates the B graph 3 yellow and the central DEXA lumbar spine measured on the forearm and the calcaneum. The contraindications for doing a DEXA scan is pregnancy, contrast elimination in the recent past, nuclear medicine scan using radioisotopes or radiopec implants in the scan area, and related contraindications are obesity and degenerative osteophytes, especially in the adult deformity patients. The T-score is calculated by taking the difference between the patient measured BMD and the mean BMD of the young normal population matched for the gender and ethnicity, and then dividing by the difference between standard deviation. The T-score, if it is between -1 to +1, it is a normal bone density. If it is between -1 to -2.5, it is low bone mass or osteopenia, and less than -2.5 standard deviations is osteoporosis. Coming over to bone turnover markers, the clinically useful bone turnover markers are either osteoclast derived, which are bone resorption markers, or osteoblast derived, which are bone formation markers. The resorption markers most commonly used are C-telopard, crosslink, and pyridine, whereas the bone forming markers which are most commonly used are P1NP, that is the N-terminal propeptide of the type 1 collagen, bone specific alkaline phosphatase, and osteocalcin. Bone turnover markers are useful in untreated patients to predict the risk of fracture independently of the bone mineral density, as well as the predicting the rapidity of bone loss in untreated patients. Whereas in patients already on treatment using approved therapies, they help in predicting the extent of fracture risk reduction when repeated after 3 to 6 months, as well as in predicting the magnitude of increase in BMD after treatment. They also are helpful in determining the duration of drug holiday and when to restart the medication after the drug holiday is over. The FRAX tool, which is fracture risk assessment tool, is a web-based algorithm to calculate the 10-year probability of major osteoporosis-related fracture using a questionnaire which is based upon the clinical risk factors and the bone mineral density. It gives results in the form of percentage of risk of the patient developing a fracture in the next 10 years. So the FRAX tool classifies the patient or classifies the probability of having fracture in terms of low probability, intermediate probability, or high probability. The low probability patients have to be just reassured. We have to advise them lifestyle modifications and then ask them to BSS in the next 5 years. The intermediate risk category patients have to be advised to get them BMD measured and recalculate the fracture risk to determine the risk, whether it is above or below the treatment or intervention threshold. In the patients who are categorized at high risk, we should offer them treatment without even getting a BMD done. But getting a BMD done is appropriate and helpful, particularly in young postmenopausal women, wherein we need to monitor the treatment. Recalculation has to be done after a minimum of 2 years if the original risk was in the region of intervention threshold or if the individual risk factors are more. At this juncture, we need to know that there is a big treatment gap in terms of osteoporosis. And to understand this, we can take an example of myocardial infarction, wherein a significant care gap was overcome in the last 25 to 30 years using beta blockers. The Sheffield group has now proven that a minority of women and men at high fracture risk actually receive treatment, and patients already having a fracture fracture, less than 20% receive therapies to reduce the risk of future fractures. The cause for a big treatment gap right now is lack of awareness, the prohibitive cost of medical treatment, and the lack of insurance coverage for that, fear of side effects, especially for bisphosphonates, and excessive reliance on calcium plus vitamin D combination therapy for primary osteoporosis. So what is the preferred site for bone mineral density monitoring? As per the latest data available, increasing the hip BMD are associated with a lower major osteoporotic fracture score as compared to spine BMD, and spine BMD change is not independently associated with the fracture risk. So it is advisable to try and monitor the hip BMD score when you are treating a patient with osteoporosis. DEXA versus QCT DPS and USG, there has always been a controversy which method to use. DEXA is the most commonly used, but now trabecular bone score and QCT are also available. And it has been proven that spine TBS and BMD predicts fracture equally well, and the combination is even more superior to the either measurements done alone. Also, spine TBS can predict osteoporotic fractures and provides information that is independent of spine and hip BMD. So that's a useful tool in our kitting. The grades of recommendation for osteoporosis have been laid down recently, and they have mentioned that we are under screening the patients for osteoporosis and we need to up our game. Laboratory testing is recommended for low DEXA results as well as for fracture risk assessment and patients on osteoporotic treatment. Measuring the response and compliance, BMD and BTMs are the two tools which we should be using judiciously. C-telopeptide, C-terminal telopeptide and P1NP are the BTMs which are helpful in the patient agents for anabolic teriparatide and P1 in a graded manner. Monitoring has been now proven to be useful for drug holidays and as well as to resume treatment, and predictor of long-term side effects, especially of bisphosphonates such as ONJ and acute fractures, can be predicted with using the BTMs. Bone-specific alkaline phosphatase and PDTH are recommended for patients with secondary osteoporosis due to chronic kidney disease. To summarize, we should be mindful of the osteoporosis gap. Signs of osteoporosis are always there on the plain X-rays. We should be always on the lookout for them. Hip BMD scores are better for monitoring of response. Trabecular bone score and QCT are also as useful as DEXA in the routine investigation. Monitoring of compliance with BTMs is the norm. Thank you.
Thank you, Ankit, for the comprehensive talk on all the different investigations. Dr. Raghu Verma, are you there with us?
Yeah.
I had a question. Let's say a patient comes to you and and sits in front of the clinic. Is it all these tests that you would do at the first day, or you would go step by step? What would be your approach?
Yeah. So obviously nobody is going to do all these tests at the first go. I think that 2-3 important criteria in which I would be more aggressive is a young osteoporotic lady, post-menopausal lady, the ones who've actually had menopause much earlier than scheduled, as we would look at it, because they are at a high risk to have a problem in the future. Or 2 ones who've already had some incidence of fractures, which was there, whether it's either traumatic or otherwise or a minimal trauma. I would look at them as a priority. And third, I would be more aggressive if I'm going to be treating the osteoporosis with all the modalities that we are going to discuss from here on, so that I have a prognostication of what is happening from here on. So I think these are 3 groups I would be aggressive. So ones in which I would intervene, young postmenopausal women, and somebody with a risk of fractures already there, I think, or a history of fractures already there. These are the ones I would be more aggressive.
Perfect. Ram sir, I had a question. In your vast experience, how many times practically you have had to dig in deeper and look for any secondary causes of osteoporosis? And when would you start suspecting that the patient has got some secondary causes?
Secondary cause of osteoporosis, one which we are seeing right now, is younger girls, premenopausal, who come to you with those odd behavioral patterns where you're suspecting that there is some hormonal issue. And in that odd behavioral pattern, they usually come with a DEXA report as well. And they have T scores and Z scores, both of which we are low. I mean, you're actually first a little bit upset as to why a young lady has got a DEXA done. But then they come and show you a T score and a Z score, which are both very, very low in the osteoporotic range, minus 3.5. That's the time where your antennae should sort of wake up and say that this is something that I need an endocrinologist to help me. And this is secondary osteoporosis. This is not just osteomalacia. Because majority of them will get DEXAs done, which will show a low T score because they were a part of their screening, because they are working with some organization which does DEXAs, and you get carried away. So only a low T score makes no sense. But if there's a T and a Z score both, and you have a girl who's got some other issues which are hormonal pattern, yes, that's the one there you have to look at secondary osteoporosis. On the other side, you may have men. You may have men who are coming at an age group which is again 50, 60 with things which are not dependent on glucocorticoid ingestion or any of the other secondary causes obvious. There again, if you have happened to see multiple osteoporotic vertebral compression fractures and you don't have a smoker, you don't have somebody who's had issues in the past, there again you have to dig deep and take the help of an endocrinologist and look for, again, hormonal causes for this, where again the T and Z score would actually help you clinch the diagnosis. So these are 2 situations that you have to be aware of. Otherwise, most instances where we go wrong is we tend to miss multiple myeloma. Hence, in the elderly, I'm extremely aggressive of doing a serum protein electrophoresis with an M-band with a kappa lambda light chain ratio. And I do it as a screening in most of my patients. And I do find that I get abnormal reports at times. They may be MGUS, which is monoclonal gammanopathy which doesn't have any significance. Correct. However, it's better to rule it out.
Correct. Well said, sir. Dr. Nene, I have a question for you. Quantitative CT is something that everybody is now talking about, although DEXA is the primary tool of investigation. How much has that really helped you in your practice? Or are you looking at that in the future for, changing or planning?
I think at the outset, we should give this strong message that DEXA is not an absolute value and it's a percentile, and the figures are based on Caucasian, Caucasian race. So looking at that score, which gives us a pleasure as an orthopedic surgeon to see a number, should not mislead you. And if you look at the FRAX criteria given by the WHO, like Dr. Ankit said, there are 10 criteria, of which only 1 is the DEXA. So which is where QCT comes in, because it's the actual quantitative analysis of the bone. So it gives you mass per square centimeter or square millimeter, which should really be nailing the quantity of the osteoporosis. The problem is that the percentiles are not known. We don't know the normative values. And hence, if it's minus 1.7 on QCT, we're not able to shuffle that in our head and, give it a relevance in a clinical practice. And we are just waiting for these normative values to come in before we can use QCT, which will then promise to be a better indicator than the DEXA.
Correct. So if there's any questions from the delegates, please, there's a chat box over there. You can put it up. The questions will be with us. We have got a senior panelist over here, and we'll make sure that the questions are answered. So without further delay,
I had a question for Ankit, actually.
Yes.
Ankit, would you then recommend that everyone who walks into the clinic who's above 45 or 50 should get a workup for osteoporosis? Or doesn't even walk in the clinic if you meet them socially also, because it's a silent disease? What's your recommendation?
So we should be using the FRAX tool as much as possible. And if that tool categorizes the patient into an intermediate or a high risk, then only we should start investigating. Otherwise, we can just wait and reassess at the intervals of 5 years.
And then what would that primary investigation be?
A conventional X-ray.
Just an X-ray?
A conventional X-ray.
Right. Of the PBH or of the spine?
Of the PBH as well as the spine.
And when I had another question with the permission of the chair. When you ask for a DEXA, is there a specific method that you give a prescription? AP, lateral, wrist, spine, shoulder? Is there any prescription that can be given, or do you stick to certain locations where you get the DEXA done? Is there some sense about that?
So DEXA is a test wherein it all depends upon the machine's calibration as well as the algorithm that they use. So if we are doing a repeat DEXA, it is advisable to do it at the same center so that we have more comparability. And if it's the first time, the patient can choose at his own convenience. And usually the DEXA that we order here in Mumbai is the hip, spine, and the wrists.
All right, thank you.
Yeah. So we have a question here. If Dr. Badani, do we have Dr. Badani right now with us?
Yes.
Yes, sir. If you could take that. We have a 5-year post-menopausal lady who had a slip in the bathroom and comes with pain, no neurological deficit, mild wedge compression fracture on an X-ray. What would be the line of investigations when they come to you for the first time?
So obviously, I would do an X-ray if they not come with an X-ray, and the severity of the fall would match. If it matches, then that explains that the trauma is the cause. And then definitely the quality of bone would not be very clear from the X-ray, but we get some idea of how is the quality of bone. And at that point, I would just do some basic investigation and treat the patient with rest and everything. I would not go for a very detailed investigation. And as Dr.
So which are the basic investigations, sir, that you would advise?
I would do a blood count, vitamin D3 levels, parathormone levels, TSH levels, creatinine, and an M-band, serum protein electrophores. These are basic few things I would do just to rule out, And PTH I would do because I know if I want to consider giving teriparatide, and creatinine if I want to consider giving bisphosphonates. So
correct, great.
Big things I would do.
Thank you so much, sir. So if there's no other question, I would like to move ahead with our next part of the talk, wherein here we realized that the investigations which we did was a little bit less probably. What about the treatment? Alendronate was started for that patient, but was that the right treatment for osteoporosis? Well, we have Dr. Aditya Kashikar here who will tell us how to rightly treat osteoporosis. If you may, Aditya, take over.
Good evening to all. Hello friends, look at these X-ray pictures. These are usual patients with osteoporotic compression fracture we see in our regular daily OPD practice. Few of these fractures we treat conservatively and few of them we treat surgically whenever indicated. But is this good enough? At this stage, medical management will come in picture. As a clinician, we have multiple options these days available in terms of calcium, vitamin D3, bisphosphonates, teriparatide, HRT, or combined therapy. My talk is mainly aimed to give you fair enough idea about osteoporotic treatment. Evolution of osteoporosis started in 1940s when Fuller Albright first time used estrogen in treatment of postmenopausal women. The approach of developing novel therapeutics shifted from one driven by discoveries in animal studies to more towards fundamental bone biology. Our aim for treatment of osteoporosis should be to reduce the risk of clinical fractures, rather than looking at changes in DEXA scan, one should aim to reduce the fracture risk. Patients who are in osteoporotic treatment, whether those are adherent to treatment or whether there are any secondary causes for osteoporosis, one should look for, and also insist on preventive measures. Whenever patients on osteoporotic treatment gets fractures again, one should think of alternative treatment regime or referral to the endocrinologist. American Association of Clinical Endocrinologists recommend osteoporotic treatment initiation in patients with T-score between -1 to -2.5 or with history of fragility fracture. Also T-score of -2.5 or lower, or T-score between -1 to -2.5 if FRAX 10-year probability of major osteoporotic fracture is more than or equal to 20%, or 10-year probability of hip fracture is equal to or more than 3%. So how should we determine the risk factor? So high-risk patients are considered who are having T-score between -1.5 to -1 to -2.5, one with history of fragility fracture, or with FRAX 10-year probability of major osteoporotic fracture of equal to 20%. Very high-risk patients are considered as patients with prior history of fractures with low bone density in elderly, frail patients. So the recommendations for fracture risk assessment are: evaluate all postmenopausal women age more than 50 years and male above 70 years for risk of osteoporosis. Male between 50 to 69 years with fragility fracture should undergo risk assessment, and both genders with age less than 50 years with diseases causing the secondary causes of osteoporosis one should look for. Now we'll come to the first agent in treatment of osteoporosis, that is calcium and vitamin D. These two agents are like married couple, one is incomplete without other. But frankly speaking, they are not the primary treatment of osteoporosis, but at the same time, their adequate levels in body are utmost important in osteoporosis treatment. Recommended doses for calcium and vitamin D are as shown in this slide. Myths related with vitamin D are: one protocol is sufficient or applicable for all, but which is not true. In obese patients, patients with malabsorption, or patients on anticonvulsant, the need of vitamin D is 2 to 3 times more. Calcitriol is better molecule compared to cholecalciferol, which is not true. Cholecalciferol is equally effective. Calcium increases risk of cardiovascular events, which is not true. If it's taken in recommended doses, there is no risk of any cardiovascular event. Usually patients ask us that, does calcium increase risk of renal calculi? Yes. One has to look at urine calcium and create spot ratio. If that ratio is more than 0.25, then the risk of calcium related renal calculi is high. So should we give calcium in such patients with prior history of renal calculi? Yes, it can be given safely with proper watch on urine calcium create spot ratio. Also, the lactate and gluconate molecule of calcium is good supplement, but in reality, they have got less elemental calcium. And also there is myth related with the continuation part of calcium, where it has been seen that few advise break after 6 months of intake, but there is no need of any gap or break. One can take calcium continuously. The first major pharmacotherapeutic agent is bisphosphonate. They act on osteoclasts, thereby inhibiting their action and resorption rate. It induces apoptosis of osteoclast, and mineralization takes place on this preserved lattice. Thus, the better mineralized bone is formed. The indication for bisphosphonate therapy are prevention of osteoporosis, osteopenia with high-risk factors, glucocorticoid-induced osteoporosis, postmenopausal osteoporosis. Oral and intravenous bisphosphonates can be given in preventive and treatment doses as shown in this slide. Ibandronate is given monthly, whereas alendronate, residronate is given weekly. Zoledronic acid, which is a IV form, can be given once a year for for therapeutic use and once in 2 years from preventive point of view. So total duration of these therapies before drug holiday for oral in low risk patients, it can be given safely for 5 years, whereas in IV, it can be given for 3 years. In high risk patients, it can be given for 10 or 6 years. The drug holiday, oral bisphosphonates minimum for 1 year and IV zoledronic acid for 2 years. Oral bisphosphonates can be given empty stomach with full glass of water in upright position. One should not lie down for 30 to 45 minutes after its intake, whereas IV can be given slow over a period of 20 to 30 minutes in diluted 100 ml NS. Once we start bisphosphonates, initial 3 months maximum resorption decrease is seen, and IV resorption is much more superior compared to the oral one. Advantages of bisphosphonates are it's very effective, low cost, with good compliance, with long safety data, and used in both prevention and treatment of osteoporosis. Side effects commonly seen are gastritis, esophagitis. Deadly side effects like osteonecrosis of jaw, atrial fibrillation also has been seen. It is contraindicated in hypersensitivity to drug, hypocalcemia with low GFR, and also in reflux disease, ataxia, bariatric surgery. Second anti-resorptive agent is denosumab. It is nothing but human immunoglobulin monoclonal antibody which inhibits rankle and thereby inhibits osteoclast activation. It is indicated in postmenopausal women, and also it's very much important in patients with multiple risk factors not responding to other osteoporotic agents like bisphosphonates or teriparatide. It is given in the doses of 60 microgram subcutaneously over 6 months. It can be given on OPD basis. Calcium level should be normal before administration, and calcium monitoring has to be done during the therapy. It can be given safely for 5 years. Also can be given in patient with moderate to severe renal impairment. And the best part is patient compliance is very good in this. Side effects associated with these are myalgia, joint pain, skin infection, dermatitis, hypocalcemia. Third major anabolic agent in osteoporotic treatment is teriparatide. This is nothing but recombinant synthetic parathyroid hormone. It induces bone formation by increasing osteoblast activity. Teriparatide stimulates osteoblasts, thus increases formation of new bone matrix framework. And on this denser, better structure matrix, mineralization takes place, giving rise to an overall stronger bone. So, when it can be given? So, it is ideal to give teriparatide in patients with high risk factors in severe osteoporosis, where bisphosphonates are contraindicated, or where patients got fragility fracture or decrease in BMT on treatment with bisphosphonates or denosumab. It is given in doses of 20 micrograms subcutaneously once a day with prefilled syringe. It is given on anterolateral aspect of thigh or abdomen. The maximum duration one can give during lifetime is 2 years. Side effects associated are leg cramps, orthostatic hypotension. It is contraindicated in Paget's disease, hyperparathyroidism. Now we'll come to the sequential therapy. So, the literature has shown that one should give anabolic agents first and followed by anti-resorptive agents. So it is preferred to give teriparatide first, followed by denosumab. Few miscellaneous agents brush through. First in this is salmon calcitonin, which is available in nasal spray form. It is given in alternate nostrils with dose of 200 international units per day. It gives very good analgesic effect in osteoporotic fractures and helps in inhibition of bone loss. Hormone replacement therapy once used to be considered one of the anti-osteoporotic treatments, but later on studies have shown it didn't reduce any fracture rates and it causes more harm than benefits. So they are now obsolete in terms of anti-osteoporotic therapy. Selective estrogen receptor modulator SERMs. Roloxifene is considered as one of the agents for treatment of osteoporosis in postmenopausal women, given in dose of 60 mg daily. It decreases fracture risk in vertebrae by 35% by decreasing the bone resorption. Strontium phenylate, it increases deposition of new bone by osteoblast and reduces resorption of bone by osteoclast. So that's why it is a dual action bone agent. Now we'll come to the last part of preventive measures. One should indulge in good diet habits. One should do good exercises. Sunlight exposure has to be very good. And screening for osteoporosis should be started in 4th and 5th decade. In diet, calcium-rich diet list is milk, cheese, dairy products, green leafy vegetables, ragi, soya drink. In vitamin D, oily fish like salmon, sardines, red meat, liver. One should have good exposure to sunlight. You can do exercises in any form, whichever way you are suitable with. Either it can be gym, yoga, running, or cycling, whichever suits you. So the take-home message at the end of this is avoid starting proper pharmacotherapy as preventive measure for osteoporosis in middle-aged men and women without indication. Consider proper pharmacotherapy only in indicated cases where there is proven osteoporosis on BMD, as per FRAX guidelines, with history of fragility fractures and patients with low bone density, elderly, frail on steroids. Avoid inadvertent use of calcium and vitamin D supplements. Supervise calcium and vitamin D intake via healthy food habits and drug supplements. And one can start using that in 4th and early 5th decade. There has to be strict watch on total duration of intake of bisphosphonates and teriparatide, whether we are using it as a preventive measure or as a therapeutic agent. In post-surgical osteoporotic fracture patients or in patients where fusion has been done in a osteoporotic patient, considered supervised therapy with teriparatide followed by anti-resorptive agents like denosumab and bisphosphonates. So try to maximize bone mass up to age of 35 years with good healthy lifestyle, good exercises, and try to aim to age gracefully. Thank you.
Thank you, Aditya. If you could stop sharing the screen. Does any of the panelists have any questions for Aditya here?
I had a curious question about this dental treatment and bisphosphonates. Is there a link? Because I get calls from dentists all the time saying that I'm going to do some dental job on your patient and she's been on alendronate for 2 years. Can I stop? Aditya, is there any literature there? Or anyone else? Manish? Do you know of any literature, Agnivesh, Manish?
A poor oral hygiene in patients with cancer, that is a known risk factor for osteonecrosis of the jaw. So the risk factor is primarily in patients with malignancy undergoing chemotherapy with poor oral hygiene. That's the literature I'm aware of. In otherwise, normal patients, I'm not quite sure if osteonecrosis of jaw is a major concern.
It's mostly with the intravenous therapy. So incidence is less with oral therapy. It's most with intravenous therapy.
I mean, the question was, does a dental job trigger it? I mean, what is the connect? Because it's a systemic side effect. It's not a local side effect. So does a dental job trigger it? But anyway.
No, not for dental job triggering, I don't think there's any literature.
Yeah. There's also a very common question that patients ask. Yes.
I have a question here to a general spine surgeon. We have an osteoporotic vertebral fracture, no secondary, treated conservatively. How do we go ahead? Start with teriparatide and then followed by anti-resorptive agents with calcium and vitamin D, or what is the exact recommendation?
So, Aditya, would you take the question? A patient has come to you with an osteoporotic fracture. How do you start treatment and what all do you start? Day one.
So basically osteoporotic compression fracture where we are thinking of conserving the patient. So anti-osteoporotic treatment wise, I will once assuming that all blood investigations are in normal ranges, what Ankit told us in means pre-startup workup. So assuming that all normal, I would go for bisphosphonates first, oral bisphosphonate. If at all, if I see that patient is not intellectually understandable, that maybe I would advise zoledronic acid, which is once in a year given. So that will suffice. At the same time, obviously, calcium and vitamin D will be started. And I'll keep on checking him every 3 or 4 months. So first anti-osteoporotic treatment will be a bisphosphonate.
So, Dr. Raghu Verma, do you agree here? Because we have a patient who's already has had a osteoporotic fracture and has come to your clinic. Would you start directly with bisphosphonate or would you consider something else?
So this is where I guess probably I'll be more aggressive with my investigations. And as somebody said that here I would not shy away from the fact that I'll do a DEXA. The DEXA sounds really bad. I would actually offer, if you look at cost effectiveness, I would probably look in giving an teriparatide for a period of time, followed by denosumab for sure. The calcium and vitamin D continue here as a adjuvant plan, so that when eventually there is going to be a weaning off period of both the teriparatide and the denosumab, the calcium and vitamin D will act like a backup system, because we all know that denosumab, as you kind of take it out of the system, there is a high risk of rebound fractures. So the calcium and vitamin D will stay. So I think here I'll be aggressive. If you look at this clinical scenario, I wouldn't shy away being a little more aggressive.
But isn't the biphosphonates a bit contraindicated in an acute fracture because it interferes with the fracture healing? Yes, Nene. I think probably.
Yes, I tend to agree with Dr. Rathore here that if a patient has got an acute fracture, you go aggressive, you start with teriparatide, and eventually you start, once the fracture has healed, is the time you shift down to bisphosphonate and other anti-resorptive treatment. Anybody has any other
As per the literature that I was seeing, so starting bisphosphonates in an acute setting is not contraindicated. There were some initial animal model concerns that it will affect the callus formation and final remodeling of the bone. But studies have shown, at least in hip fracture studies have shown, it does not matter. So I would not hesitate to start bisphosphonates in an acute setting.
Correct. Yes, Abhijit, you have a...
Yeah. In this acute fractures, is it, I mean, it's for all the question, can we just wait for like 4 to 6 weeks for this to heal by itself and start just calcium and vitamin D supplements, or is it just necessary to investigate all these patients who are postmenopausal with an history of fall and have an acute compression fracture? Why don't we wait for 4 to 6 weeks to see whether this heals by itself?
So technically speaking, Agni, if you want to, please.
No, it's okay. Please, you go ahead, then I will say.
Yeah, so to Abhijit's comment, technically, if a patient has had a trivial from a standing height and has sustained a fracture, which means by default it becomes a osteoporotic vertebral fracture. That's the definition. And such are insufficiency fractures. So expecting these fractures to heal on their own is kind of pushing it, because the biology here is bad. So we need to supplement, help the body heal these fractures. So I'm of the opinion as you go aggressive. In fact, one point we missed, when a person has the acute fracture, calcitonin really helps a lot because it has a bone building effect, plus it has a good analgesic effect as well. So that's my take. Agnivesh was coming up with a point.
So most of these patients who come with osteoporotic fractures, if you check their vitamin D is by default low. They are not sort of normal vitamin D. And before starting bisphosphonates or denosumab, your vitamin D has to be normal. So as it is, you give them a trial for 6 to 8 weeks of vitamin D, you let it build up and then you start bisphosphonates. There, as Mani said, there is no evidence that it interferes with the bone healing. Theoretically, yes, but regardless, all of these patients, most of them have high. So you treat it and maybe start bisphosphonates 2 to 3 months down the line.
Why not give calcium and vitamin D supplements and let it heal? I mean, why not give it a chance for 4 weeks? Why do we investigate to begin with?
Of course, Abhijit, that's a valid question. Most of us would conserve the patient and not aggressively investigate, but you use this chance as a opportunity to treat osteoporosis. Once the patient gets better, then they never come back and the osteoporosis is missed. So this is a chance to get into that discussion, start the discussion with the patient and then take it forward on your follow-up visits.
Right.
Ram sir, any final words on this discussion?
My take is one, there is an ideal case scenario and there's a practical case scenario. Ideal case scenario depends on what type of a patient you have. If there's a patient who understands that he or she has an insufficiency or a fragility fracture and is convinced enough with all parameters working in their favor. I'm not repeating the tests that need to be there. Vitamin D has to be replenished, etc., etc. But if there is a patient who's willing to be compliant, can afford, and is adherent to treatment, teriparatide would be an option to begin with what literature says today, that hit them hard in the very initial stage and then maintain the rest. However, most of our patients are not very, very eager or compliant to take an injection or a shot every day to begin with. Hence, in these patients, you begin the way Agnivesh said, that you either put them onto a combination of calcitonin nasal spray and vitamin D3, B2 and calcium till the period that D3 comes up, and then start them on an anti-resorptive. When I'm saying anti-resorptive, again here my choice would be a denosumab over a bisphosphonate today. But yes, if there are patients who are non-affording and bisphosphonate is the only way to go, yes, bisphosphonate would also come in. But a treatment-naive patient is the best patient to start teriparatide. Efficacy is the best in a treatment-naive patient as compared to one who has taken bisphosphonates earlier. So
I would just like to ask one question to all senior panelists. So are we suggesting that we start teriparatide to all fracture patients?
You didn't get me right. I said, please go through all that Abhay has said, all that Raghu Prasad Verma said, and all that Agnivesh said. We have done our DEXAs. We know that we are dealing with a severe osteoporosis. Right. We know that when a person gets his first insufficiency fracture, let's believe Raghu's TP score says minus 3.5. Patient is 60 years. She is 15 years post-surgical menopause or otherwise. She gets one fracture. If we don't protect her, she will get a second fracture. If we with vitamin D3 and calcium, she's asking for trouble sooner or later. Hence, we need to be very, very aggressive to begin with. And this is what literature supports today. We were not willing to accept this literature earlier because teriparatide was extremely expensive in our country.
I think that's...
Today, with it coming at a level where probably the middle class can afford it, we are now exploring these possibilities and are happy using it. So it's just that, yes, I am not going to use it in every patient, but in a few patients after my counseling, I would offer it. If I'm dealing with a severe osteoporotic, which is under your criteria, T-score being low and an acute fracture presentation, and I have a treatment-naive patient, I would consider teriparatide.
I would be much, much more aggressive, and I'm going to stick my neck out here and say that as per the International Osteoporosis Guidelines, a fracture rockets a patient into the severe osteoporosis category. And it's been recommended that anyone who's got an insufficiency fracture after the eligibility criteria have been, scored, you should start them on teriparatide. Dubara mat puchna. It's that significant a statement. So take it or leave it. But if you look up the guidelines, that's what it's going to tell you.
Content of my
also, one question, sir. Since you're very aggressive, which are those patients where you would consider dual therapy rather than just teriparatide alone?
So dual therapy. So there are multiple combinations that were tried. Bisphosphonates with denosumab, denosumab with teriparatide, bisphosphonates with teriparatide, and the only one that seems to work is teriparatide with denosumab. So anyone who's a higher risk, so you have a fragility fracture, you have very low DEXA scores, all the FRAX criteria are met, it's a thin lady, the chance that she's going to break a hip and need a surgery very soon is extremely high. And you are irresponsible if you have not given her the biggest shot at treatment. So I would treat these people with a combination therapy. And money no longer, I think, is an issue because the generics are reasonably. It's just about you convincing them to take an injection. If a crummy diabetologist can, convince them to do insulin every day, surgeon personalities are far more overbearing to convince them to take a teriparatide a day.
And if you can put the word across that you're going to prevent further fractures down the line, which might need intervention, I think that's going to be the final word for the patient.
And the easiest way to convince them is to just tell them the surgical charges for a osteoporotic fracture patient, and they'll directly jump to teriparatide. So I think enough pharmacology for surgeons here. Let us move ahead with our case. Yes, there's one question. Yes, of course.
Request to my colleagues. Please do not use teriparatide for 3 months, 6 months and call it a day. Humble request, use it for 24 months, what it is recommended for. Earlier it was 18 months. Please don't create a situation where we will have patients who do not respond to teriparatide, where I took 3 months treatment 8 years back and I took another 6 months 2 years back. Should I now take the rest of the treatment? So please be aware, we have no literature on that, but if you study, they work best beyond 9 months. That's the time that they sort of start getting the upward slope, and to maintain it, you have to go at least up to 18 months and ideal up to 24 months. So please don't try using 3 months and 4 months. Humble request to all of you.
Absolutely perfect, sir. In fact, my next part of the talk is going to exactly
so who should have an osteotomy?
Tell us what Ram sir just told us. This same patient where the vertebroplasty started failing, that patient was put on teriparatide, and look what happened. With time, over 18 months, we saw that the fracture started started healing on its own, and at 18 months, patient was absolutely fine. And I don't think any revision surgery would have helped us achieve this. So basically, teriparatide saves life. And the bottom line is teriparatide is the treatment of osteoporosis. All others are time-buying options. So how to really use it correctly is where Dr. Ketan Badani is going to tell us, so that this misuse of teriparatide stops. Sir, if you could take over.
Can you see my screen?
Not yet.
No,
Ketan.
not yet. Not yet.
Yes, Ketan. Yes, Ketan.
Yes, now we can.
So we are hot on the discussion of the uses of teriparatide for treatment of osteoporosis, and Aditya, in details he outlined the how the anabolic effects of teriparatide are useful in the treatment of osteoporosis by improving BMD and bone quality. I'm not going to go into details of that. However, the important point which we were just discussing a minute ago is, can it have a role in the treatment of osteoporotic vertebral compression fractures?
Survival is almost 100%.
Can it enhance fracture union, give early pain relief, and heal faster, thereby giving early mobilization and improved quality of life? So interest has been generated in this direction, and not many papers are available, but the papers so far, they try to study the pain relief, quality of life, the speed of healing, the amount of fracture collapse and kyphosis, the union rates, and the changes in the bone marker levels. So these studies could be grouped into two types. One that studied the efficacy of teriparatide versus bisphosphonates, and the one that has studied the efficacy of teriparatide versus standard calcium D3 therapy, which we are just discussing. So in the group that compared teriparatide with bisphosphonates, there were 3 studies. 2 of them used teriparatide therapy, whereas one of them used a weekly teriparatide therapy, which is also another way of using teriparatide. Some use weekly, some use bi-weekly, and the efficacy in osteoporosis was found to be good. So this also has been extrapolated to the treatment of osteoporotic fractures. And the criteria studied by these different studies were rate of healing, speed of healing, pain relief and quality of life, and the radiological parameters of collapse, kyphosis, and the correlation of the radiological findings with the clinical benefits. So in the group of teriparatide versus bisphosphonates, what they found was that at the early stage, 6 months, and in one study at 3 months, the union rate was significantly higher. The percentage of fracture that united was significantly higher, but at a long-term follow-up of 20 weeks and 27 months, the union rates were similar. So the difference seems to be that with teriparatide, the union seems to be occurring faster. Comparing the radiological parameters, the teriparatide group had less loss of the body height, less
Is
increase in
actually
the
quite accurate and
kyphosis,
quite good.
and significantly high levels of P1 and P marker of osteogenesis at 12 and 24 weeks. As regards pain relief, there was a significant pain relief in the TPD group at 4 weeks as compared to 12 weeks in the bisphosphonate groups, and the clinical improvement seemed correlated well with the radiological parameters of vertebral height loss and kyphosis. So in the TPD group, the better radiological parameters and also better clinical results and earlier pain relief. So prior treatment with bisphosphonates seemed to have a negative effect on the fracture healing because of suppression of osteoclasts which severely disturbed the bone remodeling. So in that respect, the TPD group was adversely affected in those patients who had taken bisphosphonates prior to the fracture. So prior bisphosphonate use seems to be having a negative impact on the healing of the vertebral compression fractures. Now the second group, where there is comparison between TPD and no TPD, only calcium vitamin D3. So again, you had two studies, one with the daily TPD, one with weekly TPD, and they studied very similar parameters which I described earlier. So in the study with daily TPD, the pain scores, kyphosis was less, collapse was less in the TPD group as compared to the control group, but the difference was not significant. The important part is that here the TPD was given only for 3 months. You know, as Ram said, that short therapy is not useful. But here the study duration was 3 months, which may be very inadequate. In another study group, which was only also for 3 months, and weekly teriparatide was used, it was found that the union rates were significantly higher in the teriparatide group, and the fracture site mobility on dynamic X-ray was significantly lower in the weekly teriparatide group. So from these from this information or from these findings, can we eliminate the need for vertebroplasty in these compression fractures? Now, it is the biology that fails, and that leads to non-union, and that is the stage where vertebroplasty is required. So if we can enhance biology somehow, we may be able to reduce the need for vertebroplasty. Hence, our approach should be to enhance biology with the use of any available therapy is very logical. In this case, is teriparatide. So overall inference of these studies show, although small in number, that primary teriparatide treatment in fractures leads to faster healing, earlier pain relief, and higher union rates than if teriparatide is not given or if bisphosphonate is given instead. So the take-home message is that the teriparatide seem to have the potential to accelerate fracture union, offer early pain relief, improve biological union rates if used primarily, and thereby it may be able to reduce the need for vertebroplasty. Vertebroplasty shall always remain a backup salvage procedure because even teriparatide and nothing can give 100% results. Thank you.
Thank you so much, sir. So I think it was an excellent summary to everything that we just discussed. Without taking any further questions, because I think this talk summarized everything that we spoke. Let's go to the next case that we have here. So here we have a 75-year-old social worker with osteoporotic vertebral fracture who was under conservative treatment. He progressively had increase in back pain. He was managing his activities of daily living, however, with discomfort, though he was not totally disabled. Those are his X-rays, which showed intravertebral instability with Kummel's lesion formation. So the further MRIs and CTs confirmed the same. Here, what would we do? on one hand, after Dr. Ketan Badani's talk, we know that teriparatide can resolve the problem, but here the patient is getting into discomfort. He is a little disabled, but not enough to warrant a major surgery. So what do we do here? Vertebroplasty is something that is in between a conservative treatment and surgery. It's a modern day approach to vertebral insufficiency fracture, wherein the strategy is that the empty space in the vertebral body is filled up with cement. So we technically acutely heal the fracture. To tell us more about vertebroplasty, I would invite Dr. Manish to share his screen and he'll teach us how to do that. Manish, if you may.
Yeah, can you see my screen, Priyank?
Yes, we can.
Right. Yeah, thank you, Priyank, for Agnivesh for having me here. So, now coming to the vertebroplasty, I'll be talking on the technique of vertebroplasty. So, as we discussed, there's a Kummel's lesion in the upper lumbar spine, and that is causing a severe pain to the patient. Now, when we talk of vertebroplasty, what are the goals of vertebroplasty? One is that you want to have an adequate fill, not too much, not too less. The cement has to fill the crevices of the fractures or the cavity, whatever is there. You have to avoid complications because this is supposed to be a pain relieving procedure. And the procedure itself should be painless. You should not give more pain to the patient while doing the procedure itself. So coming to what equipment you need is step one is you need all your equipment, their materials for local anesthesia. Second, you need Cook needles. So there are two types of needles available. One is a Cook needle, other is a Jamshidi needle. Cook needles, I prefer overall the diamond tip ones because your needle placement is very comfortable. The needle does not slide. On the other hand, if you use a Jamshidi needle with a bevel shape, the needle frequently slips if you're having a slightly larger or a globular facet. Next, you need cement. So cements are also nowadays you get ready-made cements, vertebroplasty cements, which have longer working time, and you can also use the old Simplex P, where you will have to add barium sulfate. We'll get to that later, and you'll need your basic general instruments. Make sure that your OT is cold as well as your cement is cold. It is kept in the fridge. These are basic principles of cementing we all orthopods are aware of. Now, one important point that I would like to make is don't position the patient first and then you scrub and let your nurse scrub and then make the trolley. What I always follow is these patients are going to be under local anesthesia. Prone position is frequently very painful for them. So I make sure that the nurse is ready with all the equipment, the C-arm is on, checked. Then I position the patient, check the C-arm, and my assistant is already ready, scrubbed, ready to drape. So by the time I am done checking my C-arm images, someone is already ready to scrub. So you save the pain of the patient. Next, we look at what we need. So you need a hammer, sponge holder, some arteries, basic other instruments. Important, you need 20cc syringe and you need 1cc syringe. You can use also with a lure lock, prevents cement leakage, but that's not really necessary. And this is the Cook needle that I usually prefer. At this point of time, make sure that your cement is still in the fridge. Many times your nurse or someone will call for the cement right at this stage because you've taken the case in the OT. You have to tell specifically, please keep the cement in the fridge. You don't want the cement to become warm, especially if you're using Simplex P. Next comes the magic part. You want to give fantastic local anesthesia so that the patient does not need much of sedation and you can get the patient up very quickly. So for a single level, what I use is 10 ml anavin, that is 0.25% levobupropion, 10 ml of lignocaine, and 1 ml of soda bicarb. This soda bicarb is not frequently used. I use it specifically because it makes the lignocaine alkaline and reduces the stinging pain that lignocaine gives. But make sure you don't add too much of soda bicarb because that will make the solution crystalline, which can cause tissue necrosis. Now, of course, protect yourself. Now we come to the positioning. So before you start positioning, you connect the patient to monitors, pulse, BP, basic, secure, and IV line. Make the patient comfortable. Just ask the patient repeatedly to go in whatever position you are comfortable, and then we'll adjust everything around that. We don't try to position the patient exactly dead straight. Just let the patient be. You can tilt the table and other things to make your SIAM images proper. Next comes is you square the vertebra.
And
So in
continue
a
this journey of
fractured
joint preservation.
level, you may not always see the end plate. If both the end plates are fractured, it will be difficult squaring the vertebra. So you can look at whatever is the unfractured end plate, or you look above and below, and you square the vertebra in the coronal plane. Make sure that the spinous process is in the midline. And again, I'm mentioning that you tilt the table as you need. You don't want to make too many adjustments to the C-arm tilting. If your C-arm is 0-0 in all positions, that's the simplest,
High impact
fastest
journal,
way
in fact, perhaps
of
the highest.
getting through vertebroplasty. If you each time you have to make angles, this angle, that angle, coronal angle, then it will save a lot of, it will cost you a lot of time, and the patient has to lie down unnecessarily. Next, giving the local anesthesia. I usually make sure most of the time, around 50 to 70% of times, I get away with local anesthesia alone. So around 1/3 of the times, I have to give sedation as well. So I just put a very tiny needle, 23, 24, sometimes even 26, just to mark where my entry is, get a bleb on the skin. Then I use a spinal needle and let it go right to the bone at my entry point. I check at this point on C-arm whether the needle tip is at the entry point, so that only the relevant area is anesthetized and you don't end up injecting too much of the local anesthesia volume. Many times these patients are around very thin and frail, and you don't have much volume to work with. So you want to go exactly where your needle is going to land, the jump sheet needle is going to land. Next, you obviously save your fingers from radiation. Use a sponge holder to check your entry point. So our ideal entry point should be up and out. So using a clock analogy, on the left side, you should be from 9 to 11 o'clock. On the right side, around 1 to 3 o'clock. That's your landing point. That's your starting point. This is where you dock the needle. So in this case, this is just around on the left side, 11 o'clock. On the right side is around 2 o'clock. And you are on the upper part of the pedicle, and you are just entering the pedicle at this stage. Now, gradually, you have to imagine, as per the level, you will be aware what each pedicle has its own orientation, and according to that, you have to direct your needle as well. You want to go from the upper outer quadrant of the pedicle to the target area of where the fracture is. So things that can go wrong is how to proceed here is what I'll show through the next few slides.
Dissect the aims of skill.
You are proceeding in the AP view, and you've already crossed the medial pedicle line, but you've not yet crossed the posterior vertebral body. Then you are 100% in the canal, and that's a wrong trajectory. On the other hand, if you are still on the outer part of the pedicle, but on the lateral you have crossed the posterior vertebral line, then you are outside the vertebral body, and probably you are going either completely out, or you are going back again inside the vertebral body, which means that you will be in the lateral half of the body, or you will be outside, and your cement will not go across the vertebral body. So when you have to have a good trajectory, your needle has to go medial, from lateral to medial. So when you've crossed the posterior vertebral border on the lateral line, you are in the AP view, your needle should still be medial to the medial, lateral to the medial pedicle line. I hope I'm clear on that.
In
when
India,
you've crossed the posterior vertebral body, your needle should still be outside or lateral to the medial pedicle line. That is a safe, that you're 100% in the vertebral body. And once you've crossed the posterior cortex, you want to medialize as much as possible. Try to reach the center of the vertebral body. So most of the times I use bipedicular in a very frail or a small fracture. I use unipedicular as well. I also use dye injection. So in this case, you can see that after injecting the dye, it's gone all in the vertebral venous plexus all the way up 2 or 3 levels above, and it is not going to the targeted fracture level. And essentially, so you readjust, and then you re-inject the dye and make sure it is reaching the fracture. Next comes the cementing part. So if you're using Simplex P or cement, any other cement which does not have barium in it, you can take barium sulfate. We'll come to the
if you look at it globally,
so the barium sulfate has to be in a very exact proportion. We'll just go through this in a video. So you emptied the cement. And you've opened up the barium sulfate. The barium sulfate is very frequently granular. Now you want to make it degranular. Just pinch it with your fingers and make sure it is completely powdery. And then you take about half a spoon of cement, take it out, and you take an equal amount of barium sulfate and mix it in the cement. So that's equal amount of barium sulfate, and mix it in the cement. Once you've done that, then usual procedure of adding the monomer. You don't beat the cement like an egg. You gently work around it, let it enter the liquid phase, and gradually it will become a liquid.
Ski should be tapping.
It will start becoming semi-solid, because this is simplex ski. It gives you only around 6 to 7 minutes of working time. So you have to hurry up at this point of time. You take up a 20 cc syringe, fill up the syringe, and I keep a 1 cc syringe under the 20 cc syringe so that there is no wastage of cement. As it flows back into the 1 cc
and with those pins in mind,
like this, you fill up around 4 or 5, then you let your nurse fill up the rest. And at this time, you look for the consistency of the cement. So next is the consistency of the cement. When do you start injecting? So you start injecting at a toothpaste consistency. You just use one of your syringes, 1 cc syringes, and look whether there should be no drops of cement falling on the floor. The cement should stay attached to the syringe tip, which is called as the toothpaste consistency. This is the right time to start injecting. Before you start injecting, you inform your anesthetist to monitor the vitals and SpO2. Monomer can cause a pulmonary embolism. And this is just a very quick video of cement injection. So these are the needles passing through. First, I'm going to inject the dye. It is going into the fracture. I'm happy with the fill of the cement. I wash it with saline. And now I'm ready to inject cement. So cement injection is always done in purely lateral position. You don't change into AP while you're injecting the cement, unless you want to see the fill of the cementing. Mostly you don't want to see AP. This was a Kubel's lesion, so I've filled the Kubel's lesion reasonably, and you come up to about a middle third of the vertebral body, and that should be sufficient. So as Dr. Ramchandra had said earlier, you measure how much the volume had come from the fluid had come from the cleft, and approximately the equal amount you inject the cement. Slightly lesser is usually better. Once cementing is done, you wait for the cement to kind of set outside, and then you remove the needles in a rotatory motion. You don't want a tail of cement tailing around outside the pedicle, which itself can cause pain. As I said, it should be a painless procedure. And if you've done your job well, then many times the patient has had no sedation, and you can get the patient standing in the OT itself. Thank you.
Thank you, Manish. Do we have any questions for Manish here?
I have a question for Manish.
Yes.
Manish, can you highlight why do you use small syringes, multiple small syringes, and not a bigger syringe?
Yeah, very good question, Dr. Agnivesh. So if you see the caliber of the Jamshidi needle, usually use 11x10 needle. The caliber of that and the caliber of the nozzles, they have to match. If the injecting pressure is too high, if you use a 2 cc or even a 5 cc syringe, the pressure gradient is very high, and that itself will cause cement to heat up and set quickly. So you want it to flow easily without causing pressure-related heat in the setting of the cement.
Manish, what's the role of barium sulfate?
Barium sulfate is to make it radio opaque, sir, and you want to see the cement flow exactly millimeter by millimeter. You want to avoid any complications, the cement flowing into the veins or cement coming into the canal.
We have radio opaque cements available. Why don't we use that?
Yeah, of course, that is available, but this is far cheaper. This cement simplex fee is 1,500 rupees. A radio opaque ready-made cements are 10,000 rupees minimum. So,
but if you,
that was a fantastic demonstration. I had a question about the dye. Do you think, or would you hard sell that all of us use the dye before?
Not really, sir. It's a personal choice. I like to feel happy before I inject my cement.
Is there
it's
any
not
pros
necessary.
and cons in your mind about using versus not using?
Yeah, there's a definite pro. That's why I use it, sir. I want to make sure that my cement is going to go into the fracture. Many times you have a fracture which is just limited to the superior end plate and not to the inferior end plate. You want to make sure your cement goes into those crevices of the fracture and not at the inferior end plate. So you want to you have a chance to redirect your needle and let the cement go into the relevant area.
Also, one needle or two needles, what do you recommend for us?
Both sides is a very personal choice. So I like, sometimes I like two needle. I like in a very frail or a general collapse, I can get a out in technique and get it across to the midline. If I don't get it through the midline, sometimes I will add the second needle from the other side.
If I can make a point there, I think in the cumulus, you can easily get away with a single needle because it generally, if it's in place, mind you, then the flow of the cement generally is much better with a single needle. I think it's the other ones where you don't have a well-defined cumul where the buy might be, that's been my experience.
It also depends on the pedicle. If the pedicle is very narrow, you can't get it across to the midline. If you have a large pedicle, it's very easy.
Do we need to get a CT scan before we decide to inject the cement prior to just to see whether the superior end plate has been completely healed or not? Otherwise, probably, like if the superior end plate is not healed, it will create another rough area and then probably like what Ankit showed the first case. And, like it might just erode onto the superior vertebra.
Yeah, that's a valid concern, sir. So in certain cases, you want to look at the superior end plate, but if there is a wafer of bone available, you can make it out usually on X-rays. It is not a routine part, but in select cases, I do use it.
In fact, we are going to talk about it very soon. Yes, Ram sir, you had a question.
I have a question and I have a comment. One question to Manish and anybody else, everybody else. If you had the luxury of using two C-arms, since this is a time-bound procedure where at times you're rushing against the clock, would you be happy to use two C-arms? I use it at request. I request my colleagues to give me or do it at a time when the two C-arms are available, and I find it gives me more breathing space. Just a question to anybody and everybody.
I agree with you, sir. Using two C-arms is a luxury. If you're in a place where, as in Jaslok has three C-arms, so I can use all of them if I want to. It saves time, it saves radiation, and your trajectory is far superior than using AP lateral repeatedly. Just yesterday, I did a 3-level vertebroplasty in a kyphoscoliotic. So two C-arms really saved my day and got me through without losing my patience.
And a second comment which I had, I tend to decide whether I'm going uniportal or biportal based on a preoperative CT or MR at the level of the camal. Very often, if you see the axial cut at the level of the camal, it can help you decide whether you'll actually need to put two needles or one will suffice. If it's an eccentric camals, maybe one will help. If it's a large camals going on both sides, I may then use biportal. So I'm very open to it and just use it as a guideline. But I don't disagree with what Raghu says, that if it's a fluid-filled camal where you aspirate it from one side and let's say 2.5 to 3 ml has come out free-flowing fluid, then it's easy to put it in right from there. You're absolutely right.
Manish, I had a question for you and in fact all the panelists. Do you always do it under local anesthesia? Are there any cases where you recommend general anesthesia?
If you're using a kyphoplasty, then you have to use general anesthesia as a painful procedure. But vertebroplasty, well, so far I've never done under general anesthesia.
In fact, and let's say if you're doing like a 3-level procedure, like just the one that you do, the cement that you showed can be used for how many levels? Like, do you
up to 3 comfortably, because it has 20 cc's of cement, so practically it gives you around 18 with all the spillage and all. You are not injecting more than 3 to 5 per level. So one.
But do you ever see that it sets before you are able to finish all 3 levels, or you are comfortably?
No, I have if I'm doing 3 levels, I am doing 2 levels, and my assistant is injecting simultaneously on the 3rd level. So that's how you save time.
Great. Now there are 2 big and scary complications of vertebroplasty. One is cement leakage, and the other one is embolization. So, Ram sir, could you share any experience if you had, or any tips where we could prevent or reduce the chances of embolization of cement?
Embolization is something, to be very truthful, you have to have a proper preoperative workup. Although this is an under local anesthesia procedure, they are usually elderly patients, and you need to actually have them checked by their intensivist, cardiologist, or your anesthetist and decide, as far as the ASA criteria are concerned, how bad they are and counsel them for the same. We cannot have a foolproof way of preventing an embolization. If it happens, it's unfortunate. As far as cement leakage or cement embolization is concerned, which may go into the venous plexus, I have a dear friend in UK, Dr. Manoj Krishna, who had actually even shared this experience and has some articles written where he mixed some gel foam along with the cement which was being injected. Plus, he used to do the cement injection in 2 stages, which means he used to start a little bit earlier before the toothpaste phase, just getting into toothpaste, inject maybe half an ml or into the vertebral body of 1 ml and wait. Take a shoot. Be very, very sure that it's not going into the wrong area, similar to what you do with your contrast injection or a dye injection, whatever you want to call it, and then complete the procedure. So he used a combination of adding gel foam to this mixture, where he claimed, I have no contact with Manoj anymore, but there is, if you look up the literature, Manoj has written about this. I have no idea if anybody else has similar experience.
Interesting. So do anyone has any last comment before we proceed? Because in the interest of time, we have to rush.
There's a question in the chat box.
Yes.
What is the time limit duration since fracture for kyphoplasty?
So in fact, we are going to come across and discuss about kyphoplasty in just around 5-10 minutes. If we can take that question at that time. So, now, based on this, technically all osteoporotic fractures are going to heal by nature. But for those that don't, we have and are painfully symptomatic, vertebroplasty is the solution. That's what we get by this. But is it really that simple? Is it always that rosy? Now, in this patient, it fit in all criteria and we did a good job at vertebroplasty. But at 8 weeks, see what's happening to my vertebroplasty. It's consistently failing. So here, I would like to know that what was wrong? Did we select a bad patient? In fact, I would like to throw across this question to our senior panelists who have had a lot of experience in vertebroplasty. Dr. Nene, can you tell us what are those patients you don't want to do vertebroplasty in?
I think my default is that I don't want to do vertebroplasty. And there are very few patients where I want to do, because I feel that by definition, the procedure is a lopsided procedure. You're trying to put in a stone in a pile of cushions, and it doesn't make sense. Even if it's a successful vertebroplasty, in the long run, it's doing more harm than good. Having said that, it's got an excellent potential of an early, excellent early results. So to answer your question, anyone who's extremely frail with severe osteoporosis, whose lifestyle is reasonably restricted, is maybe a good candidate to get this done. But a fitter older man who has a fairly young back, so to say, young lifestyle, he's going to load his back a lot, and poor T-scores, I feel would be a bad option, bad candidate for V-plasty, because he's going to break the bones around it, as we published in the past, that.
Correct. And does timing have any bearing? Like we did it at 8 weeks. Is there any recommended timing when you should perform this procedure?
So again, I'm going to stick my head out and say that I would just delay as much as I can. And today, teriparatide has bailed me out of most of my planned vertebroplasties. So if I'm able to start teriparatide on day 0, by the time it's 6 or 8 weeks, the fracture heals, even the Kummel's lesion heals. And again, we're about to publish a series of patients who needed intervention, who got bailed by teriparatide.
Correct. Dr. Raghu Verma, have you seen any patients of vertebroplasty which eventually you found out to be infection?
Yeah, so I can remember about 2 or 3 of them. Interestingly, one of them was actually, I had done a vertebroplasty, and like was discussed earlier, I took a little sample of the fluid and I was dead assured that it was a osteoporotic fracture. And when we got the vertebroplasty done, patient was good, went home very happy. But when the fluid was analyzed, they actually brought out Mycobacterium tuberculosis. Interestingly, what it helped me was that it made the patient very pain-free. And then the antituberculous drugs bailed me out, because anyway, the infection part got better. I can remember 2 or 3 of them in which infection was the primary diagnosis, but I thought it was an osteoporotic vertebral fracture. Having said that, we rediscussed the MRI afterwards, and the radiologist was thankful enough to agree with the fact that they would have also gone by and said it was osteoporotic fracture. So it was not an error judgment.
So in that case, do you send the sample across for testing after every?
Yeah. So for me, I think especially the ones in which I get I try my best to get a sample. All my vertebroplasties, I think I put in the needle with a concept to get the sample. If you look at a ballpark, about 60% or 70% of them, I actually get a diagnosis. I know there are 30% of them where I don't get a diagnosis, but I always follow up those patients, whether it is fluid for a cytology, which is probably not the best, or a bone sample. Sometimes I've actually exceeded the entry of the vertebroplasty needle more to kind of go close to the anterior cortex and get a sample, because you have to make a little effort. We are here to put in cement, which is our primary motive. But over the last few years, I have always made it a point to get the best shot at getting a biopsy sample, I think.
Great. So, Dr. Ketan Badani, in this patient where the vertebroplasty failed, do you think if I would have done something like a kyphoplasty or a vesselplasty, it would have given any better result? What is your experience with those procedures?
Yeah, I think that if you do a vertebroplasty, your aim should be to put cement which will intertwine with the existing bone, ideally, to make it into a uniform structure. But if you do a vertebroplasty where the cement becomes like a ball, same thing will happen in a kyphoplasty. There, I think there are greater chances of failure because the whole ball has got more potential to move, especially if the resorption occurs around the cemented area. So I don't think that kyphoplasty would have been a better solution for that. If it had to fail due to certain reasons, both would have failed.
Correct. And Ram sir, what do you think about the new procedure which is out there, vesselplasty?
Well, I have no experience with vesselplasty, so I'm not here to comment on it. I have done some kyphoplasties and vertebroplasties both. And what I've learned is that high volume cement is asking for failure. Under cementing low volume, accepting a little bit of deformity and doing it delayed, which means not doing it in the first 6 weeks, but doing it later, you can probably get away, provided there is no instability posteriorly in the interspinous area. So we have to always be very vigilant that we are dealing with something where the culprit is biology and the mechanics is not too bad. If the biology and mechanics are both bad, then we have to address the mechanics as well.
Well said, sir. So moving ahead with our talk, I think we have a good summary here that we should identify those patients which have had an insufficiency fracture with a non-union of 3 to 6 weeks, symptomatic with edema on MRI, not a major loss of vertebral height and minimal canal encroachment. Guys, watch for those fractures where there is neural canal encroachment locally, non-contained fractures or fractures close to end plate. Focally, if there is a lot of kyphosis, instability, or pre-existent adjacent pathology. And in general, a very severe osteoporotic patient and a high demand back. Please keep away and don't do vertebroplasty in such patients. So what about these cases? They have a fracture. They're very close to the end plate. They are disabled, but not enough for a big surgery. You really don't want to offer them a big open surgery. Can vertebroplasty be given? Yes, of course. But after hearing the expert and with experience, I'm not too in favor of that. So is there any way to augment our vertebroplasty and make sure that it doesn't fail? Well, we have Dr. Abhijit Pawar here to share his experience and tips on how to augment vertebroplasty. Abhijit, if you could take over.
Can you hear me?
Yes, we can.
Okay, can you see my screen?
Yes.
Thank you all. So I'm going to talk about vertebroplasty and minimal invasive stabilization in osteoporotic vertebral fractures. So just now, Ram sir told, we discussed about biology. I'm going to talk about mechanics when the mechanics fail in this osteoporotic vertebral fractures. So these are the patients who had worsening of back pain and progressive deformity and some neurodeficit. So you have to identify the spine at risks in these patients who had worsening of pain and progression of kyphosis as well as worsening of neurology on conservative management. So there are several risk factors you can see on this CT scan or X-rays or even MRIs. I'm going to just pen down few risk factors which you have to look for in these patients for mechanical instability. You need to look for incomplete burst fractures. They're at high risk for non-union. Need to look for vacuum sign on MRI. Local kyphosis of more than 20 degrees. Also for retropulsion and spinal canal encroachment for more than 25%. Also look for posterior ligamentous injury, as we discussed, Dr. Ram sir said right now, and also for multiple wedge compression fractures. These are the patients who have tendency to get worse and they will progress to further neurodeficits. So you have to pick them up early. I'm going to start with one case here. 78-year-old female, wheelchair bound. She was ACR D. She had multiple risk signs on this X-ray and MRIs and CT scans. She had vacuum sign, local kyphosis of 24 degrees, vertebral body height loss of anterior vertebral body height loss of 50%. You see here, and retropulsion as well as spinal canal encroachment. So since she was 78, we went ahead with vertebroplasty and minimal invasive stabilization. Since she was osteoporotic, we also augmented the screws with cement, that is fenestrated minimal invasive screws. This patient did well, and she did improve from ASIA D to ASIA E, and now she is ambulating well. She was also given biologics later on to heal the osteoporosis and so that she doesn't develop any new fractures. This is another 82-year-old male patient who had also ASIA D neurology at presentation, and you see he has local kyphosis, vertebral body height loss, significant retropulsion, spinal canal encroachment. And so this patient was almost non-ambulatory because of pain. I mean, he was ASIA D, but he was not able to walk independently. He needed support. So he underwent vertebroplasty and just minimal invasive stabilization. Now these patients, when you position them prone on bolsters, you get partial correction of kyphosis, and then you can do the vertebroplasty and the minimal invasive stabilization to augment this vertebroplasty. If the encroachment is significant, you can go ahead and do a minimal invasive decompression from the midline if necessary. This is another patient, 65-year-old patient.
How they can serve
incomplete
better
burst fracture, had a minimal retropulsion and tricolumn injury he had. So he underwent minimal invasive stabilization and vertebroplasty. He did well post-operatively. So vertebroplasty plus minimal invasive stabilization. Vertebroplasty stabilizes the anterior column. The fixation provides stabilization of the middle and the posterior columns. Correction of kyphosis and fairly good restoration of anterior vertebral body height results in indirect decompression. The midline decompression can be done necessary if the stenosis is significant as necessary. Usually I feel that if it's more than 50% canal compression, then you can go ahead and do a small midline decompression. This is another female patient, similar patient, underwent similar procedure, vertebroplasty and minimal invasive stabilization. This is another similar patient, same procedure. So vertebral compression fractures with retropulsion and neurological involvement can be effectively treated with minimal invasive stabilization and vertebroplasty with or without local decompression. What we have seen is this: most of these patients are elderly. They will not tolerate a large procedure like vertebral column resection. So they have a lot of comorbidities. So this procedure, which involves only vertebroplasty and minimal invasive stabilization with or without midline decompression, is well tolerated in these patients. And they do improve well, and they get back to ambulatory status very quickly. So this is one of the procedures which should be considered in patients who fail biologics and who have mechanical instability with all these risk factors. Thank you.
Excellent presentation, Dr. Abhijit. So so this is like a wonderful tool that you have in your box. Can you stop sharing the screen so that we can have the discussion? So this is an excellent tool. So basically what I understand is patients who you want to do vertebroplasty, but they are, not that, either not that bad, or they don't have that, or you are medically unfit. You can augment it by just passing MIS screws. Are there, like, in general, how many, like, we have a question from Dr. Srivastav asking that how many patients would you really decompress, or all of them get sorted out with ligamentotaxis?
See, if there is more than 50% canal compromise, you can do a midline decompression. So you are happy, that you've done a decompression in the midline. I don't go and do a vertebral column resection or something. You have to make a call by yourself that, okay, there is significant stenosis there. You go and make the patients prone. You achieve some correction of kyphosis, that's great. If you don't achieve kyphosis, which is a rigid kyphosis, you go in the midline, take a small incision and decompress it.
Correct. And this procedure that we are doing is for those patients which are, those not the ideal candidate for a percutaneous vertebroplasty. So you are kind of
where the mechanics is failed.
Yeah, yes. So you're kind of extending the indication. So the chances of things like cement leakage and all is high. So what would you say, like, if you're doing this procedure, MIS stabilization with vertebroplasty, have you had times where the cements have leaked in the canal and you had to open and clear it out?
Not till date.
Not till date.
I mean, the cement has leaked on the side, but not in the canal. I mean, I have seen cement leaking on the sides, but it was never a problem. It has leaked in the disc space. I've seen that very frequently while doing vertebroplasties as well. But I don't think that leads to any problem with disc space leakage or leakage on the side.
With the permission of the chair, if I can ask a question.
Yes, of course.
Actually, for all the panelists, one of the issues sometimes is, I think, where Abhijit talked about, he had an ASIA-C neuro, so obviously a neuro. One of the difficult decision makings is actually when you have nil neuro, a walker, but at the CT and the MR studies look at about 50% compromise. So now here you have a walker with about 50% compromise in the CT, MR, in the axials. There, would the panelists look at decompressing or would just resort to the ligamentotaxis as a concept? What is the general consensus?
I would go with ligamentotaxis because these patients would do well. Because as you position them and fix them, you can correct the kyphosis. It would lead to indirect decompression.
So neuro as a criteria, if it's negative, normal neuro, you would just not decompress.
Normal neuro, even it's a neuro, it works well.
Even with neuro, it works well.
Yes, absolutely.
If I say something, there has been an old study which showed that when the fracture heals, or you give stability, the retropulsed bone usually resorbs. There have been very old studies. So in case when there is no neuro deficit and you are stabilizing, I would expect that the bone to resorb. So in the situation of a nil neurology, I would use that information to not open and decompress the canal.
Yeah, in fact, the next part of our talk is what to do in patients with neurology and canal encroachment. So I think we'll continue the discussion after the further part of the talk. Anyone else has any questions for Dr. Abhijit?
Abhijit, I have a question.
Yes.
When you do these patients where you done a minimally invasive with a sextant and you limited yourself to 4 screws, have you had any situation where you felt like putting in 6 screws or 8 screws? And
yes, have
you managed it reasonably well?
Yes, I had about 3 failures. About 32 cases I have done. I had about 2 to 3 failures where I had to go and extend the fixation because the screws had backed out. So now,
did you learn anything from those 3 failures where you could tell us that these patients need a longer construct?
Yeah, what I learned is if we can use fenestrated cement augmented screws, then you can shorten the fixation. So nowadays, if the patient is above 75 plus with a low DEXA score, then I tend to put cement augmented MIS screws rather than just regular screws.
Another question.
Otherwise, you can go for a little 2 levels above, 2 levels below MIS stabilization.
Another question to you. You've created a strong construct in between, like 3 vertebrae are stronger than the vertebrae above and below.
Right.
Have you got any thought of trying to put just a prophylactic vertebroplasty above or below?
I have done in one or 2 patients, but I can't tell you the results. But I think it does make sense that if you do prophylactic vertebroplasty, it would avoid further collapse or the construct failure.
Because the level above and below are actually stress risers. So just a thought.
Correct. I agree with that. I agree with that.
All right. Thank you. Thank you so much, Abhijit. Moving ahead, back to our case. At progressively at 8 weeks, the patient post vertebroplasty started developing neurology. We got an MRI done. It showed that the fracture was now moving posteriorly, and it was now encroaching the canal and causing cord compression. The patient clinically had instability and neurology both. So what do we do now? That's the next step. Obviously, surgery is what we have to decide on, because but which kind of surgery? How do we reconstruct? Do we do anterior, posterior? Do we do, you put in cement again, a cage? What about decompression? So discussing all these, I'll be talking on surgical strategies in management of these osteoporotic vertebral fractures. Whenever we are planning, both planning and execution of these surgeries are very important because they are unforgiving. You don't get a second chance. So here you should look for these three things. Think about instability. Does the patient have additional neurological deficit? And what is the kyphosis at the site of fracture? Based on this, if there is if just instability and non-union, you can think about vertebroplasty or mini-open vertebroplasty. However, when there is neurology, you think about surgery. And here we usually do a transpedicular decompression along with stabilization in patients with interbody or intrabody reconstruction. Whenever there's a kyphosis, then we do a pedicle subtraction osteotomy. In fact, this algorithm has already been published by Dr. Abhinene in European Spine Journal. So for this patient, here there's not a lot of kyphosis, but we see that the bony canal is being encroached by the body, and there is instability and neurology both. So how do we plan for this surgery? To plan, we look at two aspects. Does the patient have an intervertebral instability or does he have intravertebral instability? Intravertebral instability is something where the adjacent discs are normal, and the instability is because of a kumel which is developing within the body. So here we could either fill in the cavity with the help of cement, or we could close the cavity. So one surgical option is decompression with vertebroplasty and stabilization. The important deciding factor here is no kyphosis at the site of fracture. Like in this lady who had progressive neurology with instability, we did something what Dr. Pawar had just shown. We ended up augmenting or filling up the gap with the help of cement, and then stabilized one above, one below with the help of screws, augmented that with cement, and did a good decompression, and patient had very good results. Another option is decompression along with pedicle subtraction osteotomy and closing at the site of fracture. So the important deciding factor here is that the patient had kyphosis at the site of fracture. Like in this case, there is a kumel there, and on an X-ray you can see that there's a significant kyphosis at the fracture site. The canal is being encroached upon. So here what we do is we stabilized it above and below, and from posteriorly we did a pedicle subtraction osteotomy and closed the fracture over the rod. This is a similar case where we closed the fracture over a Hartschild rectangle. Next is patients with intervertebral instability. Now these are patients where the instability is at the discovertebral junction. So here you need a rigid anterior structural support to take care of the instability. What we usually do is reconstruct the anterior column either by a strut bone graft or a mesh cage along with posterior instrumentation. So the cage is usually inserted from posterior only. But of course, if someone is not comfortable, you can do an anterior posterior approach as well. Like in this patient where there is a significant bone loss along with affection of the disc as well. And when we were decompressing this patient, because the patient had a bony chunk which had gone behind and was causing neurodeficit, you can see how unstable the fracture is. From the back, after stabilizing and putting a working rod on other side, we decompressed the canal till the rod, till the cord was completely free, and eventually inserted a mesh cage from the back, getting this result. So this is what we do in such patients. This is another similar patient with a intervertebral instability where it was taken care of with a mesh cage, anterior reconstruction and posterior stabilization. However, the things are not completely rosy. You have to be very, very careful because in spite of using all the techniques, right, you can have such problems where the cages have migrated. So there's definitely a steep learning curve in operating patients with osteoporotic vertebral fracture. So back to our case, what we did in this patient was we put in cement in the front and we put rods, screws and rods above and below. We had good early neurological recovery, but at 4 months, the problem started. The implant started walking out, and progressively it was disheartening to see this in spite of doing everything by the book. And at 4 months, the patient started having severe radiculopathy because of inferior cutout of the screw. What next now? We have done everything. What are we really missing here? Was it the implant selection? Because everything else was taken care of. So surgery in osteoporotic spine actually keeps throwing us challenges one after the another. I'll invite Dr. Agnivesh Tiku here to give us a little bit of idea on what are the best implants that we can select in patients with osteoporotic fracture. Agnivesh, if you could take over.
Thank you, Priyank. Thank you very much. I'll start sharing my screen. Yeah.
In the meantime, after Dr. Agnivesh's talk, we can have a combined discussion on all the surgical aspects. Since this is the last talk of the day, I encourage all our delegates to put in their questions in the chat box, which we would happily discuss after this talk. Yes, Agnivesh.
Is my slide visible?
Yes.
Okay. So I'm going to speak on how to decide about the implants in the spine. What are the pros and cons on how you put the implants and what selection of implants you do. Let's try to understand first thing that osteoporosis is a different situation. It's a different scenario. And because the bones are weak, you have to put more screws to get the same amount of hold, which in an adult in a fracture you may get by a single level up and down. You have to medialize more because that gives better purchase and better pull-out strength. There are hydroxyapatite coated screws which are available in the market. You can augment the normal screws or you can use cement augmented screws. You can aim for a bicortical purchase within the safety limits, or you can use hooks or sublaminar wiring to improve the purchase. So let's see what effect does the design of the screws have. The contact of the screws with bone is more important. The diameter or the circumference of a 5 mm screw is much less than a 6 mm screw. So that is why you try to put the larger diameter screw, which you can safely put. If you can put 6.5 mm screws, please put 6.5. Aim for that and don't aim for a thinner diameter screw. Many of the companies which we see normally, they have conical screws. Now, conical screws are the one which are tapered in front and they are broader behind. When you are putting those screws, you get a very nice feel. When you tighten those screws, you get a very nice feel ki acha mast tight ho gaya. But the problem is it's a cone. The moment it sort of toggles or becomes loose, that cone will come out completely. It's like a cork in the bottle. So once the cork slightly becomes loose, it will come out very easily. Let's try to have a look at the scenario. How does the insertion depth of a screw matter? Now, normally we aim the screw at the 1/3 and 2/3 junction of the body. If you consider that 100%, then if you are using a screw which is 50% of the length, you get a pull-out strength of 75%, because whatever you do, the best part of purchase is in your pedicle till the neurocentric joint. After that, the purchase is less, but yes, it does increase. And if you put it at 100%, which means touching the other cortex, you get 124 to 154% of the pull-out strength of a screw, which is 80% of the length. And as I said, the neurocentric joint in thoracic spine is what you should aim for crossing. Anyways, it's a very short screw, so it doesn't matter. Now, in dorsal spine, you can choose two trajectories. You can go the anatomical variant where you go with line of the pedicle, or you can do a surgical variant or a straighter screw, which is parallel to the upper end plate. Now, this screw, which is parallel to the upper end plate, has got a better purchase or a better pull-out strength of 27% than the anatomical variant. So 1 mm under tapping is what you usually do, but in osteoporotic spine, you can even put untapped or even a smaller tap because the bones are very soft, the screws go very easily. So, and in an osteoporotic spine, cement injection also increases the strength. Now, the other thing is that if you medialize the screws, the effect again is significant because once you are medializing, you are engaging a triangular cortex of the bone, triangular bone. Once you pull out, you have to take away the whole triangle with it for the screw to come out. But if it's a straighter screw, all the screw is dependent on is the bone around the threads. So try to medialize the screw. It helps to get better purchase. Now, what happens if you sort of loosen a screw or you are doubtful about the screw? If you take out the screw and put the same screw again, the sort of strength reduces by 34%. So it is not a wise thing to do. So what to do? That if you sort of burst a pedicle or if you sort of your screw is not loose, consider a larger screw if the pedicle walls are intact and you can safely accommodate a larger screw. You can consider a different trajectory because if you're putting the same surgical screw, it is better to put an anatomical screw in that vertebra because it will have still better purchase. You can augment that hole and then sort of insert the screw, or if it is beyond salvage, you can consider putting a wire or a hook instead of that screw. Now, let's see if you have a screw which is 6 mm and you have messed up that screw. So what you can do is if you sort of take out that 6 mm screw and put a 7 mm, not take out, if you use a 7 mm screw instead of 6 mm screw, you get 73% better purchase. And if you use a 7 mm screw with a cement augmentation as compared to a 6 mm screw, you get 384% better purchase or a better pull-out strength than a shorter screw. And as a general rule, if you have an option of going 2 mm higher, then an 8 mm screw is much better than a 6 mm screw with a cement augmentation. But in our Indian population, 8 mm is something which is overzealous. I don't think most of the patients will not accommodate these screws. Coming to the cement augmentation, so you can augment the cement. This is a 69-year-old female with multiple fractures, consecutive up and down. And these are the cement augmented screws which were used. So these are the screws which were upper ones are the fenestrated screws and the lower ones are the augmented, means we have done a vertebroplasty and then put the screws over here. And it tends to hold on quite nicely. A cage plasty, which I have learned from our mentor, Dr. Samir Delvi sir. And it is a central vertebral body lesion and your end plates are intact, but there is a pincer type of a fracture and you are not comfortable putting cement over there. You can insert a cage within the body to take care of the intravertebral instability, and this sort of gives the structural support to the anterior column. And this is a 1-year follow-up of the patient. It has sort of collapsed a bit, but eventually it has healed very well. You can use dual thread screws because cortical screws, more diameter, they tend to get better purchase. So again, an 87-year-old female, you can sort of do dual core screws, dual thread screws, and get a better purchase with this. One of the problems with fenestrated screws is that you cannot go too long because you don't know, because there's a fenestration at the tip of the screw. Nowadays, it also has been taken care of, but you don't know that whether if you are perforating, whether it will cause a cement leakage or not. If the instability is interbody, it's not intravertebral, it's intervertebral, then something you have to do is an intervertebral reconstruction. You have to put in a cage in the anterior column between the vertebral body and the upper end plate to sort of let it heal. And eventually when the screws don't work, then there are a lot of hooks, wires and all that which can help. And there was a study which was done where it shows that in a normal spine, the pedicle screws are better because they get a 3-column hold. And you can see the strength of a pedicle screw is much more than a claw, or it is much more than a transverse claw. But this is true for a normal spine. In osteoporotic spine, the whole thing changes. So the axial pull-out strength is not better when the BMD falls below a particular level. And it has been recommended that you should not be putting the screws in the very osteoporotic spine. There was an very old study wherein this Jikai osteoporotic grading scale was used. It's an X-ray based study. We don't use it anymore. But when you have a severe grade 3 osteoporosis, no matter whatever implant you put gives poor fixation. So it was not recommended. And another study which sort of proved that if your absolute value of BMD is less than 300 milligrams per centimeter square or 0.3 grams per centimeter square, it is not recommended to do pedicle screw fixation. So this patient with a progressive sort of paralysis, you operate, fix it. The screw's trajectory is anyways not looking good, but this is what happens over a period of time. And when this construct or the building fails, the ultimate rescuer which comes to your sort of rescue is the heart shield. So then you only option left with you is this heart shield, because that is the ultimate savior. It gets purchased in the lamina, which is a better bone, and it is more forgiving. It allows vertical collapse and translation, and it allows a bit different from regional. Also, another article which was published in 2006 try to compare 3 different types of sublaminar implants, which are wire, tapes, and
national societies will probably be more
in titanium. And 2 things were studied: laminar cut through sort of resistance and the stiffness of construct. Now, stiffness of construct did not change as per the group, but they felt that tape and braided cable were slightly better than wires. But obviously, you cannot construct the whole sort of construct with tape, and you have to use wires.
How many we have in the bank, and
but
how many
again, because they have a wider sort of, they are broader, they have better sort of cutout strength as compared to a single wire.
How many big conferences?
To conclude, I would like to say that understand the instability pattern and plan your treatment accordingly. Keep multiple options available, and customized approach towards each fracture or each case or each patient is what is needed. And don't shy away from sublaminar wiring. Old is gold, and it is your ultimate rescuer. And most important, do not miss on treating osteoporosis. Thank you very much.
His meetings.
Nimesh, what is cage plasty?
So this was a term which was coined by Dr. Samir Jalvi sir when we were with him. So it is basically an insertion of the vertebral, intervertebral cage within the 2 vertebral body, and he has been doing this procedure since 2006 or 2007. We had the follow-up of all of this. So
Members,
that's why I've used the same word
we are not
over here.
Great. Thank you, Agnivesh. It was an excellent talk. We have now been allotted only 10 minutes for our final concluding discussion. If any of our panelists have any questions, please put forth. I saw Ram sir asking something. Ram sir, if you may.
My only contention here is that we tend to look at all these patients mainly as surgeons, but here the biology actually dictates the success or the failure of our
Thank
surgery.
you very much,
And we have
William,
to
for
be
that.
very, very aggressive as far as medical management is concerned, as far as patient selection is concerned. And I strongly believe that less is more. I mean, Abhay, who probably has the largest contribution to vertebroplasty from our country, if he's moving away from vertebroplasty, it's as dramatic as Dr. Khanna moving away from PLIF many years back. So I think we need to give it a second thought as to whether cement augmentation is boon or bane. And yes, maybe it will still stay, but in limited indications, in areas where you're just adding a little bit, you may be combining your posterior shortening to a little bit. So we'll actually extend that cage plasty to a small cementoplasty, where we shorten it and can't put the smallest cage. So it's going to be a combination of all that we have learned.
4 years.
But I think we are going in the right direction, and if we can medically move things better, we have a better future for the elderly, especially when a few of us need these procedures on us. So that's what I'm looking at.
Thank you so much, sir.
Of getting no money. Please use teriparatide as much as you can. I may sound like a company representative, but trust me that it's going to bail you out of a lot of tight spots.
What do you say about denosumab? I mean, some patients just want one injection.
Not on the same page at all. It's a poor second. It's a bone anti-resorptive. Remember, it's not a bone-forming agent. So there's just no comparison.
Okay. Mm-hmm.
Anybody has any experience about the biologic cement, calcium phosphate cement instead of the, PMMA? Anybody has any experience or any knowledge?
Yeah, the Meditronics has the hydroxyapatite cement.
Okay.
So I use that frequently for all my vertebroplasties.
Is biologic?
Say it again, sir.
I'm just addressing this. I'm just saying that the funda of vertebroplasty is that you have expected this bone not to heal. So you put in cement to block it. And when you put in the biological cement, you're expecting the bone to traverse across. This is not good. This is not a live bone you're putting in. So you're putting in, that kind of challenges. But basically, when you put this and probably you give teriparatide, it may work. I don't know, Abhijit, what's been your experience? Because I always worry that by the time the bone heals, the guy will be dead or it would have fractured again.
No, I personally feel that the hydroxyapatite cement has been working well. So I tend to use that. I mean, I don't have any research to...
But standalone or with fixation?
No, even standalone. If I do standalone vertebroplasty, I use the HA cement, yeah.
Actually, Abhay, there was a device which did not stand the test of time because it got withdrawn, both for the interbody and for the intra-body work, which came from Israel, which was that B-twin device, if you remember. It was an expandable cage. They had a similar device which could go transpedicular. Hear me what I'm saying. It went transpedicular, very similar to the plasty, Dalvi plasty.
Actually defined as cage plasty. In Thailand, exactly. That Bompura set had defined that, coined that term cage plasty, when you used to put that mesh that would expand.
Exactly. It used to be a 5 mm tube which used to go in. It used to open out and then you could push cement. That cement actually percolates into the trabeculae. Unlike what we are doing, where we are doing what Ketan says, that we create a soft ball a ball in there, which is actually not healing and is actually a stress riser around which bone collapses. This used to actually get into that bone, and a little bit of cement used to be injected through that area. So which was there for a long time, unfortunately got withdrawn. Maybe it will come back someday, will give us some in between or a mid path. I'm very hopeful it will.
Raghu, any tips from your experience?
No, I think more and more I would agree I think we have to look at biology. I think we'll go back to what Dr. Ramchandra said. I think any amount of surgery is probably a stopover till the medical disease looks out. Let's just treat it like COX. I think it's like TB. The point is osteoporosis is no different from TB. I think you have to look at biology. One point, I think, extension to Abhay, and I think I learned it from him. We always should look at bone like a tank, and so there are two ways that you put water into a tank a tank full of water, and you get water out. All except teriparatide acts at the outlet, which means where the water is going to leak out. The only thing that acts in increasing the water in the tank is teriparatide. And therefore, I think it has a role. Cost concerns are a part of an Indian scenario, but I think we should not shy away from offering it to them. With time, I've become more aggressive with it, and I use it far more. It saved me in many, many situations, if I can remember.
One more comment I want to make is that a lot of these fractures, we call them compression fractures, but they're actually burst fractures, where the posterior cortex is damaged. So at the outset, at the first X-ray, if we can identify this either on X-ray or on suspicion an MRI or a CT, that would, completely help us in guiding the management, because they're going to be more unstable than the compression fractures. And they are not the one, where an eventual failure of union would lead to vertebroplasty. These are the ones that would require stabilization. So at the outset, I think one should define whether it's a pure wedge compression or is it the burst type fracture.
I love your answer, and I in fact strongly suggest, if we are doing intervention, which means that we are doing anything from just a cement augmentation to a complete stabilization, we should insist on a localized CT of that area, vertebra above, vertebra below. And believe me, if you're doing an MR, adding a localized CT is not actually adding much to the bill of the patient any which way. But that localized CT can give us a lot of clues. Even a situation like what Raghu said, where an infection, well, let's be very frank, an infection would probably be better picked up on a CT at times, which may not be picked up with just an MRI, where you went wrong and where you thought that this was. So it's just a thought. But these are things where we should combine both MR and CT if you're doing an invasive procedure. It will help us, the way Ketan said, if there's a posterior leakage, we can predict it. If there's going to be an intradiscal leakage, we can sort of predict it. If there's going to be going something in front, we'll avoid it. So these are all things which we can work on. And I think it's worth the effort doing better imaging before we put our sort of needle into that vertebra.
Thank you so much, sir. In interest of time, I would like to conclude today's session. But before going, I would sincerely thank all of our panelists for having taken time out from their busy schedule for today's workshop. Before going, a couple of take-homes. Cases which present to you with osteoporotic fracture. Remember, everyone has reiterated to you guys that you have a fracture, but you have osteoporosis that you need to deal with. Presence of an insufficiency fracture puts osteoporosis in the severe grade, overruling any kind of investigation. Teriparatide is the treatment for osteoporosis. All others are time-buying options. When to initiate medical treatment for osteoporosis? It's yesterday. The sooner the better. Ideally, you start at pre-op, but if not, do it immediately post-op. Whenever you have a patient where you're going to operate, judge the instability early. Go ahead, fix long. Consider extraosseous fixations like sublaminar wires in high-risk patients. Remember, untreated osteoporosis can ruin good clinical results. Thank you everyone for having attended our workshop. Before go, all of our academic sponsors and to Vama Events for having made this possible. Also, I would invite you all for the conference next weekend, which is going to be a power-packed show with national and international delegates. And of course, a big thank you to Dr. Uday Pawar and Dr. Vishal Kunnani, and of course, Dr. Srivastav sir, for having presided over this wonderful conference. Having said this, I would end today's last workshop of the day. It's been a busy day. I think everybody now deserves to go and have a beer. Thank you, everyone.
So thank you, Dr. Patel. Thank you, all the moderators and all the panelists of the day. I think we conclude this long day, but I guess a fruitful one for all the delegates. I thank all the delegates who have been patiently listening to all this pre-conference workshop. I thank the OrthoTV guys, Dr. Ashok Sham, Dr. Neeraj Bijlani, the Vama guys who have been the technical team. And we look forward to host you next weekend, Saturday and Sunday. Please do join us then. And please enjoy the academic feast that we have for you. Stay safe, guys. I think we'll sign off for the day. Thanks all.